Good afternoon, everyone. We'll start with a small prayer and lamp lighting. Shashank. Professor George Joseph, Dr. Anil Bhan, Dr. Kamal Pathak, please come. Dr. Anil Bhan, please come. Pradeep.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं मारकोटि प्रकाशं शान्तं महाकाव्यनाटकादिप्रियम् महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महागणपतिं मनसा स्मरामि
So once again, welcome to Hyderabad and thank you all for joining us. This is a slightly different format of meeting where we have very few talks, but a lot of discussion. And if this goes well, I think we will have more such meetings in future. So we are really looking forward to all the deliberations and inputs from all the faculty who are here. So without wasting any more time, we'll get started. First talk by Dr. Anil Bhan, Type A Aortic Dissection, the lessons learned. And then we'll have 2 sessions of discussions on Type A dissection.
Thank you, Dr. Gupta, for inviting me. And it's a pleasure to be here after a long time. And something very interesting, which I'm going to talk about, the type A dissection, which we encounter in our practice on a regular basis. We see a variety of acute aortic syndromes as aortic dissection, intramural hematomas, penetrating ulcers, but the most malignant one is the aortic dissection, which basically is sharing off of the layers of the aorta, blood going into the wall, and a high risk of variety of complications. If we look at this disease, it's a disease which has a potential uh, cause of death, and the death is very imminent if not treated. A very high rate of mortality, 1 to 2% every hour in the first 48 hours. So quite a few patients are dead in the first month. A very selected group of patients who will survive and reach beyond 1 month. And the major complications are the malperfusion syndromes of the various vital organs. So time is very precious. It's very important to do a timely intervention. And the moment a patient comes to us and a diagnosis of type A dissection is made, the attempt is to take them to the operating room as soon as possible. Of course, there are certain contraindications which we can talk about in our discussion. There are certain situations where one would like to avoid operating on these patients. Well, the content of this presentation is basically trends in aortic dissection over the past 3 decades and comparing to our own experience, the challenges faced during the journey and how we evolved, and newer techniques, newer problems, and the dissection being a dynamic disease. Well, this is my entire experience, 32 years of aortic surgery, and this includes about 554 dissections, both type A and type B, and also of late, recently in this subgroup of patients, we started doing frozen trunk procedures, and I've done 33 frozen trunks, I think in the last 3.5 years. Well, if you look at the results, our own operative mortality has been 2.2%. Neurological dysfunction has been quite low, and re-expression also been quite low. But if you look at the IRAD data, the mortality has been almost 25%. So we need to see how we can reduce the mortality of the disease. And enhanced knowledge and skills are very important. The strength is in knowledge and skills, of course, by diagnosing early, timely diagnosis, timely referral to the right place, and timely intervention. Of course, adopting the newer technologies, the hybrid procedures will certainly improve the outcomes. Malperfusions are the main problem and the main killers of the disease. And the essential natural history of the disease is dependent on the behavior of the flap which runs through the aorta as to how it's going to behave. So we'll talk about the major issues, aortic regurgitation, which is one of the serious problems associated with this. And it happens because of the avulsion of the commissure from the aorta, leading to acute aortic regurgitation, and which is a very serious problem. And these patients are very sick once they develop severe aortic regurgitation. And in addition to this, coronary ischemia, which is, do you have a pointer? Can you give me a pointer? Which involves the coronaries, and most often is the right coronary which is involved. And the events could be a frank myocardial infarction. As we have seen sometimes on the operating table, the right ventricle looks very ghastly, absolutely black, and sometimes inability to come off pump, which can also be a very serious problem, and death due to massive myocardial infarction. And mortality of this subset is almost 20 to 33%. Well, this is how the right coronary artery or any of the coronaries could get involved. The dissection only into the ostium, flap entering the coronary, as in this case, and a complete avulsion of the coronary from its wall. Well, these are some of the operative pictures. This is the injury of the coronary close to the ostium, which we managed to get away by a local repair. And these are two subsets where repair did not work because the right coronary was completely avulsed from the ostium. And here again, the same picture. And in this subset, the best option is to put a bypass graft in addition to doing the aortic repair. Well, the other problem would be the cerebral malperfusion, seen in about 3 to 13% of the patients, and most often it's the right carotid artery because the spiral behavior of the flap is such that most often it enters the right carotid artery. However, it could enter any of the arch vessels, and it could present as a transient neurological dysfunction or as a frank coma, which we see so many times in these patients. And this, let me point out, has been one of the contraindications if they have frank coma or severe neurological deficit for any surgical intervention. These are CT showing the dissection flap going into all the three arch vessels. But let me also tell you that presence of dissection flap in the three arch vessels is not a contraindication to surgery. The CT scan showing a dry infarct, again, if neurologically patient is in an acceptable situation, then we take them up for surgery as soon as possible. Well, limb ischemia is a serious problem and 10 to 12% incidence, and a significant lower limb involvement signifies a massive dissection. And these patients have to be treated as fast as possible because left alone for some time, the mortality is almost 70%. And this subset of patients, if possible to delay the central repair, it might be feasible to do some kind of revascularization of the lower limb by either a T-bar or some fenestration to ensure the limb flow is improving. Well, this is a prescription of a doctor who was sent, the patient was sent to us by a doctor who had absent lower limb pulses and diagnosed as aortoarteritis, whereas he had a type A dissection. Our protocol is check the peripheral pulses first and check if there's any loss of sensory motor function. And if that is so, then we actively get a CT done and look at the images of the CT. And that gives us an insight into what's the kind of vascular involvement. And if the vascular involvement is severe, then I think if patient is stable, until there's a tamponade, in that setting, central repair becomes paramount. Otherwise, fix up the lower limb, improve the lower limb blood flow, and then only take up for the central repair. The surgical strategies are if the patient comes early, as soon as possible, within a few hours, we generally try to do a central repair first and then look at the peripheral pulses after the surgery and then accordingly take a call on this. I'll tell you a very important case who came to us with type A dissection and only one peripheral pulse, that was the right radial artery, was palpable. Nothing else was palpable. And we took him up for surgery immediately because he came in a few hours' time. And after we returned from the operating room, all the pulses were palpable. We didn't do anything else. So it's just modifying the flow of the blood flow through the aorta. And in certain situations, it's happened in a number of cases. In fact, one of them was an anesthetist working in a hospital in Delhi, where we found after repair, we did not get the required pulse. So we did an exurobiofem at the same time. This is the post-op CT image of the same. The worst thing is to have a mesenteric ischemia, which can be one of the drastic complications of acute dissections. But fortunately, the severe form only in 2.5% of the patients. And again, in this setting, if patient is stable, as I have written here, until there's a cardiac tamponade, the first priority is to ensure blood flow into the gut. And for that, the role of an interventional cardiologist or a vascular surgeon is very important. And we have been doing it regularly now, that before taking them for central repair, we get it fixed up by the vascular surgeon. And we tell the family, of course, priority is to fix up the aorta, but unfortunately, the setting is such where we need to fix up the gut or the limbs first before we take them for a central repair. And that we could lose the patient in between. A CT image showing the flap going into the superior mesenteric artery. And the malperfusion management, as I said, and I highlight again, is to delay the proximal aortic repair until after differential treatment for the mesenteric malperfusion is taken care of. The various modalities, how it could be done, have been talked about. Renal malperfusion is another problem, and the spiral of the flap is such. Most often, the left renal artery comes out from the false lumen, and the right comes from the true lumen. Well, it could be vice versa. It could be both the renal arteries coming from the false lumen. There's no hard and fast rule about it, but generally, this is the behavior. And this is not a contraindication whatsoever for surgery. I can tell you, I've had so many patients who were in frank renal shutdown, severe metabolic acidosis, on dialysis, taken to operating room, came back within 4 to 6 weeks, their kidneys recovered. It's a good subset to deal them as soon as possible. So the sequence is hydrate them, get a CT angio done, check the renal infarct on the CT. If yes, involve the nephrology team, keep low threshold for dialysis, avoid nephrotoxic drugs, and restrict the intake, proper intake output monitoring, and primary aortic repair is the first line of treatment in this subset of patients. Well, of course, a serious problem of rupture, as you can see here, the worst thing that can happen to any patient. And most of the time I say we cannot do anything. The patient will die in front of us and we just cannot do it because there's a patient who goes for a CT. We are in the CT room. He coughs and he crashes. So this we have seen a number of times. And I think that's the saddest part of the whole story, that we can fix them up, but the situation is such we can't do it. Well, this is a flap in the aorta. This is a hemopericardium, and most common cause of death being this. Well, these are some operative pictures of a patient where we open the pericardium and blood jetting out, and another patient, the hemopericardium, when we open up the pericardium. The aim of the surgery is to prevent the rupture, prevent the exsanguination of these patients, correct the aortic regurgitation, restoration of the coronary blood flow, and restoration of the blood flow to the other important vessels. The key to success is rapid surgery. The second part of this problem is how much to resect, because that's always a debated topic, from where to where. So that's very important. But in our own setting, most of the time, let me admit that we do a complete root replacement in most of the patients, because our patients will not like to go for a redo procedure. And I'll show some pictures where we had to go back and redo the whole aorta within a 1.5 years time, because we try to avoid doing the root. Well, AR due to the involvement of the valve itself, the pathological dilatation of the aortic root, and when the dissection is going into the aortic root and the root looks bad, in that setting, the entire root replacement is the best option for these patients. The options could be a mechanical Bentall or a biobentall procedure or a porcine root. Well, that's the surgeon's choice. A lot of data being published now on the valve sparing procedures. But let me tell you, even Tyrone David's own series, only 15% of the patients with acute dissection were dealt with this modality, because these patients are very sick and you don't want to have any residual AR and all that at the end of the procedure, and you have to go back and refix it. It's very difficult. Regarding the ascending aorta, most of the tears, 60 to 64% of the tears in type A dissection are either in the ascending aorta or in the proximal arch. So if we deal with the ascending aorta, that will take care of around 60 to 65% of the tears, but there's still 35% who are beyond this territory. And that we'll talk about briefly how to go about it. So options are limited to ascending aorta, a hemiarch, or extended arch, depending on if the arch is low, the tear is lower down, and we want to cover up that part of the aorta. The problem with the distal part is we want to fix up as much of the aorta as possible. We want to cover up the distal intimal tear also, so that we can cover up that area and prevent the progression of the false lumen, and also avoid a resurgery on these patients. Well, at the same time, we have to also understand this is a sicker group of patients. So we have to be very careful in choosing patients where we extend our surgery beyond the proximal arch. And also, when we are talking about these modalities, we are trying to remodel the aorta to ensure that we are dealing with a situation later on where the longevity of life is much better. Well, how do we do it? Either we do a ascending aorta and a total arch, ascending aorta and a frozen trunk, ascending aorta with a separate T-bar graft in the descending thoracic aorta, and the total aorta with warm stent graft, which is deployed after the cardiopulmonary bypass is over. As we know that the main concern in these patients is the malperfusion of the organs. If there's no malperfusion, the mortality is 12.6%, and if there are three malperfusions, the mortality jumps to 43.4%. So we have to ensure that as little malperfusion as possible. Well, as I said, extending the surgical procedure beyond the arch has its own fair share of complications, and nothing is free that applies to type A dissection. More extensive operation will increase the operative risk, and additional procedures like valve intervention, CABG, also add to the risk of the surgery. At the same time, as I said, just because there are intimal tears or flaps going through the arch vessels, it does not call for any arch replacement. As long as the brain perfusion is all right, we don't have to worry about it. Well, there is supposed to be a greater mortality in acute dissection setting with a total arch replacement, but there's data also, which says the mortality is almost the same. Well, it depends on the operating surgeon whether he's willing to take the chance or not. Well, the recommendations are aortic valve resuspension is recommended for most of the patients with type aortic dissection, if possible, if the root is suitable for that, if the valve is tricuspid and the root is not completely damaged. Aortic root replacement is recommended in type A dissections with root aneurysm or primary anti-tear in the root. Aortic root replacement is reasonable in patients with type A dissection with Marfan's and other connective tissue disorders, and a valve-sparing aortic root replacement may be reasonable in selected number of patients with type A dissection. And when do we intervene for the arch? If the arch is more than 5 centimeters, or there's a tear in the arch, or there's what's called a ruptured arch. So that is a setting. But let me tell you that doing this procedure is not an easy job. Doing a type A dissection, arch replacement. Well, this is a patient, a post-op patient who had a type A dissection that complete ventral plus arch was done. But at the same time, one has to be very careful in choosing the right patient for this kind of procedure. So these are disappointments also. This is a patient where I had done a supracoronary ascending aorta replacement and a hemiarch, and he came back within 1 year with a huge aneurysm of the root. At that time, root was absolutely fine. So we have to be very careful in selecting the modality and the surgical option for these patients. Certain special situations which I would like to talk about. The intramural hematomas, which again is a debated topic. Some people feel that we could leave them alone, but that's not always true because some of these patients can behave exactly like a dissection and almost 16 to 47%. In fact, when you're taking out this clot from the wall of the aorta, you can actually see the aorta is dissected. So this is expected and natural for this aorta to misbehave at some point of time. So our own feeling is that all patients with type A intramural hematoma should be operated and treated like a type A dissection. However, most of the time what we have seen, their aortic valves are normal. So we can get away with the supracoronary replacement of aorta and the hemiarch procedure. In fact, I was telling Prashant in the night, I was doing one type A intramural hematoma. This guy was flying captain for Air Force. So, well, this is, as I said, some centers, they still feel if the aorta is less than 50 millimeters and the thickness of the IMH is not too much, in that case, we could just leave them alone and manage them medically. But I think to be on the safer side, as I said, some of them get converted into type A dissection over a period of time and have sudden death, 25% mortality at 1 year. I don't think we should take that chance. The important thing, technical details, is the quality of tissue is worse in type A intramural hematoma. So one has to be very careful in sewing up this aorta. Both proximal and distal ends to be adequately reinforced with felt pieces. Well, this is type A intramural hematoma with a leak inside the hematoma, and another patient with a type B intramural hematoma with a penetrating ulcer, best treated by an endovascular device. This is a very interesting patient I want to share with you. This patient came to us with hemopericardium and hemodynamically unstable. And one of our cardiologists said, get a CT done. We got the CT done. CT was absolutely fine. There was nothing wrong. But he insisted that we should open up and see. When we opened up, we found a penetrating ulcer which had ruptured into the pericardium. On a CT scan, it looked absolutely normal. So some of the iatrogenic issues which I want to talk to you about. One is the post PCI interventions. where there can be dissection. And I have had opportunity to operate on many of these patients who had a PCI and had a dissection of the aorta within a variable period of time. The post-TAVI is another subgroup where we have to be prepared now to deal with this situation because the TAVI numbers are going up. Similarly, post-TVAR, I'll show you one representative case of this, and post-CABG. First, I'll talk about the post-CABG dissections because now our cardiovascular scenario is such that most of the patients are operated off pump, and therefore the chances of injuring the intima are high. And however, now off late, as per the recommendations in our own center, also I'm seeing that people are bringing down the pressures to 60 and 70 and then only putting a side biting clamp on the aorta for doing the proximal anastomosis. Well, this is a lady who had a bypass done. As you can see, all the grafts are patent. This is the X-ray, a huge aneurysm she has developed, and all the grafts patent. This is another CT view of the same patient. And you can see this internal mammary, which was patent, and the type A dissection here. And as I said, most of these patients also, their aortic valves are normal. I've done about 12 or 13 of these post-CABG dissections now, and this is the this is the CT again, patent internal mammary, intra picture, huge aneurysm of the ascending aorta, the false lumen are dilated. This is the one of the grafts which we harvested and put a graft in the ascending aorta up to the proximal arch, and this is a reimplanted graft. Because the other graft was the internal mammary was patent anyway, post-op CT of the same patient. And another problem with this patient where we tried, I think Subbu was here. I saw him just now. He was involved with this case. And this Rahul had done, he had come from Mumbai to do it for us. And unfortunately, when he landed up in the ICU, we found the upper limb pulses had all gone. So I called up, Rahul was just boarding the flight because he used to come and help us. And we found that there was a big retrograde dissection from one of the spikes of this device. And this is the intra picture. Then this is the device, as you can see, the transection of the aorta at the level of the isthmus, just beyond the isthmus, sorry. And this is the final picture. And this is the post-op image where we had done a crossover carotid initially itself for doing this device as a part of the hybrid procedure. And then we had to take off the innominate artery and implant it separately onto the main graft. Well, the bypass strategy is by and large standard now. We cool down most of these type A dissections to 30 degrees unless we are doing an arch along with it, in which case we go down to 25 degrees. And at 30 degrees, we feel pretty comfortable to go through the hypothermic perfusion. We are perfusing the brain and not the rest of the body. Only towards the later part, we use the side graft of the arch graft for perfusing the lower part of the body to ensure that we don't leave the lower part of the body ischemic for a long time. We do axillary cannulation all the patients except the ones where there's a dissection going into the axillary artery or there's an aberrant right subclavian artery, which is not going to help us because in that case we have to go a femoral cannulation and do circulatory arrest or otherwise carotid cannulation. But we are scared because if there's a dissection flap going into carotid, we cannot do it. And monitor NIRS in all these patients. And one more thing which is important is that whether it should be a bilateral or a single unilateral cerebral perfusion, the data is very controversial, but we do only unilateral. And I will give you a very interesting idea which we started doing for last 3-4 years. When we are perfusing the right carotid through the axillary artery, we clamp the left carotid just above the aorta. And we've seen dramatic changes in the NIRS values. Suppose the NIRS value before clamping the carotid was 25, 30, we would target 40 or more. It immediately comes up because the blood doesn't steal from the cerebral circulation. Even if 25% of the patients have an inadequate center of circle of Willis, even then it helps us in avoiding the cannulation of the other carotid, which most often is dissected, and we don't want to make it worse. Well, bleeding is a problem always. And as we know, we have to be mentally prepared with what all we can do for these patients to avoid bleeding, which is exsanguinating the patient. And over a period of time, as you keep doing, you learn how to deal with the bleeding part. In fact, the patient I was talking about, we did yesterday night, he had taken clopidogrel and aspirin till day 4 yesterday night when he came to us. And there was a lot of bleeding, but with all these blood products And we started using fibrinogen in very sick patients recently, manufactured by this Reliance group, and it's given us very good results. At the end of the procedure, we find very good clots forming in the pericardium. So the brain protection is a very important aspect. So we started off with deep hypothermic circulatory arrest when we started this program at All India Institute. Then gradually we have now switched over to antegrade perfusion. And when we were doing the deep hypothermic circulatory arrest, we used the retrograde cerebral perfusion into the superior vena cava. I'll show you a nice picture which I recovered from a previous slide. This is a patient where we are doing a type A dissection, and this is a distal cup being made. As you can see, this is the cannula into the SVC from where we perfuse the brain. And this is the bright blood, as you can see here, going into the brain. And we also modified the circuit and we made it very simple as per the recommendations of Professor Imra, one of the genius in the department. He only suggested to me, why don't you do it this way? So we started doing that way. And with that, I think I don't know how many hundreds of patients we did with retrograde cerebral perfusion only. But in 2012, I think we switched over to the antegrade cerebral perfusion, the axillary artery exposed. And those days we used to get this prefabricated axillary artery cannula from the Edward people, but now it's not manufactured. So we use a regular aortic cannula, which we use for any other patient, just flat. And one has to be very careful in dealing with the axillary artery. It's a very, very fragile artery and much more prone to dissection and injury than any other artery in the body. So one has to be very careful, and very important point which I want to share with you. This is the cerebral perfusion through the two carotid arteries separately. As I said, I'm a little scared to do it with these cannulas. They might damage the intima further and therefore make the situation worse. And NRS, as I said, monitored in all the patients. And the only limitation, it gives a very good idea about the cerebral brain circulation, but the only limitation being that it only scans the frontal lobe oxygenation. It does not scan the rest of the brain. And IRD has definitely worked on this and has given us a lot of information and teaching as to how to deal with these patients. And we are one of the very only center from the country to be part of the IRAD. And it's also very important, like whatever data is available, if you're doing less than three, it's a very important message I want to pass on. If you're doing only less than three dissections in a year, the mortality is 27.4%. But if you're doing more than 13 per year, the mortality is 16.4%. So these patients, as you keep doing, the results are going to get better and better. And therefore, to reach a 2.9% mortality, as in our case, it took some time. It takes time to learn all these things because dealing with this subset of patients is sometimes very, very difficult. So how to manage them post-op? A very important thing is to control your blood pressure. And the essential component of the management of the post-op is to ensure that there's no progression of the disease in the rest of the aorta. So managing their BP is very important, and beta blockers have a very important role to play. Absence of beta blockers was a powerful risk factor for reoperation. So it's very important to ensure the BP is kept under control, and follow-up is very important. I want to share a very interesting case with you. I had done his mental procedure, I think in 2008 or 2009. Then he had abdominal pain. He went to a general surgeon. He was admitted there for 4-5 days. They didn't realize what was happening. And then they got a CT done, which showed a huge abdominal aortic aneurysm with dissection. And you look at this picture. This was the back of this aorta, which was eroding into the vertebral column, and which gave him severe and immense pain. And this was the intra picture. And we had to do his complete thoracoabdominal replacement. These are the Casoli graft that was used for this patient. And similarly, now this we are seeing more often, because initially we thought, as the Yale people said, the reintervention rate for distal aorta is less than 2 to 4%. But I think the numbers are going up. Now the current data says that reintervention rate could be anywhere between 20 to 40%. And we have started seeing these problems more often. This is a patient who had undergone a Bentall for a type A dissection, came with a large arch and the proximal descending thoracic aorta. And for this group of patients, I think Thoraflex or any other frozen elephant trunk gives a very good result. And this is a post-op CT of the same patient. Lot of study going on in the genetics of the aorta. I think this is the future because I'm trying to tie up with a few companies who are working on genetics to look at how we can utilize that technology and data for patients with aortic disease, because unfortunately, there's such a genetic dominance in this disease. The families are always concerned that how do we protect our children from all this? So I'm trying to tie up with this Amma's hospital in Bangalore. I think they're doing some work. I'm trying to talk to them and see how we can look for some biomarkers which can give us an idea as to how the disease is going to behave. The basic information. If you have a CRP which is low, survival chances are better. In a type A dissection, similarly, D-dimer levels are low, so survival chances are better. This is a basic information that we need to capitalize on. So disease is very old. Nothing about has changed. It's we who change as we learn to recognize what was formerly imperceptible. And there is no disease more conducive to clinical humility than the aneurysms of the aorta. There's no single, it's a very important message which I want to pass on. There's no single operation for a patient with type A dissection, but there's a correct operation for each surgeon and the clinical scenario. Thank you very much, Dr. Gupta, for inviting me. And it's always a pleasure. And I was thinking to myself that I feel very honored, privileged that we have become almost a nodal point for the entire North India for the aortic work. And we're doing almost 25 to 30 aortas every month. So I think when I joined Medanta, Dr. Trehan told me our target should be 300 aortas a year. So I told him last week, I think we're almost there. Thank you.
Thank you, sir. I think that has set the ball rolling in a very nice way, covering almost all the aspects of aortic dissection. And I think a lot of what Dr. Bhan has presented will be discussed in the panel discussions. For the first panel, Dr. Girish, Dr. Chandrasekhar, I think he's not here. He'll probably join us for the next one. Dr. Vivek Javali, Prashant, Atanu, come Dr. Saha, Niranjan. So there are certain discussion points that we have put up for each of the panel discussions. So you can follow these points, change the format, do whatever, but we need a good lively discussion and informative discussion on these issues. So the first one is on optimal strategies for type A dissection.
Yeah. So one thing is that I would like to thank Dr. Bhan, who is my teacher, who has come here and given his, I would say, a mammoth experience by any standards in the world. There are certain points which I would like him to highlight. One is during our training as a resident, I think all cardiac surgical training should train residents so that they can do at least basic work, because there is a debate of centralization and regionalization of dissection services. So at least the goal should be to take out the patient alive from the operation theater. That should be the first and primary goal. After that, there are central centers, as we have seen the range and spectrum of complicated cases which he is doing. He can do those complicated revisions only if the patient is alive. So that is a very primary fundamental aim of dissection surgery. The second thing is that he exclusively does axillary artery cannulation. If you find an iatrogenic malperfusion on cardiopulmonary bypass, so what do you do at that time? Yes, sir. Suppose you have started the cardiopulmonary bypass with the right axillary cannulation, and suddenly you know physiologist says that there is no pressure on the lower limb or on the contralateral left radial artery.
So Prashant, and first thing first, that how do we deal with the basic aortic dissection patients?
Sir,
That
please
we-
sit down.
No, it's okay. So the basic thing is that one has to learn the basic operation for the disease. And as you said, we have to send them survival. Yes, a supracoronary ascending outer replacement and resuspension of aortic valve. If you want to get into a messy situation, it's in your own hands. You want to save the patient, I think that's a basic operation. Even today, the guidelines say that do that operation. It's not, you don't have to do a fancy operation.
Yes.
You don't have to do a fashionable operation.
Yes.
You have to do a functional operation. This is what Dr. Carpenter wrote about mitral repairs. Second part was the perfusion issues. We put in an axillary cannula, we check the flow through the axillary cannula to give you a very good idea as to whether you're on the right place or not in the true unit. The moment we connect the arterial line to that cannula, we ask our perfusionist to run some volume flow, maybe 200-300 ml. You see this going freely, there's no problem. And third, but not least important, is to look at the annulus values. If your annulus values on the pump are okay, then you're fine. If you're not, then you need to change your cannulation site. You may have to go to groin. We always keep a groin ready, which might give you a better option, but you should have a pre-op understanding of which femoral arteries connect to the true lumen. Most often, one of them is connected to lumen, one is going to false. So you should know that beforehand so that you are mentally, within 2-3 minutes, you'll make this decision. You come off the pump, open the femoral artery and cannulate it there. There's no problem.
Okay. Then. What do you
Um,
do?
uh,
Do you do change over to central cannulation straight away? True lumen cannulation?
Well, there is some data from Hanover where they cannulate the true lumen, the central aorta. But as you understand, Prashant, the arteries, these aortas are very bad. You put a purse string on them and the whole thing will come out. So to be on the safer side, I think it might be better to go to the femoral artery.
The problems with femoral artery?
So one of the biggest issues is false lumen perfusion, persistent false lumen perfusion. And in fact, it can worsen visceral malperfusion in that case. So I think femoral artery perfusion should be one of our last options if we are not left with any other arteries. As much as possible, true lumen or any of the vessels that are communicating with the true lumen. Of late, I had to cannulate 2 left axillary arteries just to get into the false lumen perfusion and to cool the patient down till I'm able to
Or
open
even
the
bilateral activity?
or bilateral. But if the right axillary is involved or if your innominate artery is involved,
Or even carotid?
you may risk sometimes, when there's dissection in the innominate artery, there's a risk of cerebral malperfusion if you cannulate from the right axillary because the flap can, get kind of closed on to itself and, we may end up into trouble. So in those cases where innominate artery is involved, I'll try to avoid cannulating the right axillary artery. Left axillary artery, most often than not, is kind of spared and it's communicating with the true lumen. So it's only femoral artery cannulation, I think, in my opinion, is last, like if we do not have any other option. And try to cool the patient as rapidly as possible and try to switch to any kind of true lumen perfusion as quickly as possible, which means hemi-arch first or distal first, restore the circulation and then work on the valve or the root.
Prashant, just one comment on this. One of the easiest arteries to expose and cannulate would be the carotid artery.
Carotid, yeah.
So why are people not using that more often?
No, people are using carotid artery, but not often. But it's a very good artery to cannulate and start perfusion.
Prashant, the only problem is if there's a flap going into carotid, that's what I said.
Yes, sir.
Then it's a trouble.
So I think the most important point here is a very meticulous reading of the preoperative CT scan.
Absolutely. Absolutely.
From all the angles, from the tear angle, from the extension angle, from various dimensions angle, as well as malperfusion angle. So the CT scan, when you see the CT scan, we see in a little bit different perspective. We see the proximal malperfusion, whether it is available or not, whether it is there or not, and a distal malperfusion. Proximal malperfusion usually is a dire surgical emergency. Proximal malperfusion means coronary malperfusion and cerebral malperfusion. Distal malperfusion we categorize as Renomesenteric malperfusion and limb malperfusion. The most benign malperfusion, in my opinion, is a renal malperfusion. That is very forgiving. Even if when the kidney is shut down, you don't have to bother. You still proceed with the central repair. The goal of a surgeon is to do central repair. However, there are certain exceptions to that, where, for example, mesenteric malperfusion. Well, there are a lot of debate regarding that. Some of the proponents, they say that if you just put a frozen elephant trunk, the central, while doing a central repair, the mesenteric malperfusion will solve by itself. But that is a dynamic malperfusion. Now, not all malperfusions are dynamic. Some are static malperfusion. Actually, there is nothing called static malperfusion. It is basically an occlusion. So it is a misnomer. And wherever there is an occlusion, then you have to treat it. Either you treat it with a selective cannulation or stenting or fenestration of the septum, and so on and so forth. That is the only reason why we will delay a surgery. Initially, we used to delay it for 2 weeks and 3 weeks, long time ago, 15 years ago. Nowadays, we delay surgery for mesenteric malperfusion maximally to 48 to 72 hours. When we see that the lactates and the amylase and all the labs, they come down and the acidosis has resolved, then you go ahead with surgery.
I'll caution you here only on one point, that don't go just by lactate. The worst thing that can happen is that you see the mesenteric malperfusion story coming up on the 5th day after you've done a central repair. So I think clinical sense has to be there. If patient is behaving hemodynamically, lactate must still be normal. Our general surgeons say, well, lactate theek hai, kuch nahi karna. And then suddenly on the 5th day, you find lactate shooting. So
sometimes what we do is that we not only see the labs, obviously we see the CT very carefully. And we have a multidisciplinary team with the interventional radiologists also. And we sit with them and we see the CT very, very carefully. And we see the lab parameters only as one can say a surrogate marker. Because there is a spectrum of mesenteric ischemia. It is not like, you see, it starts from the history itself. When the patient comes to the emergency, we see whether he has a history of abdominal pain or back pain. Some patient gives a history of abdominal pain. Some patients, they come with frank bloody stools, which is a very dangerous sign, which is gut gangrene. So there is a spectrum of mesenteric ischemia. In a mild mesenteric ischemia, you can still go ahead with the central repair. But in a gross mesenteric ischemia, then it is very difficult. The second factor here is the timing. So if there is a lot of difference in gut ischemia, if only 2 hours or 3 hours are elapsed, and the patient with 4 days of mesenteric ischemia, they will end up with gut grinding. And mostly 100% of these patients, they succumb.
So I would only say that if you have any doubt in your mind about gut ischemia, there were 2 options. Either do a laparoscopy, but there is a
on a central repair,
negativity in there, because we made an error on this once. So ask the general surgeon to make a limited 4-inch laparotomy and have a look at the gut. That's it.
In the central repair, we actually extend the incision, open the periperitoneum, and have a look at the gut. Sometimes when we have really doubt that there is a reason of mesenteric ischemia.
Can I just quickly ask you two points? And so one is, this is for discussion. I'm going to introduce all this. It's innominate artery for cannulation. Is that something, sir? Is that something?
Yes, that is if on a CT scan, innominate is not dissected, that is my default option. I used to do axillary cannulation for 15 years. Since last 6, 7, 8 years, I do innominate artery cannulation. That is my default option.
What cannula are you using for that?
Not cannula, sir, graft.
Okay. Because if there's a problem, if you remember in children, we used to use innominate cannulation for arch repair.
Yeah, and also selective antegrade cerebral perfusion.
Then we used to just turn the cannula over and all that. But that kind of cannula you cannot use in dissection. Yeah. Obviously, putting a graft is a more practical solution to the problem.
So you would be debranching with that.
We've been using
graft to debranch.
No, it depends upon. My initially when I started, of course from All India Institute, when I came out, I was conservative at that time. Sometimes I did only address the tear, ascending aorta replacement, that's all. Clamp the ascending aorta and handle the tear. That is the simplest operation actually to get the patient arrived. But now the generation of that, they are no longer there now. And so now my default option for this is a hemi-arch. An open arch and hemi-arch is the default option. The first. The second option, if I have to treat the arch, we do about 25 dissection per year, which is not a very big number, but since it's a smaller unit, it's a reasonable number. Last year, we have done only one total arch, and total arch is a very rare operation for dissection, according to me, including in United States. Total arch replacement is very, very rare operation. Maybe less than 1% of the patient requires a total arch. What we do is zone 2 arch, and zone 2 arch opens the possibility of n number of endovascular interventions. That is our best option if we have to address the arch.
Hi, thank you, Dr. Gupta, for inviting us. Regarding cannulation, I'd like to add 2 points. As Professor Bhan has already said, we use axillary cannulation for all dissection cases, but we always tend to use a graft rather than directly cannulating it because we find it a safer procedure to use a graft rather than directly cannulating it. Regarding innominate artery cannulation, I prefer not to use that because many a times, as we see in dissection patients, the dissection flap tends to extend up to the origin of the innominate artery as well. So it's better to go for the axillary cannulation. That's my view. In 3 cases, we had problem with axillary cannulation. The moment we went on pump, the line pressures went up. So we always use a T during cannulation and going on pump. So in one case, actually, we could actually cannulate the true lumen through the aortic arch. So that saved the day for us. And in rest of the 2 cases, we had to go for femoral cannulation. We always keep 3 lines in place, one from the axillary artery, one for the femoral artery, and one from the carotid artery. So that is, I think that's the safest strategy to go.
I would like to ask a question to Dr. Jowli. So based on how young or old the patient is, and of course, like Dr. Bhan mentioned, to get the patient out alive is the #1 strategy. But say a patient is relatively stable, like no lactemia, patient is not very sick. Hemodynamically, of course, hypertension at time of presentation, but controllable with labetalol. And the patient has, say, a proximal arch tear. So how aggressive would you be in such a case? Would you go ahead and do a hemi-arch or total arch, or would you just stick to ascending aortic repair? So based on age and, of course, how young a patient or older patient influences.
Young or old, its patient is acute or patient is settled. Acute patient, of course, you have to do the least and you have to do it immediately. And you will have to, as much as possible, stabilize the patient. Patient who are settled and calm. Then patient whose arch hasn't got a tear and patients whose arch has got a pathology. I think these are 2 different candidates. And the second variety, the patient whose arch has got a problem, I think I would go all the way and correct everything. And that patient gives me a time and opportunity to do this.
Thank you. If I can ask one question to the panel. So we try to sometimes do the minimum possible, which means a hemi-arch or maybe just an ascending aortic replacement. What is your thought about putting a graft from the ascending aortic graft to the innominate so that in future you don't have to open the chest again and you can just do a bypass in the neck and probably put a TVAR?
That's what I was saying, that is called zone 2 arch repair, where you replace the ascending aorta and then you debranch both innominate and left common carotid. And in the future, if you have to put a stent graft, you can put a stent graft. You can do a carotid subclavian bypass if you want to save the subclavian. The subclavian is attached. The distal anastomosis is at zone 2. So zone 2 arch is a way to go instead of a total arch replacement classical.
As such, as a general dictum for all modern cardiac surgeons, hemi-arch is a must. Like, try to push the disease as distal as possible. So hemi-arch is a must. Yeah, but that's like the bare minimum we need to do. So open the clamp, short, arrest time, maybe 10 minutes maximum, and then you're done with the hemi-arch and you restore true lumen flow. It also gives you the opportunity to look into the arch to see if there is any catastrophic tears or any other arch vessels involvement and things like that. Otherwise, it's just a blind thing. So, but I think what Dr. Prashant here is saying is that it's, if we are able to debranch zone 1, I think in today's hybrid world, I think that's the best option possible for this.
Patient is stable, I would go all the way, because today we are surgically so matured. But patient who is urgent and patient who have a doubt about the arch, I think that's the option which should be a must. Debranch, do the minimal, and then you have everything in your hand.
That's what we have been seeing, and it's very difficult for us to try and convince our cardiothoracic surgeons to, when you are going in to do the ascending aorta replacement, do at least a hemiarch. The point is that the same argument is we rather have a live patient than a patient dead on the table. But when it's an acute situation, would you still do this?
So, acute can be defined in many ways. It's either a patient who has arrested or arresting, or lactemia is already set in and patient has visual malperfusion or other things. Yes, that time you just restore true lumen perfusion and you're out. That's the general principle of dissection surgery, right? But if a patient has a acute type A dissection, as I just mentioned, and no other major clinical complications, then I would go for a hemiarch. In fact, all my ascending aorta repairs are hemiarch, all of them.
Another observation is, if you have to do a debranching, where do you do the proximal anastomosis? How below? Which is very important. A lot of people err and keep it little above, and then there is a hell.
The second issue was, I would like to ask the panel, what is their take on how much far you go onto the proximal end? Like Dr. Bhan has already mentioned, it's better to do a Bentall procedure straight away. What are your criteria of root replacement? And what are your criteria for valve sparing? Obviously, this procedure is mostly done by young surgeons at midnight, 1 o'clock, 2 o'clock. Senior surgeons like us may not be available who have got extensive experience of valve sparing procedure. So it might be actually dangerous or not advisable to do a valve sparing procedure by a surgeon who is doing only one valve sparing per year into an emergency setting in a sick patient. So what are your criteria for root replacement? What are your criteria for valve conservation? Valve conservation means, actually, I don't like this word valve sparing because it connotes the meaning that only Jacobs or David procedures are valve sparing. Coselli said that if the dissection flap is extending into the coronary sinus, the non-coronary sinus mostly, or the coronaries are dissected, and if you can resuspend the valve and repair that, that is also a valve sparing.
I think if a tear is originating in the root, there's no doubt it needs to be replaced. In terms of diameters, we got to be a bit, I would say, conservative in type A dissections. Unless it is 5 centimeters, I would say it's still okay in not so experienced hands to just leave it alone and just do ascending aortic repair. Between 4 and 4.5, you can still leave it alone. I think getting the patient out alive is definitely the motto here. And valve sparing, as you said, more often than not, I've seen people using valve sparing if they have left the root alone. But that's not actually the idea. It's actually David's or Jacobs, where you reconstruct the entire root. And that's why it's VSARR, so valve sparing aortic root replacement. So unless that is being done, and I think that should be reserved to very young patients who are uncomplicated type A dissections, I think it's still reasonable to do that in experienced hands. If it's a junior in the night, just either do a Bentall or just leave the root alone and take them.
If I can add to what Dr. Niranjan has already said, I think in an acute situation, I'll still prefer to go for a total root replacement, especially in Malperfusion patients who are syndromic, a dilated root, definitely tear in the root. And if more than 1/3 to 2/3 of the aortic root is involved in the dissection process. In those situations, I don't think valve sparing root replacement is an ideal operation because we need to get the patient out with minimum AI, and that is the goal of surgery. So yes, in aortic dissection, aortic root replacement, I think, is an ideal operation.
There is one philosophy is that if you cannot save the valve, there is no point in saving the root, just replace the root. So let's say if the morphological abnormality of the aortic valve is stenosis calcified or diseased, there is no point in doing a valve sparing. You straight away replace the aortic root. Or there is a connective tissue disorder with a massive root dilatation. It is better to do root replacement in one go.
It's valve replacement, which you do. Most of our patients are young patients, and then so would you be using a metallic valve in these patients? So see, that's where I wanted to ask you, when you have a metallic valve and then you have debranched it and we have to put a stent graft to enable the
Yes,
wire.
you can't put the guide wire through into the LV. So that is why it is ideal that you should put a bioprosthetic valve. We do valve sparing mostly the reason, not the classic David or Jacob's procedure. But as I said, by Koselle's definition, valve sparing, the root is addressed when the dissection flap extends below the sinotubular junction, then you will have to do something to that. You have to resuspend the valve. You may have to do, subcommissural annuloplasty. You may have to do repair of the sinus. In that, there is an option of endovascular stent graft in future because you can negotiate the guide wire into the LV and you can have good purchase on the stent graft. Otherwise, even if the patient is 50-year-old, I would advise to straight away do a biobentol.
So just to proceed with how we are treating these dissections, nowadays all around the world, some of the authors, especially a lot of centers of excellence for aortic surgery are coming up. So the concept now is tear-oriented surgery. So wherever you have these major tears, if it's in the arch or if it's unless the patient is in a dying situation, complicated type A dissections, they recommend doing a FET, frozen elephant trunk, or total arch repair or partial arch repair at least. Get to the tear and close the tear, which can give you better, outcomes. Because if there is a tear in the arch and you're just doing a hemi-arch, and correct me if I'm wrong, there could be very high incidence of delayed or early malperfusions, and that can kill the patient. So you've done the repair actually, but so I think that concept of tear-oriented repair is makes sense, and I think should be practiced at least in centers of excellence who do regularly, type A dissection.
Usually, although the classic Stanford as well as the DBK classification you have, but you can follow for the younger surgeon the TEM classification, which is the type of dissection. Then you have, entry point, entry tear, and then you have malperfusion syndrome. So you can categorize it right. The planning, preoperative planning is very important in this.
I have a question for Dr. Ban. Some of the Western authors are now saying that doing a frozen elephant trunk as a routine for type A dissections improves aortic remodeling in the future. So I just want to know your thoughts on this take.
I have never done a frozen elephant trunk in a type A dissection situation. Whatever 33 cases I have done, they are chronic.
One question to you all.
Yeah. The important thing is that, as I said, nothing goes without a price. A type A dissection, you start doing the frozen elephant trunk, adding to the duration of the surgery, sick patients, very fragile tissues. I imagine it will be technically more difficult and more challenging. Just because you want to remodel the aorta, because there are other ways which are sure which you can achieve the same thing at a later date to cover up that tear or reduce the flow through the false human and get the false human thrombus so that you can remodel the aorta with much simpler way. Frozen elephant trunk is not be taken lightly. It's a
Very correct.
taken seriously.
If you have a spontaneous dissection in the ascending aorta, it's above the STJ. But very fact that there's a dissection, this aorta may have aortopathy, most always. So is there anything like just ascending aortic replacement? Should we ever spare the root?
Well, so many patients, in fact, recently I operated on a patient who had a very limited dissection of the ascending aorta. That's it, nothing else. We changed just the ascending aorta. We didn't do anything. There was no evidence of any aortopathy. What had happened, whether it had happened spontaneously or whether any procedure had been done, there was no history, or it was post-traumatic, which can also be one of the reasons. But if you have a limited dissection and no evidence of aortopathy, what do you have to figure on the level?
Post-traumatic, we will have a history. but there is no
Yeah,
such
yeah.
history,
I'm-
spontaneous dissection, and there is no way to know there is aortopathy, there is no aortopathy.
So,
and
sometimes
10
patients-
years later, what will happen? That you have
some
seen.
patients have acute accelerated hypertension. During that time, they injured their aorta and settled down. It was by chance they found something like this on a CT or for some other reason you are investigating. So these are things which we have to keep in mind, because if there's no evidence of any aortopathy, what do we have to train the whole assembly?
And if the aortic root is not dilated, I think it's quite reasonable to leave it alone, because once the dissection part is taken care of, hypertension is taken care of, and if you're getting 10 years out of the primary repair, that's already an excellent result. And, unless it's grossly dilated, it's evident on table that, the root is dilated.
I'm saying this because in my past, I have seen this very easy, clean, just ascending aortic replacement done. I have seen in the future problems coming back. So unless I'm cocksure it is not an aortopathy, I should have a low trigger to replace
So
the
these
sinuses.
patients should have
That's
genetic
where
study.
that's
This
where the
patient-
genetics will play an important role.
Correct, but we
We
don't
have
do.
to start working on that.
That is correct, but we don't do in practice, and nobody does that. And
So
so,
it's going to happen, sir. I'm telling you.
no,
I've
that's
been talking to
tomorrow.
a few people to
Hmm.
look at the various genetic parameters that we need to look at. Because the main question when we are operating on somebody with acute dissection, the family is only concerned about their siblings and children and other people in the family. So I'm talking to the Amrita people, they are working on it. They have a biological lab where they're working on the various markers, TTF, beta, and all this stuff. Let us see how it shapes. Maybe in future we have some screening method to know whether these guys prone to dissection or. I think we should switch over to the next thing. Otherwise, we'll go on with this dissection, this dissection chapter only. We all get dissected.
I have one question for everybody, hopefully one last question. So a patient, you've done a dissection repair. You've not had any major signs of malperfusion on CT scan, but the patient continues to have lactemia. The limb perfusion is okay, pulses are okay, upper limb perfusion is okay, brain is well perfused. I don't see any dissection flaps, but the patient continues to have this lactemia, which worsens with MODS, then AKI. So how do you get out of the spiral of lactemia, AKI?
And you don't find the reason for this, you will not be able to fix it up. I think you have to look at gut, because most importantly, I just did a patient, I just did his bypass. And on the second post-op, he became unstable. And then we found his his stomach getting bloated up. Then we started looking at lactates going at 18, 19. We knew gut is gone. So I think the most important culprit in terms of the tissue load is the gut. And if your legs are okay, gut is the culprit.
And if the patient is very sick and the gut is involved, do you proceed to resect?
I'll answer the question the way our general surgery people said. Just last week, I'm telling you, I called them over. They said, get a CT done. I said, he can't be taken even the next bed. We will take him to a CT room.
Yeah.
Then he said, okay, we'll open up the abdomen in the ICU only. But family was not keen, so we gave it up.
No, that is a big issue. When you have a dissection extending lower down, whether the gut is involved, whatever you do, I mean, even whatever CT, MR, nothing will tell you if it is in that intermediate period where the gut has not gone into gangrene. It is ischemic. It will not show you, it may say it's edema, sometimes they say thickened wall, but that doesn't mean to say anything. So the only, as sir said, the only thing is either laparoscopy or as laparotomy, a small laparotomy.
So
And
I said laparoscopy, we made a mess of
Yeah.
ourselves. It gave us a wrong diagnosis. I think making a 4-inch laparotomy is not going to hurt. And as Prashant said, usko extend kar do thoda sa, but then you commit yourself. If you are following that pathway, this pathway just make a laparotomy and you feel the gut is not okay, you give it up. Otherwise, once you open the chest and then you open the peritoneum, that means you have committed yourself to that. Or otherwise, tell the
Niranjan.
family, this is your plan, this is how we are going to do it.
Dr. Niranjan.
Yes, sir. Yes, sir.
There was a saying when I was in general surgery, a negative laparotomy never killed a person. खोल ले उसको.
But that is
You miss it.
that is
You are in
peritonitis.
big- If you miss
That
it,
is peritonitis, that's not dissection.
So if you miss it, you're in back trouble. Lectemia हो रहा है, kidney perfusion
Yes.
ठीक है, वो तो कट
Yes.
ही है. बुद्धि इधर उधर मत लगाओ.
So that was
CT scan, when you see, actually I start seeing from the scanogram itself. Sometimes you see, big distended bowel and gas in the bowel. You know something is wrong.
Yeah.
Obviously, if you have like interventionist like Dr. Georgie, I say take him to the cath lab and see fenestrate the first.
Here again, I agree. Clinical sense
septum.
plus CT imaging should nail the bug. इतने में we should get it.
That's why I raised the point is you find a gut ischemia, but what are you going to do about it? So you've done a laparotomy. Yes.
Can I just say one thing? I'm sorry, I have to disagree with this discussion about that a laparotomy is required to diagnose gut ischemia with the advent of modern dual energy CT. I think we are going backwards here because with modern dual energy CT, with a good CT interpretation and with the high index of suspicion based on lactemia and clinical suspicion of, bowel sounds and all of those things together, high index of suspicion, you don't necessarily need to get to gas in the bowel wall to diagnose gut ischemia. You can diagnose mucosal ischemia far earlier than that, 24 hours, 36 hours earlier than that. So I think if you use your CT interpretation properly is the wrong word, with all modcons, then the concept that you cannot diagnose gut ischemia on CT alone is incorrect.
I think you have to look at what kind of CT you're doing first.
Yes.
If you're doing a single phase arterial CT, you're not going to find many.
No,
things.
it has to be
It has to be a multi-phase
multi-phase,
CT, never a single
mesenteric
phase.
CT.
Even if you have shifted out.
No,
Then you
so
can't do
that is a
anything
different-
anyway. Then it
that
doesn't
is-
matter. Then
No,
you are
if-
at a loss.
If the patient is too unstable to shift, then that is beyond the question. Question is in a subacute state where we are talking about an evolving malperfusion state, and you're wanting to make a diagnosis of malperfusion, of course, clinical, of course. Put your hand on the patient's tummy, look at the lactate, hear the bowel sounds, look at the bowel habits, look at the scanogram or the X-ray, like you said, all of that. But there are so many subtle signs of CT in the radiology. Modern radiology literature now is replete with these papers talking about
Agreed.
the superiority of CT in diagnosing the
It's
second.
a gold standard.
even you can also do just a normal
So I
routine
think-
ultrasound.
This is one of the advantages of a multidisciplinary team and a multidisciplinary meeting, that so many different points come up. Now, I would like to ask the panel, you mentioned and we sort of waved off using FET in acute type A dissection. Any of you use it? Because we do it, and that's a go-to procedure for type A dissection. And we've been quite happy with it. Dr. Gopichand is here. And I mean, I can't say why we should not do it.
Well, there have been a lot of controversial data of using FET in acute dissection. The centers which were using it, like Heinz Jacob in Eisen, or in fact, Hanover. Hanover, they were using almost 60% to start with. Now they are using only 10%. So there must be some credible reasoning. In Hanover.
What's the reason? No, what's the reason? Why would they say that FET cannot be used in acute dissection?
No, I'm forfeit. I think you have to ask people who are.
I am for FET only in selected patients. Only in selected patients, and that too, people who are using FET, they were also doing angioscopy to see a distal tear.
Yeah.
So,
If
Prashant,
there is no distal tear, then what is the rationale of using a FET?
so what
can
makes
do
you decide that this patient you will do FET and this patient you will not do FET? What are your criteria?
My criteria of doing FET is a highly complicated arch dissection with a tear extending to the distal aorta, which we can find out on CT scan. So
Yeah.
the planning is done on CT. We don't put FET blindly in all patients for two reasons. There is a price to pay for everything.
Yeah.
One is the price of life, and second is the price of money also.
Yeah. As I said, it's tear-oriented surgery. So if there's a tear in the arch, FET is reasonable.
But we spoke about
Niranjan,
angioscopy.
I just want to.
Yeah,
understand,
angioscopy
How
is-
many acute type A dissections has no tear in descending aorta? Most of it is going to extend down, right?
Not descending aorta. So we are talking about
Secondary tear.
arch and,
Arch and it's a spiral, right?
sir, multiple re-entry tears will be there. But if there is a major tear, a big interruption of the continuity of the septum, then yes, in those conditions, it's better to do a FET. Like recently, I had a case, patient had a subclavian artery tear causing retrograde type, non-A, non-B dissection with the proximal descending tear. And there was a big gap of at least 1 centimeter in the septum. Those are the type of cases where you need to do a FET. Otherwise, you're going to have near or short-term complications much sooner. So, but having said that, again, if there is a tear in the arch, FET.
And patients with connective tissue disorder, you should do FET actually, so that you can extend the stent graft nicely, because you can't put it in the native aorta. So the absolute indications of FET is complicated tear, distal tear, and connective tissue disorder. This patient, you must do a FET.
So when you are doing a FET, whether for acute or as Dr. Bhan said, for chronic, if you do not have a hybrid theater, how do you sort of make sure that your wire is in the field?
So
how do you place the graft? Because there have been instances where people have placed the distal end of the FET in the false lumen, ending up in a disaster. So how do you ensure truly?
Trans-echocardiography, sir. Trans-esophageal echocardiography. Absolutely. Till now, we've never had to be to the cath lab, fortunately, but we use trans-esophageal echocardiogram and CT. So CT, we've already identified which side the true lumen is. Sometimes it's on the esophageal side, sometimes it's on the other side. And on TE, that's how we correlate. And also, it should reach the ascending aorta. If it's threaded through the false lumen, that's a different issue. If there are major tears in the descending aorta, you need a cath lab probably for that. But more often than not, TE is.
So for T, Dr.
is good. Yeah, T is good enough unless you are doing something in a hybrid OR, which we don't do. We do in a routine OR.
Using T, are you sure that for the part of the aorta that is not visible on T, you're in the true lumen, the right way?
Usually from the apex of the heart or the descending aorta behind the apex of the heart to the ascending aorta, you can see everything in T. So almost always I know that I'm in the true lumen.
The only blind spot is the arch of aorta.
You typically start
and distal ascending
at
aorta.
the level of the diaphragm, visualizing that the wire is in the true lumen, and then slowly move the probe up, making sure that the wire is in the true lumen all along. So far, we've never gone wrong.
Okay. I've not used a T for guide wire placement. Shubro does it for me. But this is for my own knowledge. What I'm trying to say is, if you're cannulating the femoral artery, threading the femoral artery, is there a possibility you're zigzagging either from the true to the false to the zig in the abdomen?
So
does it create any problem?
No.
Use the CT. See which femoral artery is actually coming from the lumen, and that generally helps in making sure that you remain in the true.
So in this,
even what possibility, hypothetical possibility he has made is actually a reality. It is not a hypothetical.
No.
But the thing is that ultimately, finally, you should be in the true lumen.
Yeah,
because you are not deploying the stent graft below down. You're deploying
if you're
above.
only doing a type A, then it doesn't matter. But if you're also extending into as a type B, then it becomes important. So what we do as a default is we have this, we obviously look at the CT, we go from the appropriate groin. We know which wall, like you said, which wall to get your catheter. But what we also do, and you could argue that this is an over caution, we put a long sheath over the wire. And at several segments, we put contrast to show that we are in the true lumen also. So that is our default mode. And you could argue that the delta, the difference in mix is probably very small. But the very unusual odd case where you end up in the false lumen with the T-bar is just so disastrous that we don't do this. Both of us, we do this.
That's why in type A dissections, a short FET is recommended so that you do not end up being in false lumens elsewhere.
And the second reason is there have been incidents of paraplegia after FET. Yes. So it is
Long
not
FET.
an innocuous.
So how do you choose the size of the stent graft in FET? I mean, what size of stent would you want to use? Is it 24, 26, 28, 30? I mean, all are available. So how do you size it?
There are two schools of thoughts for diameters. One is the true lumen diameter at mid descending or where you want to land the FET. The true lumen diameter, that is where the septum is. The other thing which I've done about 10 cases where I've started measuring the diaphragmatic level aortic diameter. that gives an undiseased, undilated, non-dilated aortic diameter, which and -1. So more often than not, I will get almost the same diameters on both sides, and also to use a short FET, 100.
Correct me if I am wrong. Correct me, I am wrong. The stent graft, according to my information, the stent graft as the technology is approved by FDA only for aneurysm. Dissection is off-label use, to the best of my knowledge.
I don't.
So yes, it is like that. It is like that. So it is not approved for dissection as well. It is the off-label use, and to extend it into an acute setting as a FET, it's a little bit debatable.
For acute dissections, try to keep the diameter small, -1 preferably, than the diameter that you measured.
So at the level of the diaphragm, you take the total aortic diameter.
Yeah. Because usually that is native, undilated.
I think we are ignoring one very good tool, which is completely portable, usable in ICU, OT, wherever you want to use IVUS. Just get used to it. It's perfect, beautiful.
Yeah.
No errors.
Great point.
I was an endoscopy, that's what I was referring to. In fact, in an open aortic repair, I have even used a pediatric bronchoscope. You can properly ensure sterility. You put a pediatric bronchoscope so you can identify the tear, distal tear. If there is a distal tear, go ahead and put a FET.
It is US FDA approved for dissections.
Is it approved? Okay.
Yeah. Part of the place.
We have learned something.
Only Medtronic.
Medtronic, do they have a frozen elephant trunk device? I don't.
No.
No. What we are talking about is not the regular stent grafts.
Frozen elephant.
We are talking about frozen elephant trunk.
I think, Dr. Gupta, for the next meeting, we'll be discussing about AMDS, because that is the new type A dissection thing, and it has its own concept.
Something more interesting. I would like to ask all of you, how do outcomes of minimally invasive approaches compare to traditional open surgery for type A dissection in terms of mortality, morbidity, and recovery time? I don't know what we see meant by minimally invasive approaches, whether it's a surgery or some other type of hybrid.
Possibly just doing the least. I think we already discussed that. We are actually on the next session now on frozen elephant trunk.
Okay.
That is also for your.
Okay.
So I think we are clear about usage of FET in type A dissections. It's a very guarded use, and also diameters. What are the barriers to widespread adoption of FET, and how can training programs and centers of excellence address these challenges? Open to the panel or audience. Yeah, please, sir. Go ahead.
FET in elective setting is very good, I would say. I am for FET in elective setting, but in acute dissection, I think the biggest barrier is the price. The price to pay by the patient clinically as well as financially. No patient of acute dissection comes with 20 lakh in his pocket. So that is the biggest constraint of using a FET.
Sir, you had something.
I just wanted to ask a very basic question. I'm a vascular surgeon, not a cardiac surgeon. Is every type A dissection has to be operated immediately? Is there a rule for waiting? Suppose the root is not dilated, patient symptoms are such that no malperfusion. You have to do it in the night, you struggle, or they will postpone it.
So the problem with type A dissections, they are stable until they are stable. They can rupture, or it can propagate, or they can complicate very quickly. And very quickly, like you have a patient absolutely who looks pain-free, no other issues, just sitting up, talking, and the next minute he can rupture or something, a stroke. Yeah.
So the element of uncertainty is so high, and the probability of the risk of dying is so high that you take the patient immediately. In fact, your whole goal of surgical training and execution is how to take the patient, move the patient to OR and do a central repair.
I think
now, what are the barriers to it? The barriers is one of the mesenteric ischemia and comatose patient. Those are gone cases.
One update. The Thoraflex hybrid prosthesis is approved by US FDA for type A, acute type A dissections.
So there is also some emerging evidence in certain, I'm not a cardiac surgeon, so maybe I should not talk too much, but there is some evidence that for IMH, low risk aortic dissections, and like you said, a junior person operating in the middle of the night, maybe it should be deferred for a sort of urgent elective procedure slightly later. So there is a small subgroup of type A dissections which might be considered. Completely asymptomatic pain got better, IMH type of appearance on CT, where you might consider waiting till the expert team is around.
If a type A dissection does not die within the 24 hours, he's just lucky.
But you will never regret operating a patient early as fast as possible. You can always regret if you defer the patient.
Just for clarity, just for clarity. So intramural hematoma type A and type 1 dissection, though the surgery is same, the timing, is it any different? I want this clarity first. Intramural hematoma type.
It has to be dealt
As just
urgently as
like type A
possible.
dissection, as early as possible. Intramural hematoma.
I have lost one patient. I thought it was a type A intramural hematoma. I wait for the night, go for early morning surgery. She died in the night.
No.
So intramural hematoma. Remember, it was not a frank dissection as well. She died. So once diagnosed, I think we should go ahead. So
I totally agree. Let's not confuse it. 2% complications per hour on the hour. अभी अच्छा है मतलब नहीं कि we can wake up and do it. Don't by default wait. अब uncontrollable circumstances, surgery नहीं है types, then what can we do? But this is not something that we can sit on. No.
Okay, that was a very good discussion. Thank you, everyone, for joining us.
Thanks. I think that was a very, very controversial discussion, but I think all of us learned a lot from that. Thank you so much to the panel. Thank you. So the next panel is again on type A dissection, alternatives to frozen elephant trunk and post-Bental dissection challenges. Dr. Anil Bhan, Dr. Gopichand, Dr. Chandrasekhar, since you missed the last panel, you can be on this one. Dr. Venkatesh is here? No. Dr. Abhijit, Dr. Digvijay, and Rochan.
So good afternoon. So we will move on to second panel discussion. This is on alternatives to FET. We'll start with the first question. What are the indications for choosing alternatives like conventional elephant trunk versus total arch over frozen elephant trunk in type A aortic dissection? Sir, you want to start? The conventional, what? Yeah, sir.
Good afternoon, everyone. I think we are going with a presumption here. Alternatives to frozen elephant trunk. That means that by default is FET an option for type A dissection. I would, in the interest of discussion, request the audience to raise their hands who will do a FET in acute type A as on today. So there are, it's 10% or less, I think. So this leads to the discussion a little more interesting because these are alternatives to frozen elephant trunk. I'm sure many of you would have been doing a lot of stuff which is not a FET. So I'm sure I missed the first. Looks like we had a very interesting discussion on intramural hematomas and whether to wait or not. And you know, little later I will tell you some studies that came in during the COVID time when weight was compulsory and what the results turned out to be. So we are having a discussion that we are going with a presumption. This, PC has put in a program that we think that FET is the standard of care, which I would beg to differ in certain ways. But here we have to lead the discussion. So in a type A dissection, what are all the other options available? I presume that here we are going for the distal extent is extending beyond, hemiarch. So that is where the role of frozen elephant trunks comes in. So whether it's zone 1 or zone 2. Now, I would like to lead the discussion with what you would do in an acute type A dissection.
In fact, let us assume that patient requires FET for the indication that we just discussed, that patient has extensive arch dissection extending into DTA, and then it has to be done. Now, if we have to decide between the FET and a conventional, though before 2017 when FET was not so evolved or whatever, I think the mortality and spinal ischemia rates were quite high. But all the latest reports, it is not so. In fact, the FET overall results are much better, whether it is mortality or spinal ischemia. I would, between the two, prefer a FET over the conventional if I have to stick to the question.
I think my take would be on this, because I haven't done a FET in an acute dissection so far, I should admit. And my philosophy in acute dissection is to, treat the root as such, and then open distal anastomosis always with preferably an antegrade perfusion selectively. And also deal with the entry tear. If the entry tear is in the proximal aorta, where I could eliminate, I would just limit my distal extent to a hemiarch and not go beyond that. If the entry tear in the arch, we have to deal with a total arch. Sometimes an elderly person do a zone 1 or zone 2 and then debranch the arch vessels for a TVAR, which can be done as a staged procedure.
Suppose if I don't have doing dissection, compared to your chronic or aneurysm status, is there any increased incidence of spinal ischemia or mortality when you are using it?
Definitely, because see, you're dealing with a dissection. Already the intimal tear is there, and there could be some compromise with spinal blood flow for sure. And you're making it worse by putting in a FET, because the incidence of paraplegia is almost 3 to 5% with a FET in an acute situation. And what is my basic question is, what is the need to do an extension of this procedure? We have achieved a 2.9% mortality with a reintervention rate of 4 to 5% at a later date, and same as the data from Yale University. What is the need to extend it? Well, if there's a problem later on, we can always tackle it. Only thing is, we have to be very careful in dealing with these patients, following them up properly, and imaging them properly. And which we do very meticulously. I can tell you, if we do, suppose we are operating a type A dissection, we always do a post-op CT until renal parameters are bad, before the patient is discharged. And that serves as a baseline for us. And after that, depending on the size and situation of the aorta, we might repeat it after 1 year. Of course, it means a lot of imaging and contrast. But if suppose the baseline CT is okay, then we may do it after 2 years, 3 years. And depending on the progression of the aorta, we do CT every 5 years. Every 5 years, meticulously, except the patients who have a renal dysfunction. Those are the only ones where I stop from this particular modality. In that case, if we strongly feel there's a problem, then we get an MR angio non-contrast.
So basically, if you are looking at other options to FET,
basically all of us gone through from conventional simple bent arch to hemi-arch to total arch replacement for dissections, which are especially involving the ascending and arch and also going into the descending aorta. Before FET was available, we used to do the branching of all the head and neck vessels, or sometimes only carotids and common carotid, innominate and left carotid, leaving the subclavian to Dr. Gupta to handle. And then same session, we'll take them to cath lab and do the TVAR so that the aorta is fixed, and then patients is fine. I mean, obviously paraplegias, all those things need to be considered. When the FET arrived to me, that gave an opportunity. Prashant was pointing out going into zone and zone 2 and not further. It gave us an opportunity to bring the entire repair of the arch closer to zone 0. Zone 1 or zone 2, it doesn't matter. So you are cutting down a lot of morbidity. 1, 2. If you use a shorter, not longer FET, then the paraplegia incidence is much less. You are definitely taking care of the remodeling and as well as thrombosis of the false lumen. So the next stage, if and when it arrives during the follow-up, there's a huge length of landing zone for descending aorta to be taken care of. And hopefully the reestablishment of the true lumen also improves the vessel perfusion. So I believe there is definitely no contraindication for FET in acute dissections, and we've done I don't know 7 or 8 or even more in the last 2 years. I have. Oh right, okay. So all of them gave us much better results in terms of ICU stay, post-op bleeding, time that we spend after coming off bypass in management of the bleeding and all those things have come down tremendously. And by putting 3 branches to three head and neck vessels, it gives a great comfort for us. And we use innominate artery cannulation, so the antegrade flow on the right side of the head and neck is also taken care of during the arch manipulation.
Coming back to the same question.
Yeah, please. The question is very clear to me. Alternative to FET, माने descending thoracic aorta में tear है. Something has to be done, right? When you would not put in a FET, even though there is a descending thoracic aorta tear. So, एक तो poor landing zone, एक patient very sick. Otherwise, you'll be putting it, right?
Now, the question for you, how do you see the bleeding has come down? You said after using a FET, the bleeding has come down. That was what was surprising me a little bit, because bleeding is the main concern in type A dissections. And this is what keeps us bothering. The operation took, say, 70, 80 minutes of pump time. It took 2.5 hours of closure.
The reason is that our dissection that we need to do, the amount of dissection that we need to do further down becomes much less and less. If you're in zone 1 and zone 2, then all you need to do is to isolate the head and neck vessels and use the collar to anastomose the FET to the native aorta, and you are in true lumen anyway. So the amount of bleeding that we need to handle is right in front of us, not further down. Sometimes very difficult to see down in the descending aorta arch junction. So these are some of the things that I believe has played a great role in reducing the amount of bleeding post-op.
But do we really need, like Dr. Maan said, when we do a type A, say hemorrhage, we convert the type A into a non-A, non-B or a B. And what is the progression of this disease? Why are we want to extend? Because to prevent future expansion, especially in the zone just distal to the subclavian, which will lead to a later type B, which has its own indications. The data says, like he said, about 5 to 10% of these patients need a reintervention in the chronic long term. And that is if we leave the entry tear. So that is why if the entry tear is not an E2 or a E3 entry tear, if the entry tear is E1 in the ascending aorta, do we need to do an extension beyond a hemiarch? That is a question. That is debatable. Now, the next question is, if it is there, now, like he said, the question is, if you don't have a FET, I think a total arch with a conventional elephant trunk with a CNR graft, if you have, is good. And I think that should be the way to go in case if you have an entry tear in the distal arch, which you need to tackle.
Prashant, if you read the original work done by John Alfred's at the Yale University, as per them, the reintervention rate is 2 to 4%, right? And believe me, as I told you, we follow up all our patients and our reintervention rate will be almost the same. And there's a complete follow-up because if you come sometime, I'll show you how we maintain our aortic history. But what this number of suddenly 20-30% has come up recently. And as Cooley said, it's a company-driven technology, not a patient-driven technology. I'm very sorry to say that, but if it's not needed, what do we need? What do we need to do?
I find out that why they is going over trend, all the centers in the United States and Germany, because it when it spreads to a dissection rather than the in fact the centers like Hanover, Iceland, Texas, Atlanta, Georgia, everywhere the trend is decreasing. People used to put almost like in dissection, 30%, 40% of the patient used to get fed. Now hardly 5%, 10% they get. So I made a suggestion.
I think last year in ISCTS daily chapter meeting about is Bental procedure the only needed treatment for type A dissection, in which I had quoted some quota from Stanford, from Houston, Texas, initially from the Methodist Hospital of Dr. Pasoli, now of course in the Texas Heart. They all come up with the same idea that you don't have to extend this operation unnecessarily. As you said, we have to save the life. That's important. And there was a question on typing a type A intramural hematoma. We have lost patients. Let me tell you that, assuming that we have to manage them conservatively. And also the night it cannot be done. I'll tell you a small story. There was a patient 3 months back who came with a type A dissection. It was a Sunday. So I told my juniors, I said, get everything ready. I'm coming. And it was Sunday morning at I think 9:30. And I reached the parking. I told them, okay, I'm in the parking, shift the patient to operating room. And on the way to operating room, we finished off. He was just 34 years old gentleman. So this thing we cannot take lightly. And later on, what happens, we feel guilty about it. If you lose a patient, we feel very guilty about it. There's something which we could treat and probably salvage him, and we let him die just like that. So what I'm trying to say, I think it's a life-saving procedure. We should do as much as is necessary to save that life. Later on, the problems, there's a tear in the DTA, there's a tear here and there, can be sorted out. And when you look at the follow-up also, it's a proximal DTA which is enlarging, not the lower down. Lower down stays virtually the same. It's a proximal, and if the patients have extensive dilatation of the aorta, whole of DTA and abdominal aorta, in that case, anyway, it's a case for surgery, not for any kind of a device.
And a debranching is a good option if we do not want to do an arch and things. Just to do the hemi-arch type and debranch the arch vessels for a TEVAR, that's a very reasonable option, which definitely simplifies the whole thing. And to people who do the FET operation during an acute dissection, Gopi, you can answer me this question. It's more, we have to land the graft in the true lumen, and we need to have a stiff guide wire coming from the groin. And in an acute dissection, that is more scarier for me to place rather than,
So, as we had a short discussion earlier, we study the CT scan, make sure that which femoral artery gives us better access to the true lumen. And we always have Dr. Gupta is in the operating room. Our echocardiologist or our cardiologist will always see them just at the diaphragm, and then they trace back up. The other is when we actually open the aorta for repairing the arch, we make sure that the guide wire is in the true lumen. So I think that's maybe overrated in my view, but there are a lot of.
It's very tricky. I think it's very friable.
No, the thing is,
even when you enter true lumen,
we don't use the stiff wire. We use a glide wire.
Thermo wire.
Thermo. It's a soft wire that we use. Never a stiff wire. We are equally concerned about hitting.
Even the thermo is not, of course, it's not like the myo wire, but still, it is still the, in an acute dissection. I know. I'm just asking you a question.
No,
whether
the fear is there, but I mean, I can only tell you from the cases that we've done, we've not caused any injury with the wire.
And there is no need to use a stiff wire, basically. Wire is a guide here. It's not for deployment purpose as
So
such.
he says with the
You can
tempo, there is a possibility of injury. So far, we've not had it, and that is the evidence we can quote to you.
I think you can use any wire because you're holding both ends of the wire.
Yeah.
There is no reason to worry about
No,
it.
while passing it, he's concerned. And
While passing in an acute dissection, if you're talking type A, your dissection is up there.
Yeah.
By that time, you will have enough wire inside that your tip will not go awry. If you do have a chronic dissection, yes, it can be very challenging to find the right lumen. If the true lumen has total collapse at certain point, then it can be very challenging to do it. In which case, you should really have a hybrid system or a something to image in the cath lab itself. Otherwise, in the OT itself, otherwise, that may be difficult. But in acute dissection, I don't think that should be such a major problem.
Yeah, maybe, but in an acute, it can go down up to the iliacs. And
Yeah,
even if
yeah,
you
it can.
get into the right femoral with the true lumen, it can still go across through multiple
Absolutely.
entry stats in the false lumen.
Absolutely.
When
So
we
it's-
do the type B, we have seen, you know,
You need to have an
Yeah.
experienced person to do this,
Yeah.
and there's no arguing with that. But that it is particularly difficult, not that much. It's okay. I mean, we don't worry so much about injury there.
Actually, the zigzag pathway of the wire is not relevant here because your stent graft is only 15 centimeter, max 18 centimeter. So the last 15 centimeter should be in the true lumen. That's it. Whether it has crossed the false lumen or true lumen lower down is not relevant and not germane to the discussion.
Next question to Roshan sir. Like once we are in a true lumen at the infrarenal aorta by confirming the angio, like can we just take the pigtail catheter instead of the wire? And how is that when you're?
You will not be able to advance a pigtail if the true lumen is small.
No,
If the true lumen is large, there's no problem.
Yeah, if the true lumen is
If
especially
it's
large.
collapsed, I would not recommend taking a pigtail blindly. It may just buckle. You will not be able to. Without a wire to get up there till the ascending aorta, I don't think is a practical idea.
But the general principle of what you're saying is partly true. I simply because I would disagree with PC to actually use a terumo because a terumo has a higher chance of flipping in and out of the of tears. So actually, if you a J with the similar to what you're saying with the pigtail, a J like this is likely to remain in the same lumen, and a terumo is more likely to go zigzag out. So the default wire, I mean, of course, if you are going to check it with TE or a contrast run, then whichever wire you use is fine. But
I think the pigtail.
yeah. So no, that's what I'm saying. If it's under guidance, then it is absolutely.
I think the pigtail catheter across the arch in an acute dissection is quite dangerous. Yeah. I would never even think of using it. Buckle and it may go create a new entry point at the arch. It's very difficult.
In type B dissection, we do that routinely because in fact it's more dangerous to pass the wire. All you need to do is that you enter the true lumen in the femoral. Once you enter the femoral and there is space, use the smallest of the pigtail, gently maneuver it and it will go. If you have
in acute
lesion
dissections
obstruction,
yeah,
of course you don't push it across.
Then what do you
You have to rotate it slightly. See that the true lumen can be in different shapes. It could be oval, it could be this way. So you can push the the pigtail very carefully and it will enter.
Even
it's safer than using the wire.
No, sir, I disagree with that completely because
the true lumen is severely compressed. What you're telling is
Dr.
100% agree.
Gopi, does age have any bearing for putting elephant trunk, frozen elephant trunk? Let's say patient is 40. Would you like to put elephant trunk in those patients or rather patient is 75?
I'm not aware of any age-related contraindications for putting
Specific indication. Suppose the patient is young, so you expect that there might be some incremental intervention, re-intervention rate in future. So you'd like to have at least some bailout plan, some sort of a contingency plan for future.
Right, Prashant. Younger patients doing a more definitive procedure makes sense to avoid the risk of re-intervention in future. A guy who's 75 or 80-year-old doing a simpler procedure makes sense because he may not live long enough for a re-intervention. So I think that's a very valid point.
On the contrary,
life expectancy is more than 15 years, then they put it.
But on the contrary, you want to do less for a 75-year-old patient. So you may want to just confine yourself to just hemi-arch or do a debranching and then let these guys do a TVAR where FET is not an issue at all. So, you know, in a way, you want to confine yourself to zone 0, closer to zone 0, so that the amount of dissection or intervention that you're doing is much less for a older patient.
Hi, everyone. I'm Dr. Rajesh, Professor Cardiology at Chandigarh. I just listened to the discussion about wiring from femoral artery to ascending aorta. We have an experience of doing TVAR for type B dissection. And then there are the cases when there is a difficulty in wiring from femoral artery to the ascending aorta. In this condition, few of my cases, I have gone through the right radial or left radial to enter to the descending aorta, snare the wire and come out. So have you people tried about using, say, radial artery to have the human, and you do a detailed imaging of the aorta in the CT scan, you can very well have an idea about where is the true human and the ascending aorta for type A dissection, wire it and place the 15 centimeter.
I remember when we in the early part of our TVAR experience, Gupta ji had terrible time for almost 3-4 hours. I wondered what this guy is doing. He tried both femorals and he could not do anything. So I didn't even know that such a thing existed. He used brachial artery to go into the ascending aorta, so to go through the innominate artery into the arch, and he went into the femorals, did a railroading, brought it out, and then put the wire from below. It's a great experience for me.
Because we have the opportunity to look at renal and mesenteric artery in the cath lab, but as you people are operating in the operation theater, not able to have a look on the mesenteric arteries and to have an idea about true versus false lumen. This is a good idea to go from the radial or brachial artery to have the true lumen, and then you are not supposed to have an idea about the distal and the descending aorta. Just put a wire from the brachial artery, you are sure about the true lumen, and put a front, we stand over there.
I think we are a little bit deviating from what the discussion is ought to be. So we had a discussion about non-FET total arch with a conventional elephant trunk. A Sienna graft will help. And we also had discussion, Prashant raised the issue of age. Yes, younger the age, go for more extensive. Older the age, confine yourself to hemiarch. Maybe debranching if the entry tire is in the E2 or E3, where you can follow it up with a standard stent graft to the femoral. And now we move on to, is there any emerging technologies and non-FET approaches, branch stent grafts? I think we have some experts here on, where total endovascular solutions are possible. Always George Joseph is here. So, and, if anyone wants to chip in on these topics, like how can the branch stent grafts and the future technologies going to change in this scenario?
No, if you're talking type A, there is only really the endobenton. Problem is it's not yet in clinical use at all. 1 in man or 2 in man have been done, but that is far from deployment. I think for the type A, the initial procedure is 100% surgical. In the case there is a re-intervention, definitely endovascular things have a role. But in the initial presentation of a type A dissection, I don't think as of now there is an endovascular solution. Maybe they will be in the future. We know Brazil, they did one first in man and we've seen the videos.
But no, we are looking at hybrid solutions. Like for example,
so combining
instead of T-branching, you just do a ascending aortic replacement, give you maybe,
in a type A.
Yeah, instead of giving you a zero landing, you do a stented,
If you have an arch involvement, and instead of a FET, you want to do more comprehensive total endovascular solution. I think if you're okay with FET and you get a wire across, it'll probably be quicker to do the FET than to put branches through with a complex endovascular device in the acute situation. I would not attempt with an ill patient. Definitely not. It is not completely predictable. When it's reasonably good, we all have done, Dr. Joseph has done many, but generally in a chronic situation, not in an acute situation. I would not put it. But yes, if the descending thoracic is involved and you want to take care of that at the same time, that can certainly be done. If you have covered up till the arch or debranched the arch, then we can put you provide sufficient landing zone, you can put a TVAR device down there.
Now, here the question addresses in an acute situation, whether there is a role for band stent grafts to manage the arch vessels. Suppose if somebody has done in a hemiarch and then patient gets shifted to you and you still feel the entry tear is still in the arch, or where you have to do something to prevent the expansion.
Yeah, thank you. I think I have a number of points to make, so I'll start with your point. So, if a surgeon has done a Bental and there is a problem in the arch, we can the very next day do a total arch repair. We don't need a chronic state or anything like that. So we need a landing zone. So that is the most important part of arch endovascular repair, a good landing zone, and that's where surgeons can be of great help. So the reality of type A dissection in India today is the patient has a sudden chest pain, he goes to the nearest center, he gets referred to the nearest cardiothoracic surgeon. And I don't think he'll have the fortune of running into Dr. Ban or Prashant. He'll be in some smaller center where the surgeon is not so experienced. So he wants to just save the patient and get out. So that sort of a situation, my recommendation is just do a Bental or a ascending aortic replacement, maybe a hemiarch, and come out. The rest of it can be done endovascular, as long as you give us a good landing zone. Now, what is a good landing zone? There are 4 points to that. The ascending graft should be long enough. Now, I've seen ascending replacements which are 3 centimeters long, just 3 centimeters. I've measured it on the CT. Maybe that removed the entry tear, but it is just 3. And in that 3, there is a 90-degree kink. So the second point is there should not be a kink in that surgical graft. So it should be long, it should not have a kink, and should not have a stricture at either end. So I have seen a number of cases where there is a severe stenosis at the anastomosis point, mostly the distal anastomosis. And I've had the misfortune of putting an endograft into that stricture and then worsening the gradient, and then I'm really in a mess. So now I do a CAT gradient whenever I do this kind of a procedure, post-Bental arch repair. So do not have a stricture at either end. Have a straight tube, preferably a wide tube, but 33 centimeters is more than enough. No kink in it. There shouldn't be any redundancy in it that becomes a 90-degree bend later. That is very difficult for our graft to get through and oppose and not have a leak. So if these 3 are done, and the 4th point is, if the root is diseased, please replace it. Because we have had situations where nice ascending repair is done, but the root has reached 5 centimeters. Now, if we repair the arch with endovascular, the root is still there to be repaired. So then there's no point doing endovascular because you have to do an open surgery anyhow after that. So the root, if diseased, or even if there is a faint suspicion of disease, please do a Bental, replace the root. And the ascending graft should be long, should be straight, should not have strictures at either end. And if it goes into do a hemiarch, even better. Now, this deep branching the arch, I don't think is required because today we are very happy doing a total arch repair. It goes off very fast. We've crossed about 120 cases, and it's very simple. I now teach it to anybody who attends our course, and now a number of places in the country, they're starting it. A total arch endovascular fenestrated repair. Now that is coming. There are already publications, and in the future, a post-Bental scenario is more likely to be treated endovascularly than by a second major open surgery. It makes sense. There are so many patients running around the country being rejected by surgeon after surgeon, post-Bental patient, because they don't want to go in and, there's all these additions, there's this diseased arch and descending, and it's going to be a major surgery. So they keep going shopping all over the place, and then some of them come to me and say, yeah, we can fix it by doing a endovascular procedure. So my request is to surgeons is keep it simple, save the patient's life, give us a good landing zone, treat the root. If you've done this, everything is possible in the future.
Can I just ask one question, sir, on that aspect? With regards to now you're moving from not doing FET, not that commonly, and moving to
Not even doing art.
not ascending heart and hemiarch. So if there's valve replacement, right? This is a question I put earlier also, because you have a metallic valve,
Yeah,
it
yeah.
makes it difficult. So there are the newer valves, the polymer valves, I don't know, since you're talking about bioprosthetic or the polymer valves. What do you think about that?
You know, I forgot that point. If you have done a Pental with a St. Jude bileaflet valve, no problem. We can go right into the LV with a wire. The nose cone of the device goes in. Even the sheath can go in. It has been published from Munich that the distance is 8 millimeters. Yeah. We have crossed 10 cases where we have crossed bileaflet St. Jude valve with our device, and our endograph starts at the ST junction. So the nose cone has gone way in, and there is no problem. The other leaflet keeps moving. We look at the pressure. There is hardly any drop in pressure. Maybe it widens a bit because you have a little bit of air. Bileaflet, no problem. Now, what about old Joxley or a single leaflet? We had one patient who 25 years ago had a single leaflet aortic valve replacement, now needs the arch and descending.
Just one question. In a bileaflet, are you going through the central aperture?
No, we're going through the side, the right side. Central is dangerous. So we put the wire in.
But for that, the valve should be oriented like that. Sometimes the surgeon don't orient it valve. Like in a bileaflet, generally, how do I explain that?
No,
But
okay.
Right, left, like that.
Yeah.
Surgeon now.
No problem. You can orient it any way you want. We will go to a fluoroscopic view where we see the two leaflets moving.
So
and
you
then
will go to a side aperture.
Absolutely.
Because central aperture obviously will produce a
that's
severe
dangerous.
AR.
So very small too.
It won't go. Central is dangerous, and the nose cone will not go. So we go to the side.
But there
Usually
is a
right.
possibility of leaflet fracture in there.
Not yet. We have not done that many cases. We've done 10.
Leaflet fracture and leaflet dislocation.
Now, the moment you go in, there'll be an acute AR, of course.
Yeah, but you can
only with one leaflet. The others
have
still
they
can't
used a
see.
peripheral cardiopulmonary bypass?
No, this patient is not on any kind of bypass. We've got his, he's in the cath lab. We've got the pressures going.
In cath lab, they use ECMO very routinely in Germany.
It's not required. It can be done without any of those things. But it's doable, eminently doable. So Pental is not a problem to do a arch.
The wire across would be the stiff Lundquist wire.
Lundquist wire. So we cross with the Termo wire, get a pigtail into the LV, change to the Lundquist wire, and then do the.
Now, Dr. George, when you do this fenestrated arch repairs in an acute situation, how effective it is to prevent it from having endoleaks?
I don't think.
Because if you have a tear there, I'm sure there will be some endoleak which is going to still create some.
So the teaching as far as dissections go, the best time to do a dissection endovascular repair is in the subacute phase, which is beyond 14 days. So let us say the patient has had a Pental day 1 or day 2. I don't think in 10 days it's going to be such a big problem, doing a total arch repair after that 14th day. We've not done any.
So what is the indication after 14 days? The patient has been waiting for 14 days. He can wait for a month, which will be a defined chronic dissection.
Absolutely. So there is no need to rush unless there is some, say, organ malperfusion or something, or the threatened rupture or something. That's quite rare. Once the surgeon has done a ascending replacement, they usually settle down in the short term. But in the long term, you start seeing the false lumen is
Sometimes you have radiologic malperfusion, bilateral carotid dissection, but clinically the patient doesn't show any sign of malperfusion. Would you like to fix that?
Not really. There should be clinical evidence of some kind of malperfusion or aneurysm growth, false lumen aneurysm growth, something like that. Then only we go in. Otherwise, we just wait. Like we mentioned, keep doing CT scans once in 5 years. If they are stable, no other problem, nothing required. But I'm talking about situations where they are degenerating. The whole thing is getting worse and you need to do something, and they're considering a second open surgery. Now, in those sort of situations, I'm saying we do have an endovascular option.
So, I just want to ask you, you said you have done 10 such cases where you did post-Bentall, a total arch endovascular procedure.
No,
What?
We crossed the valve with the device.
120 cases.
We have done,
No, that is the total number.
No.
I'm just asking about the patients who had a type A
Yeah.
dissection, underwent a Bentall procedure, and then you have to go back in the subacute phase. What was the indications of doing it?
No, so
Because in our experience, as I told you, we do quite a few dissections. We never needed to do anything
Correct.
of that kind in,
No, the vast majority were chronic. Vast majority were chronic dissections.
Yes, precisely.
Yeah,
Yes, so-
vast majority are chronic. But I was saying that in case there is a situation where you need to do something quickly, we can still do it.
Because dealing with these aortas is not easy.
yeah.
They're very fragile aortas.
Absolutely.
They can bleed any time. And as Dr. Cooley said, the aortas do bleed, the books don't.
Absolutely, I completely agree with you. It's not that we want to rush in immediately after the Bentall. I was saying in case there is a malperfusion in the descending or something and something needs to be done, we can do it. But
One question I want to ask, which may not be relevant to the discussion. We have had a patient who has had a FET, and about 2 years back, she had a Bentall procedure done somewhere else. She came to me with a dilatation of the arch and the central aorta. We did a FET, and unfortunately, the lower end of the FET is lying in the false lumen. So she's getting back for admission day after tomorrow because I was given this impression it's a disaster. But she's perfectly all right. Only thing is that false lumen is getting perfused. So our vascular team headed by Dr. Parekh, they say we'll cross into this from true lumen to this FET lower end and put an extension. So it sounded so simple. But here, after listening to so many people, I'm getting scared whether we should get it done or not get it done. She's getting admitted on Monday. She held back. I said, I'm not in town, so come on Monday. So,
So she's one of the lucky ones whose false lumen is holding stable. Generally, the false lumen with a high flow has a potential to enlarge, and then it can be a disaster. But she's one of those lucky ones where it has not been a disaster. So I think you can let Dr. Parekh go ahead.
yeah. Otherwise, I'll have to open it up.
We have 15 minutes more and we have a couple of more.
One more point before I leave. I want to tell you, Prashant, because we were all talking great things about FET. Let me tell you, the long-term benefits of FET are far inferior to the endovascular device. There is data available on this. Endovascular hybrid procedures are far superior to FET in terms of the longevity and in terms of the survival.
Sir, I want to ask George the same question. When you do a hybrid procedure and then do a hemi-arch or whatever, and do a thoracic graft, maybe single vessel pen for the subclave or whatever. The point is, what is the long-term results vis-a-vis you doing it totally endovascular? Hybrid versus total endovascular.
Okay, so you're talking about hybrid debranching and then the thing versus total endovascular. I don't think we have much data on that. The total endovascular series are just about coming out. Stephen Holland's was one of the first ones. Their first generation, the first study didn't do too well, but the second onwards have been doing very well. So it's no head-to-head comparison. But if you look at the results, just as good or better.
So there's also stent fractures.
No, I haven't
Recently,
seen
I saw one patient very much in this city, stent fracture in the subclavian and a massive chest.
You're talking about the fenestration stent into the subclavian has fractured.
Yes. The branch stent.
Depends on.
Stent. That can happen.
We have not seen one yet. I'll qualify that remark. There was a stent called the Silene stent. It's an American stent, horrible stent. It was like half of them were fracturing. So that was a bad manufacturing. But now we have very good stents, dedicated fenestration stents. There are 2 of them, which are meant for fenestration. So double layer of metal, double layer of fabric. So really strong ones. One is VBX. and the other is
B-flared.
VBX. Yeah.
That's good. And
And-
B-flared from the other one.
And the other one is
B-flared.
the Bentley 2. There is the Bentley 2.
Yeah,
So these are the two dedicated fenestration stents.
just again for my clarity, sir, one more thing is that that will be aortic, Bentley.
That's the
Yeah,
aortic.
Bentley aortic you'll have to use
Yeah.
if you are going to use that.
More than 12 million.
The for these total arch endovascular, these subset of patients who have got connective tissue disorder, so their aortas and vessels are not normal. So that you wouldn't do an arch endovascular, just as
No,
would you-
the dictum for genetic diseases, the repair must start in a surgical graft.
Okay.
Okay.
Understood. What about the stents you put into the carotids?
No, that is okay. Into the aortic branches, you can put stents, but in the aorta, in a genetic or a collagen disease, the repair must start in a surgical graft. Because
that's why I was saying that FAT, one of the cardinal indication is connective tissue disorder. Marfan, Ehlers-Danlos, their FAT is a very good procedure. Actually.
So we've
but sir, we always see some, let's say, even in connective tissue disorder like Marfan, we do axillary cannulation. Those arteries are very fragile. So I thought that it's not only the aorta, but there is a cystic medial necrosis all over the vasculature.
If you hold the artery, you're going to lose it.
I agree. Axillary, I shifted completely to carotid. Stitch a graft to the carotid.
One question too. One, can I ask a question?
What I was talking about was hybrid versus total
endovascular.
There is I don't know if there's a follow-up on the Najuta series from Japan. Sir, which is a custom-made graft actually, but they had total endovascular arch. Very large number of cases. They had a 5-year follow-up with the reintervention rates around 15%, I think. But that's Japanese, so I don't really know what.
The other thing I want to ask you is,
Can I just so excellent discussion about the type A. I think Dr. Bhan is just leaving. So there was a point there, multidisciplinary approach. I'm sure there are enough senior surgeons here, cardiologists, vascular surgeons, IRs. So what are the lessons learned throughout these years of experience? Like one was mesenteric ischemia, where and coma patients, you said, we have to defer the central repair. So is there anything like, is it just a cardiologist or a surgeon, cardiac surgeon, or do you involve the intensivists? What was their learning experience over the period of years of managing these patients? And is there a holistic approach to say, okay, this patient is not going to make it. Let us not, do on this. No, it is just a thought, because a lot of us are sitting in this room. Just to close this discussion, can some of you have an approach where how there is a, Prashant was telling about the mesenteric ischemia and the coma, these are the patients we should not be doing. So is there anything we can come to some understanding?
There is a couple of scoring systems. Actually, the STS 0 score doesn't work well. You have a web-based app from the German registry for dissection, Gerada registry. They have a scoring system where 15 to 30 plus corresponds to the mortality. If your score is less than 15, it's a 15% mortality, 15 to 30% mortality, more than 30 is a 30% mortality, where there is organ malperfusion. There is a pen scoring system, which goes by the amount of the quantum of ischemia that is involved. 0 is no ischemia, there is no malperfusion. And then you have 1, 2, and 3. 1 is proximal coronary malperfusion, 2 is arch vessels, 3 is mesenteric, 3 plus is mesenteric or anything peripheral, which has more than 50% mortality. And mesenteric per se carries 5 times mortality than any of the other ischemias. So this is a form of a rough scoring system on which you can risk stratify But as you know, in cardiac surgery, the three calcific aortic stenosis, CTEPH, and acute dissections have strictly no contraindications. Their relative contraindications or the risk is higher. But based on this scoring system, it will give you a reasonable idea whether it's worth going in or not. And when there is a level 3 of a pen scoring system, there is a debate on whether to reperfuse the ischemic area first and then do a central repair, or a central repair immediately followed by. That's still debatable. I do not know what the answer is still.
I think we should also address the basic question when the patient comes to the emergency department, how the emergency physician sees the patient. Some patient comes with stroke, they go the stroke pathway. Some patient come mimicking myocardial infarction, they go infarction pathway. Some patient comes with acute abdomen, they go to GI pathway. And some patient comes with limb ischemia, they go to a vascular surgery. Sometimes the diagnosis of dissection is actually missed, and that is very detrimental to the patient.
Absolutely. In fact, the consensus statement 2024 says that the basic thing is to feel all pulses clinically.
Yes. Because many a times we have operated patients who have actually been thrombolized, and they have loaded with dual antiplatelet, and that is a nightmare.
Like you said, recently we had a patient who had carotid dissection, both, but neurologically intact. So you never know whether this really on the CT pictures, clinical picture is something totally different.
Just can I have a quick question? Just on this alternative FET. I was looking at the RTVON's new device, which I read in one of the papers, SRS Medical AMDS, yeah, which has got a proximal PTFE and a distal retinol stent, which is non-covered. So they're saying that that sort of increases, sort of modifies the flow, and then is essentially closes of the false lumen. What do you think about? I mean, have you heard of the AMD?
There's the DOTS trial which has been done with the AMDS device, I think in the US multiple centers.
Yeah.
So basically they say if you are seeing the patient is too sick for an FET, or it's too difficult to do because of collapsed lumen problems, whatever. If your FET is not your best option, you don't want to deal with the cerebrovascular circulation debranching and anastomosis, you can try to restore the true lumen by placing the AMDS and address the problems, which may happen later by getting time to get the patient off the extremely sick list and then deal with it.
So the AMDS is an open procedure, isn't it? It's an open procedure.
Yeah, it's surgical procedure. It's surgical.
So I want to ask you,
it's a stent instead of a stent draft.
What are the re-entry points if there are there? Will that?
No, actually, the open stent is basically like to keep communication between the false and the true lumen, to have a both perfusion of both true and false.
Reopen the true lumen.
Thank you very much. I'm Dr. Fujikawa, a Japanese surgeon working in Hong Kong, and now AMDS is available in Hong Kong now. So we are launching the radar trial. This is a randomized control trial, which is a better for hemiarch replacement, just hemiarch replacement, or hemiarch with AMDS or not. So I have a couple of experience of implantation. So AMDS is a bare stent device. And actually, I can, today I don't have presentation about AMDS, so just I want to explain about the length of AMDS. AMDS can reach to diaphragm level. If you take chest X-ray after the operation, the AMDS is reaching to diaphragm level. So it will expand the distal true lumen. But at the same time, there are a lot of contraindications if there is because this is a bare stent. So if there is any entry tear in the arch, we shouldn't use it. And so as for the today's discussion, first of all, my basic strategy for type A dissection is hemiarch replacement, because still type A dissection surgery is higher mortality. So life saving is a first priority. And then I go to frozen infantile is if tear is in the arch or arch is already dilated. If that's the case, we proceed to frozen infantile. So another indication of AMDS is the Artivion company is pushing to use more and more Sorry, I didn't know. But in my opinion, this today is one of the topic. If patient has a gut ischemia due to the narrow descending through lumen, it's the best indication of AMDS. So this is, I think, a last solution for the AMDS. So I hope it will be available in India as well. And if you have any information, I'm willing to share my modest experience. Thank you very much.
One caveat, it is definitely very beneficial when there is a mesenteric ischemia,
Yes.
but it should be dynamic in nature, not a anatomic obstruction. Like like thrombosis of the mesenteric artery or a flap intercepting into the mesenteric artery is not going to be solved by EM.
Because AMDS cannot solve all of the problem. Thank you.
I think, we have a couple of questions to be addressed. We discussed everything. In fact, there is a question on whether mechanical or bioprosthetic valve. I think the intention was to see whether we can cross it for future interventions. So the other thing is how to manage the coronary issue. Yeah. Coronary artery involvement or pseudoaneurysm following a Bentall. Yeah. I had one patient who had the coronary buttons alone becoming aneurysmal. But the patient is stable, so I'm watching him. It's not huge, but still there. So any tissue can expand over a period of time.
Usually in connective tissue disorder, we cut a very small button.
So still that small.
Yeah. And
It was
the
done
line
about-
is going through the osteum.
Yeah,
Osteum.
I always go through the osteum. It was 12 years ago, but it's still a small, little two bulges are there. But it's not big enough, but I can see that, the question is, I'm sure there are a lot of big pseudoaneurysms which come or from the proximal suture line. I have seen one patient have a,
I have a point to make, which is off this question, but when you're doing a Bentall and you reimplant the coronaries, if you reimplant them high, then our landing zone is compromised. So do not reimplant coronaries high up. Keep them as low as possible so that there is longer endovascular.
Generally, it is not implanted higher because in order to implant higher, you have to actually mobilize the coronary. And
if you are doing a
some of
vein graft,
the endovascular intervention, they say low implant, but the cardiologists who do structural heart, they say make it high.
No, no, Dr. George is talking about in case you need to do a bypass, I think. The coronary buttons, we just mobilize a little, and wherever it comes without stress, we just put it.
Talking about the proximal landing zone. It
Correct.
reduces the proximal
Correct. He's
landing
talking
zone.
about sometimes when you do a Bentall, if the RCA or something is the
structural
dissected.
specialist, he says higher implant so that there should not be coronary occlusion if I have to do valve in a valve for a degenerated by a Bentall.
So
we all got landing zones.
Yeah.
No, I've had opportunity, 3 of them, where the cannulation, when they cannulate the aorta, they develop a pseudoaneurysm there. So it all depends on the size of the rent. Because if it is chronic, then it becomes bigger. So we've used the PDA device, and we've also used a ASD device sometimes when it's large, like a plug.
But that's not a coronary.
No, not correct.
So it's a trade-off between TAVR and TAVR, I think. I think one take-home point is you need 5 centimeter, right, in a graft landing zone. That's very important.
4 is the minimum.
4, yeah.
But 5 is 6 luxury.
So even when we debranch, we have to get the inflow as low as possible.
In fact, the question that was asked is post-Bentall pseudoaneurysm, AVR pseudoaneurysm or those kind of things. The first in man case, Sao Paulo, was one endobentall was done on a patient who had an AVR and subsequently developed pseudoaneurysm. But that's not, I think there is a presentation. He's going to give a talk at 4:30 online. So it'll be interesting to watch that. But surgical is the best option for addressing both pseudoaneurysms as well as coronary. When we didn't know about the connective tissue disorders affecting the arch or the aorta, the entire media, We even used to leave a lot of island of head and neck vessels when we're reimplanting the head and neck vessels as an island as opposed to individual grafts. They themselves become aneurysmal, and we had few cases where we need to go back and then re-excise that part. So surgical would be the right option for these kind of problems as of now, obviously.
We recently had a case of a pseudoaneurysm post-surgical, which could not be operated because patients already had, I think, 3 open heart surgeries. So we did a total arch repair and landed into the ascending graft and closed off that pseudoaneurysm. Because why did I do total arch? Because the innominate, left carotid, left circulating, all very bunched up close to each other. So if you want a distal landing zone, we had to go into zone 3. So we had to have 3 fenestrations, and it was effective.
I think we will sum up this session. Thanks to everyone. To summarize, I think these are non-FET options. I wish to state that FET is not a standard option in type A dissection consequent to all the discussions and how many hands went up. And in India, we are also limited by the availability of FET in the middle of the night when we have. So a standard hemi-arch is quite good unless there is a tear in the arch where we have to chase it to extend the distal extent. Open distal anastomosis is a standard of care and have a low threshold to address the root. If the root is dilated, to do either a valve sparing root or a Bentol. And I think maybe everyone may not be George Joseph. If the patient is in an age group where a bioprosthetic valve is applicable, it's just say even on the lower threshold 50, probably a bioprosthetic valve may be better to address future issues. But then George has his own techniques to cross St. Jude valve. So that is good. So I think this is to summarize, this is the take-home messages. And I think we have a lot of talks coming out on future technologies and how this is going to evolve in future to make it lesser invasive. So I think this is the message that has come out of the discussion so far in this session. Thank you very much for the opportunity. Thanks all participants.
Then can you unstuck a stuck valve? If you can enter it through, can you unstuck a stuck valve?
Yeah.
Yeah.
It's already published, how they do it. They actually balloon. Yeah, they do a balloon dilatation and release it. And they have cerebral protection because embolization can happen.
Thank you. We don't have coffee breaks, but coffee is available outside through the day. Anyone feeling sleepy or just wants a break, please go have a cup of coffee. And I'm glad to see we are running almost on time. So next, we move on from type A, which has been so controversial, to another very controversial area, type B aortic dissection, how to manage that. So in this, we'll discuss best practices for TBAD management, including role of IVUS that did come up, complicated versus uncomplicated TBAD, and medical management approaches. Dr. Shekhar, I think he's having his coffee break. Shivanesham, yeah. Dr. Sharath, Shubro. Dr. Jain is not here. Rohit. Rohit is also, I think, on a coffee break, and Murli. So again, we try to follow some of the things that we've written on in the booklet. So we try and follow some of the things which are mentioned, but if you feel like digressing, there is something more important, and within audience participation, we can go ahead.
Somebody needs to moderate. Yes. Otherwise, we won't stop talking. Okay. So I think the questions are excellent. And thank you very much for firstly inviting us and also allowing us to have this discussion. And if we can get through even 75% of those topics that you have highlighted, then I think it would be a big win. So the first, let us go by the list. The first very important question, I think we can do it very quickly because relatively less controversy. What are the current guidelines for determining when to pursue endovascular, surgical, or medical management for type B aortic dissections? So can you please just quickly highlight the types of type B dissection and our broad decision making?
I mean, to introduce myself, I'm a cardiology guy. So first, see, we generally intervene in patients type B dissection, which is complicated, or having some high risk features.
Before we get there, let's first just for the audience very quickly, what is the type? What is complicated? What is uncomplicated?
Yeah. So see, wherever there is a rupture, so and our indicators of rupture, and next is having malperfusion syndrome. So having either visceral ischemia or lower limb ischemia. And next is the size, more than significant increase in size of the overall aorta. So in these scenarios, it's a complicated aortic dissection. It is better, you intervene fast. Otherwise, if there are any high risk features, then again, we end up in intervening. We are reasonable to intervene. Yeah.
So we're going to come to that. So very basically, I think we'll all agree that the most guidelines talk about complicated means a malperfusion or a rupture. We will come across the high risk features in a second. But for a acute complicated type B dissection, the standard of care is TEVAR unless the anatomy is contradictory. If the anatomy is suitable for TEVAR, then it should be TEVAR. If there are few exceptions, the anatomy is not suitable in collagen vascular diseases, then there should be increased consideration for surgery. If the patient is young and fit, then more consideration towards surgery. If the patient is older and more morbidity, more consideration towards endovascular. For an uncomplicated type B dissection, the standard of care still is optimal medical management, although that idea is changing. We'll come to that. The idea is changing. And one thing that is sort of a little bit uncovered is the concept of that non-A, non-B dissection. Where do they actually fall? Can you just, can you please talk to us about what is non-A, non-B dissection?
The classical.
Oh, there is a separate discussion.
Yeah.
Okay, we'll
Here, about the medical treatment, majority of the patients are initially treated medically, which includes
for uncomplicated.
Uncomplicated. Unless the patient at the time of presentation itself presents with aneurysm, which is larger than 5 centimeters. Even there is a controversy.
Correct.
Each guideline mentions a different diameter.
Correct. Between 5 and 6.
Yeah.
Yeah.
So initial presentation itself, the total aortic diameter is more than 5 centimeters. Or there is hematoma, that it is leaking, and pleural effusion, not just effusion, it's
Hemorrhagic pleural effusion.
Persistent pain, uncontrolled hypertension, all these are considered as indications for, they will also come in the high risk group.
So we'll do that. So the first statement is complicated, which means malperfusion or rupture. That is in the high risk group. So
aneurysm size.
So an aneurysm size that goes for if it is an acute presentation TEVAR, unless surgically, unless the anatomy is contraindicated.
Regarding surgery, it is now well proved that the results of surgery are inferior to
in acute complicated type B dissection. Right.
So
okay, so the rest
of surgery is coming down and down.
Yeah. So the rest of the patients are going to be treated medically unless there are some high risk features. We'll discuss that. So can I just quickly ask you that what is the medical management?
The control of pressures and the heart rate, and the immediate infusion has to be given with a blockade, and this one sometimes.
What is the level of control that you want to achieve? Like a diastolic pressure, systolic pressure?
As per the one meta-analysis and one more this SVS guidelines is 120 should be your target, and heart rate less than 70.
The map it says So same meta-analysis should be between 60 to 70.
This regime of anti.
Now hearing a lot of, like malperfusion. What is the hemodynamic criteria of malperfusion in the subsets of limb malperfusion and visceral malperfusion? How do you define malperfusion in the visceral vessel and the limb arteries? So the hemodynamic criteria.
I don't think there is a hemodynamic criteria. It's symptomatic and how the malperfusion is
Malperfusion
symptomatic.
is a spectrum.
Sir,
You
like
can
for
have
example,
limb ischemia, you can have limb gangrene.
No, sir, limb
Greater.
ischemia, acute limb ischemia has a classification class 1, 2, and 3. Class 1 ischemia is just a less flow, but patient is having both motor and sensory is intact. Those patients we don't immediately intervene. So everything has a clinical criteria. There is no hemodynamic criteria for all of these malperfusions.
Well,
For example,
there are certain groups which have studied and made a hemodynamic criteria, especially in Atlanta, Georgia, when they directly cannulate the superior mesenteric artery and they see the systolic pressure. So if the systolic pressure is, let's say, 90 and the mesenteric pressure is 50, it's a clear-cut case of malperfusion. The criteria which is set is 15 millimeters of mercury. If the difference between the systolic pressure and the visceral vessel pressure is 15, then it is a malperfusion. Similarly, in cardiac surgery, radiology.
For subclinical ischemia.
No, direct measurement. So while doing fenestration, when they cannulate the SMA for stenting, they measured the SMA pressure.
No, but that is, you have already decided on the stenting. So,
Yeah.
but the decision here is one step before. Is that
clinical?
Where, yeah, because I think vast majority of us would practice clinical grounds, which is like you said, the types of acute limb ischemia. Mesenteric ischemia is like we have discussed in the previous session in terms of, clinical lactemia, abdominal pain, postprandial pain, all of those things.
Clinically, let's say the systolic pressure is 100 in the upper limb and the lower limb is 90. Would it be considered as a malperfusion?
No, sir. So lower limb, it's very clear. Is as for the Rutherford classification, if it is class 2B, it has to be intervened. And class 2A and 1 is
we
medical
can manage conservative.
There's no confusion.
So
in
it's
that,
clinical
as far as the limb is concerned.
Yeah, so this is where I think it's a very important point what Dr. Prashant said with regards to visceral. I think you were talking about FFR as well. So even if you use a 4 French catheter and measure a 4 French catheter to measure the systemic pressure within the aorta and the mid SMA distal to the ostium about 2, and if there's a significant difference of 15 mmHg, then it's certainly something which you have to consider that you have to treat it. So even you can use ultrasound of the SMA and look at the peak systolic velocity.
No, sir, sometimes we have to treat the patient rather than the images.
No, but that might be too. But my question that
hepatic artery.
This and all you already have.
But we are coming to we'll come to the question of radiological versus clinical, subclinical malperfusion. We'll come to that in a second. But what I'm saying is about the first question was, what are the guidelines? The guidelines clearly state that it's only malperfusion and rupture and 5.5 centimeter. That's the guidance.
I know, but the question there was, how would you define malperfusion?
It is clinical.
Clinical only, sir.
So clinical malperfusion, how do we
Means the patient is complaining of abdominal pain.
Yeah, postprandial abdominal pain. And or abdominal tenderness, rigidity, lactemia, bowel sound reduction.
Yeah. But if the patient is complaining of abdominal pain in the situation of aortic bypass, it should consider malperfusion and investigate further.
Yeah. So the investigation might include a CT scan. It might include what you described as, a catheter intervention to look at pressures. But the first judgment to whether you should do anything is clinical. I think that is the summary. Okay.
And I think one more point to add on that very important is blood gas analysis. It is not necessary the patient will have frank symptoms and we cannot go back and treat. These are the early features: decrease in urine output, increase in the creatinine, and uncontrollable hypertension. All these are sinister findings of malperfusion.
My question there is, isn't that too late? I mean, why are we waiting for it? This is my question. Isn't that too late?
So I have a point to make. I think Dr. Rohit has a point in that malperfusion
and malperfusion syndrome are
Yeah,
two different things.
two different things.
So malperfusion syndrome is when clinical presentation happens. But there is a potential that the patient may be in this window where malperfusion could happen.
So I will
So-
give a clear, like most
No.
of the time, left renal artery will be from the false lumen.
Yeah.
When you take a CT, left renal artery will have hyperperfusion compared to the right in the CT, in the plain arterial phase. Do you say this is a malperfusion?
No, not that.
Clinically, it won't.
Exactly, I do agree.
Low flow does not mean patient is going to have a symptom. That's what we want to say.
No,
So
that's
don't go behind the
No, that's
images.
true. But when it comes to renal and limb, I think we can buy time. But the bowel sometimes doesn't forgive. So if there is something that
I think
is a very
Pradeep and
forgiving
George.
thing. Renal malformation, it's a paired organ. So,
So,
even
okay.
if the whole kidney is knocked down,
I think we have to move on as well. So Pradeep, quick point.
I think we are not getting confused between acute TBAID versus chronic TBAID here. I think that is what.
No, this is only acute TBAID we're talking.
So, I had a patient referred to me from Chennai with a type B acute dissection and with abdominal pain. So very mild, very, not the typical pain, that's very mild. So gas is normal, pH normal, CT scan normal, everything normal. And we did a regular repair, and this patient never recovered. I mean, never did well, never could eat properly. Then finally, we said we just have to open and see, and he had florid gangrene. So these signs and things are.
We
all
discussed
getting-
that. We discussed that a little bit earlier about CT. I think for the sake of not repeating it, that it's a question about how you interpret the CT. So let's just move on to another very key topic that all of us just briefly mentioned. That within an uncomplicated type B, what are the high risk features which would make you intervene sooner rather than later? And we all have agreed that the best time, there's now a study showing that the subacute phase is the best time to intervene. But which are the high risk features? Can I ask both of you? Please list the high risk features.
ESBS has clearly a set of 6, I think. So if there is an entry tear in the lesser curvature, the entry tear size more than 10 mm, or initial diameter of overall diameter of aorta is more than 40, then if the pleural effusion harmful freeness corresponds to blood. And
most important first two are ongoing pain,
uncontrolled hypertension,
and also failure to control hypertension. Yeah. So standard medical management has failed to reduce BP less than 120. There is ongoing pain. Again, it is slightly debatable at what time, 48 hours, 72 hours. So roughly 40 to 72 hours, there is still ongoing pain in spite of moderate anesthesia.
We haven't detailed about what exactly the medical management you have to give to say that you have reached the maximum pain. So most of the patients are not started on morphine opioid infusion. First thing is like you start the patient on beta blocker, IV, and then alpha blocker, start morphine infusion. Most of the patients will settle.
Shuru, one question. Does partial thrombosis of the false lumen indicate a complicated TBAC?
So there is a study about these partially thrombosed false lumen, which then turn out to become aneurysmal false lumen camera. So that is being considered. If you look at the 2024 as well, ESC, they have said that as one of the high risk features. So as what Dr. Simulation said, along with the other features, 22 mm false lumen, 40 mm aortic total lumen, along with that partially thrombosed false lumen is a indicator for high risk.
So a couple of more. I'm just reading from what I had just prepared. So refractory pain, refractory hypertension, bloody pleural effusion, aortic diameter more than 40, radiographic only malperfusion. What we were discussing comes into high risk. So it does not come into complicated, but it comes into high risk uncomplicated. Radiographic only malperfusion, readmission. That is an important criteria. If the patient is being readmitted, entry tear, you have already said. So this is part of the character. And false lumen diameter more than 22 millimeter. So that is another one. So these are the criteria for which there is now increasing evidence that there should be intervention.
And additionally, would you consider the ratio of diameter of true lumen and false lumen?
the ratio of a diameter of true lumen to false lumen.
So
if let's say,
narrower
yeah,
the true lumen, wider the false lumen.
yeah,
you shouldn't do. So that is also indirectly
Invariably,
radiographic malperfusion. So basically what happens is we see these cases whereby the true lumen is so chinky that you have some clinical manifestation. Clinically, practically, I mean, you guys do a lot more than what we as IRs do. The difficulty in this classification is, for example, pain is a subjective symptom. And to use pain as a criteria to say that this is now a high risk, uncomplicated, is clinically not so easy. Are there any firm objective characteristics that you guys use to classify pain? You have already highlighted that morphine, post-morphine, but are there any criteria? Is there a
Generally, clinical practice, what we see, blood pressure is not controlled, the pain doesn't get controlled.
Okay.
If blood pressure gets controlled, the pain usually will come down.
I'm going to make one controversial statement here. I mean, I wouldn't say controversial because I strongly believe in that and I have practiced it and I am quite happy about it. See, what is the cause for IMH and dissection? What is the age of the patients that we see? Do we see what we see in the West? We see younger patients. Many of them do not have atherosclerotic features. Why the hell are they developing dissection? See, in many of our peripheral vascular disease, we have seen there is an element of inflammation in them. There are times when we are done stenting for the legs and they come with thrombosis and you give them steroid, the whole thing resolves. So there is an element of inflammation in these patients. I strongly believe this dissection and IMH in our patients, younger fellows who have never been hypertensive earlier, they would have, it is some people never checked and they found to be hypertensive at the time of presentation. But some of the chaps who have already known that they have never had hypertension, now they have hypertension and they're coming with dissection or IMH. And you look at their inflammatory markers, they're quite high. I routinely put them on steroids. The pain disappears. Even if we have to intervene, we have got a time of 2 weeks, 3 weeks time to intervene, by which time the inflammation subsides. We are quite happy to put the TIVA there, and there is no question of developing sign and other complications that are usually associated with TIVA. I'm in the process of collecting.
Agreed, sir. Uniformly.
Inflammatory markers before starting
CRP,
steroids.
yes.
And what
CRP
markers do you check?
CRP and ESR.
Yeah.
See, what is the cutoff for your CRP to start steroid?
We see CRP at least 20.
See, so because that is one of the things Dr. Bhan also mentioned.
Yeah.
If CRP is high, the results seem to be poor.
The same thing only we have published in the mesenteric artery dissection, which is going to be published in Journal of Vascular Surgery soon. A lot of questions were asked to me, why you're now doing this, that, but I managed to convince them, they've accepted and they're going to be published. See, in the all collection, even in, you see, the dissection is most common in Asian countries, especially the superior mesenteric artery dissection. And all of them have reported more than 36% of them have high inflammatory markers. They have not analyzed that. They have not analyzed. One of the objections raised was, why can't it be due to the inflammation caused by the dissection? Yes, it can be. No doubt about that.
So which period do you give the steroid and how long do you give
Immediately.
it for?
As soon as the patient comes, you do the inflammatory marker. If it is high for IMH and acute dissection, when they do not have other features of atherosclerosis, I put them on steroid. It's around 0.5 milligram. Initially, if they're having a lot of pain, I give Solumedrol and followed it up with oral steroid. All of them, the pain subsides very quickly.
And that allows you to delay your procedure through the subacute phase.
Yes.
Okay. So I think that's a very fantastic new message that to consider doing CRP, Rochan.
That said, steroid is also used for pain relief as such, especially in oncology. So if pain goes away, that's a very good thing. If steroid works, great. But are there contraindications to steroid use in this situation? That can be a question.
Yeah, I have one concern here. See, generally, we accept that, steroid would delay healing process, delay fibrosis happening, in the process of healing. How does that going to affect, in this typical part of body aorta? Because if it affects healing process, then
If you're going to do open surgery, I agree, it may delay. But anyway, that's not an absolute contract.
About conservative treatment added with steroid.
And we know in iatroarthritis patient comes with the symptomatic state, we routinely put them on immunosuppressant and it subsides. It subsides.
I think it's a great point. We have covered actually the middle portion of what Dr. P.C. Gupta had written first. So let's quickly go back to the first portion. We have covered the guidelines. Now, this is an interesting point. I mean, you've got our industry colleagues outside and with some fantastic new devices on show. So what are the advancements in TVAR technique and devices that you think might change this decision making? I think Dr. George Joseph, how I outlined what he talked about in type A applies very much to type B too. Just one basic concept that we need to talk about is, although we had discussed to limit type A repair to the life-saving, minimally invasive surgery or the least surgery, but it is also important to understand that the arch is the common shaking hand zone for the surgeon and the the TVAR person. Okay, so and that is important because of issues about the angulation, the bird beaking, and no device can be stable at that angle. So there should be, from the TVAR point of view, a tendency to go more into the horizontal transverse portion of the arch, whichever way it is possible, whether it is debranching or fenestration or parallel grafts, whichever way it is possible. So can I just raise this question about, we'll talk about the new devices coming, but before that, do you agree with the principle that TVAR, that the standard TVAR description of zone 4, just zone 3 deployment, post-ductal zone 3 deployment should change now to at least encroaching onto the transverse arch?
Absolutely. So I like Dr. Shekhar said, he said something controversial, but which he believes. I have a similar thing about type B dissection. Now, if there is type B dissection and the ascending aorta is 40 millimeters, that ascending is not a normal ascending. And this is a situation where if you did a zone 2 or 3 repair, you have a high chance of retrograde type A dissection. So in these situations, we actually start zone 0 and we start as close to the ST junction as possible. Now, you may ask, why do we do that? First is the entire ascending is covered. So you cannot have a retrograde A. All you can have is a focal dissection at the proximal end of that endograft. So we have experienced that in like 6 patients, this focal dissection.
This is because of the barbs.
There are no barbs, it's just a free flow.
Because of the
free flow digging into the wall. 4 of these were just incidentally detected at 6 months follow-up. And 2 of them, they presented to us without a catastrophic presentation. Usually retrograde A is catastrophic. They 40% die almost immediately. And so this is a very, very milder version of a dissection, if at all it happens. And in all these, we sent for surgery and they did a simple root replacement, anastomose their graft to our endograft, and the patients did well. So, whereas earlier to this, we had 3 retrograde type A's, all 3 died, where we did a zone 2 or zone 3 repair. And all of them had fairly dilated ascending aorta, 38, 40, 42.
So, Rohit, what is the biggest graft you would like to put in the ascending aorta? So, because 40 millimeter ascending aorta, there are a lot of studies that ascending aorta more than 37 millimeter should be replaced actually, if you want to put an endograft in.
So we have put up to 44. So when we had a 40, 42 ascending, we have put a 44 up to the ST junction. Some of them are doing well. The root and all doing fine. 1 or 2 had this, what I said, a proximal edge dissection on the outer curve, which had to go for surgery.
Actually,
so we've seen some of these coming back
aorta
with
is
indolete.
indexed to the body size. Let's say the body surface area of this patient is 1.5, 1.3. That will be aneurysm. It will be called aneurysm along with the endograft.
I think the guideline clearly says if you have an ascending 4.5 or more, it's an indication for a FET.
Right.
I think landing a 45 endograft.
So let us not cover that area which has already been covered.
No, type B.
Type B. So
if you have an ascending, because he made a point in the dilated ascending aorta.
Yeah.
So I think that's a surgical candidate. I'm not going to fetch.
Yeah,
It's a
yeah,
surgical-
okay, sure. So
The question I want to ask was, so would you be using, you're talking about non-bare metal stent or with a bare metal when you're going down?
It's either the Valiant.
About the, is there a non-bare metal component? No, right? Or you're using a non-bare?
Valiant has a bare metal ring.
Then the
Both closed web and free flow are there.
So this is where I wanted to ask about this.
Valiant has both closed web and free flow versions. Are you using the complete PTFE or using the
Valiant Captiva?
Captiva is the one with the.
With the short non-bare. So that's what I wanted to ask you. Isn't the chance of retrograde dissection more when you have a non-bare metal component in zone 0? You understand? So if you are landing, I'm just asking you. Just
We have
testing of
covered the whole zone 0. We are at the ST junction.
Yeah,
so there is only the root left.
So but the non-bare metal will be against the root.
Yeah. So on the inner curve, the free flow actually crosses the ST into the root. On the outer curve, because of that slant, it's a little up.
So I think that is whilst.
Artery, if even there is a small dissection, it will dissect the coronary artery.
It's a very
STJ and coronary artery is not very much.
It's a very large stent there, 44 or something. You got no options after that other than to open with a stent in place. So we've seen these patients coming back with endoleak and dilated ascending aorta, and it's a nightmare operating them.
No, see, I beg to differ. I talked to the surgeons who have done our 6 surgeries of this. All of them say it's a very easy procedure. They do a midline sternotomy, they replace the root and a bit of the proximal ascending and put in there either a Bental graft or just a graft, and then they anastomose it to our surgery.
Why not do it as the first procedure?
Yeah, okay, you can do that. I mean, if you
I
want.
mean, if some surgeon can do this, removing the stent graft, it should have been as the first procedure rather than putting a
Stent graft
44.
is not removed. Stent graft is not removed.
I think, to be honest, I think
very good logic.
See, the point that George has raised is valid. That is, in a patient with type B dissection, if he has an ascending aorta dilated,
that has to be.
it is not enough just to cover the dissection.
So the point is that it
You
has
have
to
do
be
something for
treated.
the ascending.
It has to be dealt with.
Whether it is open
Right.
or no, it's
It has to be
different.
dealt. Right. So the basic principle that we are as a group are agreeing on is that the days of only a type B dissection to only cover distal to subclavian should be passed because the arch is still an abnormal area, and we should try to encroach or extend as far as practically possible with our available expertise. Depending upon.
I think
Would you do if a patient has only, let us say, 1 centimeter from the subclavian? Would you intentionally cover the carotid also?
So this is what I'm trying to say is this, the principle is that if you look at all the long-term studies of the old-fashioned TVAR of distal to subclavian deployment and all the secondary intervention, the stent graft induced new dissection, and then 15%, 20% re-intervention rate, that I feel you can reduce if you extend your graft proximally, electively, even if it is 1 centimeter distal to the subclavian, to whatever is your nice horizontal part of your graft. If that means that you are having to cover the left carotid and you are having to do a carotid bypass or something like that in a hybrid setting, or a FEN if it is Dr. George Joseph or Girish, it's okay, whatever way you want to do. But principle I'm saying is that the arch, the transverse part of the arch should be your area of entry, even in a type B dissection, which is in zone 3.
So most of this type B, if you look at the CT scans, you always find some hematoma up to the.
This is what I'm saying. So the entry point and the proximal hematoma extends proximally.
Exactly.
You should at least cover. So that is what they call it as non-A, non-B now. So you should at least try to cover to the point where the hematoma extends. So wherever that level is.
The question I think was different. I think there was a different question raised by Dr. George Joseph, which is more valid, I would think. Can we use the Western criteria for the ascending aorta in India should be the question we should ask.
Okay.
But has
I think one thing is that I have operated many Stanford type A dissection with normal size aorta. So what is the criteria with this 40 millimeter? Should I get a patient of 40 millimeter aorta and I prophylactically replace the aorta thinking that it will get dissected?
So we are formulating all our premises, presumptions on only one criteria, which is the diameter, which is not the only diameter. We are not looking at the material characteristics of the aorta, the length of the aorta. Let's say, for example, from Germany, one group said the absolute length of aorta from the plane of the annulus to the brachiocephalic trunk, if it is more than 11 centimeter, there is a lot of shear forces on the greater curvature of aorta. So why should we base every decision like extension of a stent graft, zone 0 beyond at the STJ based on only simple criteria of 40 millimeter?
Okay, can we move on, please, because we cannot answer all the questions.
Yes. No, there is no answer for that. I mean, I fully agree with that.
No, there is a guideline saying of the aortic height index. It's published.
That is
what Prashant said.
that is 11 centimeter. That is
Correct.
that's
Yeah.
yeah.
No, not 11. It is the
No.
aortic maximum diameter to the height of the individual. It is
Sure
not
that-
to the size. BSA is, girth. This is purely height. AHI. If it is more than 10, it's an indication for intervention.
It's equivalent to the aortic index.
Yeah, 2.9 is the cutoff.
So we haven't touched on the question that I put forward to the panel, that what are the devices, the new devices that are coming through? Would that change our strategy of covering the arch and doing more hybrid procedures or more completely endovascular procedure because of the new devices that are coming through? Yes or no? Yes or no?
Or dissection type B.
For type B, I'm talking about.
I think it'll be case to case, but yes, we will do more endovascular as I see it.
So dissections, we have to
No,
take
he's
care of
asking for
both
newer
the,
devices and different techniques.
so,
See, like,
in a type B dissection, we have to take care of both the proximal and distal. So the advancement is proximal as you go more. Like I agree with Dr. George. We also go as much like we never take a zone 2. We always go zone 1 or zone 0 for type B dissections. That's for a proximal. Distal, like how much we have to.
So, so we'll come to that. So I think you also mentioned, so
advancement for distal, like there is a petticoat technique.
we'll come to that. We'll come to that.
That's it.
Yeah.
All those.
So the advancements in terms of so one thing is very plain now with the recent evidence is that false lumen obliteration is the goal, right? Not just increasing flow in the true lumen, false lumen obliteration. So the false lumen obliteration techniques, can you please talk about that?
Yes, it's a false lumen. Now we have a petticoat, stabilized, Knickerbocker technique. So many techniques are there. That is best done if you are in the subacute phase, like when the intima is more pliable. So you put an uncovered stent beyond the proximal is petticoat. Stabilize, you try to balloon it and same Knickerbocker, same techniques. But of course, it has to be done in the very safe, and otherwise there is chance of rupture of aorta. And routinely should be done. That is the question. Whether it should only address the intimal and come back, or should we routinely?
So should it be done, and also should it be done at the primary procedure or should it be done at the secondary procedure? Can we just have a discussion on that?
1 minute before we do that. See, I think George routinely covers the entire thoracic aorta right up to the celiac artery. So I don't know how many people would agree to that. Always with a covered stent. The other option is to put a badge stent. You cover the leak part and remaining part you put a badge stent. So these are the two options. I think we should discuss on that.
So, so regarding the length of coverage, okay. So firstly, regarding the minimum coverage should be 150 millimeter, because less than 150 millimeter, there is a high risk of sign, which is stent graft induced new entry point. No?
I have one question for the George's concept of covering up to celiac and erosions are also. Like in aneurysm, because of the mural thrombus, most of the spinal circulation would have been occluded. In a dissection setting, most of them will be patent. And is there theoretically, practically, I'm sure it is not there. That's why you continue to do. Theoretically, the spinal cord ischemia is more in covering up to celiac.
Great. We've actually thought about this a lot. Now, there is a difference between aneurysm and dissection as far as spinal cord ischemia goes. In a dissection, some of the intercostals take off from the false lumen. When it tears like that, it's very unusual that all the intercostals are from the true. Some of them do come from the false. And when you finish a repair up to the celiac, you always have some retrograde flow going up the false. So there is always some spinal cord blood supply that is preserved, enough to prevent paraplegia. Whereas in an aneurysm, that's not the case. You are completely seal on top, seal below, nothing should go into the aneurysm. So maybe that is why we don't see paraplegia in type B dissection.
Another thing is how aggressively we should chase the re-entry tails below the celiac and when to address them.
So below the celiac is we just observe yearly with CT. Only if the total aortic diameter is increasing or the falls is expanding, only then we do a completion repair going down to the iliacs. Otherwise, we just observe. So there's no need to.
So length of coverage summary.
But one question about the length of coverage. Should we do it in one step, or we can also stage it and do it in 2 steps?
So
Is there any opinion from the house?
So the plus side of the minus side is that if you have not just cost, also not just cost, also if you have got a groin open for the first procedure, and if you are not going to do a percutaneous technique, then another groin opening is a counterproductive thought process. But you're firstly as
cover and back.
So we haven't talked. Firstly, can we just concur on the length of coverage? Provided subclavian is patent and provided celiac is patent, I think as coverage of the whole of the descending aorta gives better results. I think there is quite a lot of evidence in favor of that. We can concur on this point. Regarding, sorry, yes.
Type B open surgery is rarely performed now.
Except in chronic dissection.
सुनो तो सही. तो उसमें aneurysm में we had to implant the spinal. In dissection we didn't bother about it. So आप लंबा celiac तक आओ कोई तकलीफ नहीं होएगा.
ये आपका पहले का experience है. We know this. Okay. So I think that is also borne out by the clinical results that dissections do not give rise to that much spinal ischemia. So whilst we are on that topic, can we quickly summarize, guys, about the best medical management strategy to reduce spinal ischemia during an aortic type B dissection procedure? Surgery or TIVA? Can we please quickly summarize?
So, like, what are the things we do, or what are the indications?
You have 19 minutes, then we have an online talk.
Yes, so we'll have to start.
So basically, when we are planning to cover from subclavian to celiac, our institute, we always put a CSF drain. We give 1 shot of methylprednisolone 30 milligram per kg, and we extubate on table. If there is any weaknesses there, we continue infusion for 2 more days. Keep the mean pressure high, keep the CSF pressure low. These are the major things.
So this
subclavian should be intact. Subclavian should be preserved.
So you have summarized very nicely. Thank you. So subclavian celiac, keep the blood pressure high after the deployment has been done. Keep the MAP above 70 or 75, and prophylactic drainage is controversial because there are papers to suggest that there is a 6% serious complication rate of just the.
No, sir. If you see a patient not waking up with the paraplegia, I think you won't take a risk again. Awake patient not moving is worse than a patient who's dead, I will say.
No. See,
paraplegic patients are very painful to manage.
For surgery, there is
no, sir. I accept that. Even you are spending 10 lakhs for a patient for a TIVA. If you have very good anesthesia, again, it is not in our hands. Anesthesia dedicated team who can put a very safe CSF drain. I don't think there is a risk to take.
There is an important point to make.
Do you have motor evoke potential there? You do monitor? Okay.
So there is one important point. See, the CSF drainage is not innocuous. We have had 3 cases.
6.8.
Where one was day 3. Day 3, patient doing fine, procedure fine. I'm ambulating the patient. He develops an intracranial bleed. Okay, the other one, day 8, post-op, almost discharged. He developed a subdural hematoma. Now, this is the long term.
And also hypotension.
Yeah.
See, the hypotension that happens with CSF bleed increases the spinal ischemia. So you have hit the nail on the head by saying that you have to have a dedicated anesthesia team who is able to do this very, very smoothly, because it is not without its complications. So as a discussion point, we have to say that we cannot say that it is universal recommendation to put a CSF drainage. CSF drainage, you do it when you diagnose as early as possible paraparesis, you must do. But to do it routinely for every case is controversial. It is not a... Yeah. Absolutely not. Yeah, absolutely. Rohit, you're saying that.
After paraplegia, nothing we can do, sir.
No, no, no. Actually,
Once
actually
paraplegia
that's
happens, nothing we can
not
do, sir.
completely true.
No, sir.
Three
Paraplegia.
cases of paraplegia
Yes,
in
sir,
my
it may be
experience.
paraparesis.
Two of them paraparesis. But why is saying paraplegia until you have tried to treat it?
No, sir.
See,
Paraplegia.
patient wakes up with paraparesis or paraplegia, whichever it is. Out of 3 patients,
Yes,
2
sir.
recovered completely. One was the problem here is age of the patient. Moment you have a patient who is 70 and above, his chances of recovery are very low. With younger patients, they are better. But the data suggests that putting a prophylactic drain does not reduce the incidence of paraplegia. That's the problem.
No, but you know, if it's very simple. If it's a cardiac anesthetist or a vascular anesthetist in our institution, like Dr. Shivanesh said, we put in routinely because they are very small catheters. They are done expertly well. Spinal perfusion pressure of more than 70, CSF pressure less than 10, and we start on naloxone. We give methylprednisolone as well. So all that, it has not resulted in any complications.
So that is okay, Rohit.
But those are not small catheters.
No, but no, there are very tiny catheters.
If they are very tiny catheters, we will drain enough.
So PC, I think we've covered spinal ischemia.
The study was based on 4.4 French catheters. I think the study has to be redone.
Rohit, it is still controversial. I think. Can I just come to a very important question? What are the tips in TVAR? And I'm looking at you. What are the tips in TVAR that we can use to make the procedure smoother? The technical tips whilst doing the TVAR to make the procedure better or to do cases that cannot be done. So one is, for example, he shows all the time about the transcaval when the access vessels are small.
Those are all very rare situations.
No, but
no, there's an important point we missed so far. The sign, you were mentioning sign.
I'll come to sign.
Oh, you're coming?
Sign is a question. Sign is a question. Next is.
Okay.
So can I quickly ask about anybody's, all experienced guys, things that you do which is not routine in terms of technical tips of doing a TVAR, executing a TVAR well?
Yeah, it's basically in our center, we always do with intravascular ultrasound.
Okay.
So that's one thing. So with intravascular ultrasound, so I can quote few, things where it makes your procedure more safer and more predictable. Let's say most of the patients, this dissection goes down into iliacs and femorals. So when you're doing a femoral puncture, you can do puncture also with IVUS.
So we have already covered that. So to remain in the true lumen.
Yeah, and remaining in the true lumen.
Okay.
And
So
next,
what else?
if you're doing fenestration also, let's say that patient, you want to do a fenestration instead of stent grafting, or sometimes after putting a stent graft, you end up in, doing a transaction, and finally you end up in again false lumen flow going back. Then we'll do a fenestration. So even for fenestration, we can do IVUS guided. It makes it much, predictable, and your chances of complications will be very less.
Okay, so I mean, it's not a very routine practice for most aortic surgeons to use IVUS, but IVUS obviously will have its role. But to be honest, if you use a DSA really well, and if you understand fluoroscopy really well, then personally, I think that if you look at your CT incredibly well beforehand, then a lot of the roles of IVUS can be replaced. So quickly moving on about tips, are you going to talk about tips?
There is one thing about, it merges with the prevention of sign. See, in a dissection, you want to start proximally just a little bigger than the aorta. So we don't want to oversize like 15, 20%, 5%. Whereas distally, we want to end as small as possible. So very difficult to know what is the normal distal, because you'll have a big false lumen and a totally squashed true lumen. So how do you know what should be the normal size? So we go by the smallest available graft, which is 22 millimeters. Okay, so we use the Cook tapered dissection graft. It's called ZDEG. There's 8 mm taper. So if you end 22, you start at 30, you start at 32 and end 24. So that is the smallest. So by ending smallest, your chance of sign is the least. Whereas if you use a cylindrical graft like 32, then that 32 will keep pushing that intima and a flap and cause a sign down the leg.
So we might as well cover sign. So thank you very much, Dr. Joy. George, but basically sign can be proximal, can be distal. So we were talking about distal sign, and in the setting of distal sign, tapering is a good idea. Distal first is a good idea if you're going to use two devices, because then the smaller graft first and then a larger graft inside that would automatically give you a taper. The sign literature talks about a 15 millimeter drop from the top to the bottom to prevent sign. There's a prospective study. No, by using two devices. By using two devices to drop by, that they're talking about dropping 15 millimeter to reduce sign. And that is, there are papers on that. And the other important point is, obviously,
Regarding the tips for this one, I just want a feedback from the people who have done more cases, like Roshan and George sir. Like, is it a routine, you being a cardiologist, you'll be using pacing possibly for all the TIVAs? No.
Not for zone 3 and zone 2.
No, zone 0. Zone 0 and...
Zero, yeah, absolutely. Zone 0 without...
Any tips on reducing bird beaking? So any tips on reducing bird?
Yeah, there's only one tip: start more proximal.
So more in the horizontal segment.
So just on that context for bird beaking, so if we tend to, one thing we can preempt about these cases are, if you've got a very steep aortic arch and you think you have to get the stent across that steep aortic arch to land, so for that you would be taking a brachial access on that. That tips for no. What would you do?
If you are going into zone 0, brachial access of no use. You need to have your guide wire in
No, I'm talking like, like for us, normal human beings, when we land in zone 2, what would you, I mean, if you want to land in zone 2, what would you say? I mean, if it's a steep aortic arch, let us say for some reason we're landing in zone 2.
We found that if you've got your wire nicely in especially into the LV, the Lundquist wire, you've got enough support even for Gothic arch.
So you don't need a through and through.
So brachial access and pull through, you mean through and through?
That is traumatic, and there is some risk of artery trauma.
Cheese wiring this. Okay.
About sign, I think one of the literature just reading, the incidence of repeating the same problem, complication sign after correcting the sign is still quite high. Around 15 to 20%.
Only 65% is corrected by adopting all these techniques. Yeah. So sign is, see again, so that brings down to one of the questions is the surveillance strategy. Can I quickly ask you about somebody that you have decided to treat conservatively, uncomplicated? What is your first CT scan time, re-CT scan? Thank you, Gurish. No, so patient has already presented to you. You have done your CT scan, it's uncomplicated, you're treating best medical therapy, OMT. What point do you do your first CT scan? Yeah, second CT scan.
So we institute 6th week. At 6 weeks, 1 CT, 3 months, 6 months, 1 year, and yearly CT, sir. We have a very good follow-up. Because again, sir, like I'm working in a government setup where once a patient has a reduction in pain, you cannot convince them to do a major procedure again. So that's why we go for open, mostly medical management. And we have around 56 patients in our registry. They are all doing fine. This is our protocol: 6, 3, 6 months, 1 year, and yearly.
So the Instead Excel and the Absorb both showed that over a period of 5 years, aorta-related mortality is lower if you intervene at the subacute stage. So one strategy that you could adopt is to do a CT at about day 7 to look at the risk factors, the additional risk factors, including radiological malperfusion syndromes, etc., which might tempt you to do the procedure sooner. Dr. Fujikawa, any comments? Yeah. For surveillance in an uncomplicated type B, imaging surveillance, what is your protocol? Uncomplicated type B, you're treating conservatively on best medical therapy. What is your surveillance strategy?
Just only CT scan or sometimes echo. Transstruct echo is also possible. So
what interval?
It depends on the size. Normally, when I was in Japan, after the onset of dissection, 3 months time, 6 months time, and 1 year afterward, every year.
So, but with the idea of intervening on uncomplicated type B more frequently because of the long-term aortic mortality. Has that changed? That what you described was the old way of imaging, but has it changed now that there should be an increasing trend to intervene?
Actually, if the size is reached to more than 55 millimeter, we just intervene. So I don't think earlier investigation may not change the result. What change the result of patient long-term outcome is depending on the intervention quality. So no matter whether it in vascular or open surgery, if we can provide better procedure, patient can get enough survival.
There is a lot of controversy even on the expansion rate. Each guideline mentions a different number. So like increase of one guideline says 4 millimeter, another says 5 millimeter, another says 10 millimeter. I think one of the surgical societies says 10 millimeter. Only then you should intervene. So absolutely no consensus on that.
So on that point, I've got, see, if you look at all the papers, I don't think this uncomplicated or complicated type is as simple as these terms. There are loads of other things. Now, can I ask you something, Dr. Fujigawa, is that when you measure a genetically predisposed patient, would you measure that patient similar to you would measure a normal chronic type B dissection? Because in that patient, the body surface area, the aortic diameter, the contrast enhance, the transcatheter, these are all very important to actually size it properly. But how many people are doing it? So this uncomplicated, complicated, I'm not very sure. I think it is still very mixed term.
So the new guidances are removing this description between uncomplicated and complicated. They're saying that all aortic dissection type B are actually complicated, complicated dissections.
In fact, that INSTEAD trial, although it was INSTEAD Excel trial was an underpowered study, but that 5-year results have shown very clearly.
The 5-year graphs were clearly different.
19% all-cause mortality for this thing versus 11% for the TWAR. So I want to ask just a show of hands for uncomplicated type B dissection, how many of you would manage conservatively? Clear and complicated without Harris features. But why would you do that when you got evidence for 5 years?
So this has to change because this is based on the existing guideline. We are not talking of money here.
No, sir, it is about the experience. Sir.
Yeah.
I am coming from a tertiary care center. We have a lot of aortic work. We have a set of patients. We are following up yearly like this. They are doing definitely well. We come out with our data because we need a little bit more numbers. That's why we have come out with data. We'll give an Indian.
But not just that, INSTEAD Excel also was a small study.
This is for debate. Okay, I'm telling you. Having said that, there's already a large data which is for 5 years.
I will ask another question. I will counteract with another question. How many of your patients with type B dissection you have done a TWAR, you are able to cure the patient? Like patient you have done 100%
point noted and no intervention required.
No additional intervention required. False lumen is completely thrown.
Point noted.
Patient is doing fine. How many patients you have?
So
you give the data and I will give my
that is also to do with where did we do the TWAR from. If you did the TWAR like that, then the number of interventions will reduce. But point taken that
dissections are not curable. So that's what I think. So we will be intervening on those patients lifelong. So if we can save some patients without intervention, that's what we're trying.
But by the time it will be too late. It will be more complicated.
So the IRAD registry is now about 1,400 cases. I think there is a publication that talks about that you should intervene. But his point is also well made that all of this talk we are doing is based on some Swedish data and some this data and you know the INSTEAD Excel was what 57 cases or 70 cases. So it is not like, you know, if we should get what he's saying is that Indian data which are being followed up, and it may be that it is different. So, but all the consensus and the group should talk about is that this is a changing scenario, that there might be more intervention. Sorry, one question I have to ask, Bas. We have to finish this one.
What is the percentage of total false lumen thrombosis? That is another thing we should be covering.
No, I think type B, it's not, I mean, if you've covered down from proximal with no bird beaking come down to celiac, I think it's not. So there are patients we have in follow-up where you don't see the false lumen. after a few years. But at the same time, there are patients where it does not close off.
Yeah.
So to say,
It does.
give a percentage,
It does.
it does close.
It does. Just one quick question. So sorry. In malperfusion syndromes, SMA malperfusion particularly, is the go-to technique just to cover the entry tear or extend it up to the celiac, or is it also to put a device into the true lumen of the SMA? Which is the strategy?
It depends on which one you choose to do first. If you choose to repair the aorta first and you look at the SMA after that, whether you need to put a device. But if you choose to do the SMA first, then you obviously end up putting a device.
And again, it depends on whether the obstruction is dynamic or static. See, if it is dynamic, simple diversion of flow is usually enough. That also we can see with IVs.
Static, then it has to be.
And we will discuss these things later. We need to finish.
We have to finish. So I'm
an
just going to summarize then. No, summary is also done.
No, summary
Okay,
later.
thank you. Thank you very much.
Shabina, you can bring him on. Yeah. Thank you. So sorry to rush you, but we have an online talk now. So we have Professor Diego from Sao Paulo in Brazil, who has done the first in-human endobental, and that he published in 2020. And we have Prashant, who has worked with him. And Dr. George, could you please come up? And Dr. Girish. So welcome, Professor Diego, and thank you for accepting our invitation to deliver this talk. And I think you know Prashant, and Dr. Girish is an interventional radiologist, and Dr. George Joseph is an interventional cardiologist, and actually very keen to do an endobental.
Diego,
good morning,
good
everybody.
morning.
Good morning from Brazil and good afternoon in India.
Diego, good morning. Can you hear us?
Good morning.
I know it's early morning in Sao Paulo.
You.
Very nice to hear news from you, my friend. Hello, do I have my audio?
Professor Diego.
We are not able to hear you clearly. Diego, good morning. How are you?
Good morning. Good morning. I'm fine. Nice to hear news from you, my friend.
Yeah. How is Carolina?
Very good. And the kids also.
And how about the old man in your buffalo? He's alive? Buffalo.
Sorry, again?
Old man buffalo.
Very good. It's very good. He's retired now, but still working with us.
Yeah,
retired from university, but not for the surgeries.
Okay. Okay. I had a great pleasure of introducing Professor Diego Gaia, my old friend of 15 years. And he has performed the first endobental in the world, device which was designed in collaboration with Brelli Biomedica, San Paulo City. And for many of us, they may not be aware, Diego and myself did the first TAVI in India, transapical TAVI. So, Diego, please go on with your talk.
Okay, perfect. Thank you very much.
Thank you.
Do you have my slides? So it's a great honor to be here presenting and to answer this question with will the endobental be the standard repair for type A dissection? This is a very interesting question because the current technology that we have probably is not able to completely solve this problem. If you move back a little bit and look at the actual results of the ascending or hemiarchal treatment in acute type A, we can see that the actual results are not so great. If you look at the series published in the European Heart Journal, we see that mortality can be up to 26%. And many of the patients present with different types of disease besides the entry tier, like 40 to 75% of them present with aortic regurgitation, 20% of them with cardiac tamponade, and 10 to 15% of them with myocardial ischemia or infarction, making the management of this disease extremely complex. And this disease does not end up after the initial surgery in a hospital phase. If you look at the evolution of these patients, we see that a post-op in-house mortality can be very high, around 10 to 20%, even if these patients are operated on an index procedure. So it's a cancer of the aorta. In 2017, Dr. Eric Roselli provided us some insights about the population in the Cleveland Clinic. Among 686 type A dissections, almost 10% of them were considered too risk for open surgery due to dementia, advanced malignancy, severe malperfusion, stroke, advanced age, and many other comorbidities. But when you take a look at the computer tomography of this 10% of the patients, 2/3 of them are potentially coverable by a stent graft. Even if you talk about true aneurysms in combination with root disease or valve disease that demand a bent procedure or valve sparing procedure, mortality can be very high. This is a combination of mortality characteristics for aortic root surgery in North America. And you can see here that mortality can be more than 20% in certain populations, like if it's emergent procedure or previous valve surgery, or if the patient is too old, or with dialysis or other concomitant valve procedures. So the question here is, are the stent grafts able to solve the type A dissection problem? If you look at the anatomy, the zone 0 is a very complex section of the aorta, and it poses unique challenges, especially compared to type B dissections. The curvature of the descending aorta is a very dynamic part. It moves a lot. It's a short length, so the coronary arteries, the brachiocephalic trunk, the AV chemistries are very close to the intra-tear. There's a lot of shear stress, and the hemodynamics is completely different comparing to the more radial flow on the descending aorta. And so at this point, we do not have any tubular stent grafts that meet the clinical need for treating type A aortic dissection. There's no classical landing zone, and the available space that we have to sew the intra-tear is very small. So it's a tough region to deal with. What we need here is a proximal and a distal landing zone that's adequate to sew the intra-tear of type A, and even going further, a device that can deal with the aortic roof and even with the aortic valve at the same time. If you look at this paper published in 2018 by Dr. Krabesh, we see that almost 68% with type A dissections could be potentially treated with an endovascular valve, endovascular stent graft carrying a valve with it. So we have space for a new technology here, but we do not have this device until now. We need a device that is short because of the length of the aorta. The size of the device should be, the nose cone should be very small in order to avoid interference with the aortic valve. We need to deal with the difficulties in the access, if it's transfemoral, transapical, or transcarotid, or transsubclavian. We have to deal with cerebral protection. We have to decide the time to treat this patient with the acute or subacute phase, and also with the presence of an eventually aortic insufficiency. If you look at some publishes, here we see that most of the evidence that we have used thoracic stent grafts for the descending aorta on the ascending abdominal cuffs or custom-made devices. This is not a new idea. Our first publication in 2008 to treat type A aortic dissections proved that in the chronic setting, if the intra-tear is on the midsection of the ascending aorta, it is possible to treat that segment with a thoracic stent graft. And planning a case like that is very complex. You need to take the computer tomography, make a prototype, design a custom prosthesis, do 3D printing of the aorta of the patients, do a 3D model fluoro test in a very short time frame because the type A aortic dissections. But when you could achieve that, results could be like that. A patient that had a previous type A dissections, a chronic patients with involvement of the arch vessels that were able to be treated with a completely custom device, treating the ascending aorta and the three vessels at the same time. Here is a prosthesis that was made in a partnership of the Briley Biomedical, the university that Dr. Prashant previous comment on. Of course, you can also use abdominal cuffs for that. So if you have an entry tier that is near to the brachiocephalic trunk and the diameter of the aorta at this segment is not so dilated, we can put a stent graft there using most of the time an axillary approach because the abdominal cuffs are not long enough to come from the femoral artery. And this is another example from our group that was treated successfully in a type A dissection. Of course, you can go further in this type of treatment. This is a chronic procedure, a previous AV replacement, a remaining dissection in the roof, and a Dacron tub up to the ascending aorta. And here we had some ischemia on the right coronary artery, so decided to put a stent on the right and then put a vascular plug to close the entry tier on the roof, and then embolization coils, completely treating this chronic root type A dissection with a previous AV valve. If you move on, we can also treat other patients that are very complex. This is a patient with a huge rupture of the ascending aorta with a previous mechanical valve on the aortic position. So we protect the coronary arteries and we deploy another abdominal cuff on the ascending aorta, completely covering the entry tier on the ascending aorta. So when you look back at the publications around the treatment of the zone 0 using an endovascular approach, the results are very conflicting, especially on the long-term follow-up. If you look at these patients on the follow-up, you see that even if you close the initial intertier, the cumulative survival in 150 months are just above 50%. And we have a significant type 1 endolic retrograde dissections on the follow-up. So even if you close the intertier and if you do not treat the roof and the valve at the same time, the patients keep dying. So in order to try to provide a dedicated device, the Gore proposed a prosthesis that was specially designed for the ascending aorta that accommodates better on the ascending aorta, respects the curvature of the ascending aorta, have long shafts, and these are the main inclusion criteria for the Gore RISE trial. The primary anterior must be in the ascending aorta, especially more than 2 centimeters distal to the most distal coronary ostia. But when you look at the initial results of the RISE trial, you see that MACE occurred in 15% of the patients, 5% of disabling stroke, and 5% of myocardial infarction. So this is still not a perfect treatment. If you look at this meta-analysis of the endovascular treatment of type A dissections, we see that in 311 patients using Cook device, Medtronic device, and Gore devices, overall freedom from intervention is just around 70%. And the index of late complications are 16% on the long-term follow-up, but we need to take a look at the number at risk, especially after 108 months are very low. So patients on the follow-up do not go so well. So the possibility of combining the valve technologies, the transcatheter valve technologies, and the aortic stent grafts in order to mimic the bento procedure or any other type of root procedure, what we call the endobento, there's a great opportunity to improve the results of the endovascular treatment of type A dissections. And these are initial scratches of what we did there. This is not so new idea. Rilsky in 2014 published a composite graft, but the coronary arteries were not addressed. So the root is still perfused and we still have a lot of risks. Of course, there's a lot of drawbacks to overcome in order to perform the endobento, like the risk of endoleak, migration, embolic, femoral access problems, axial adjustments. We have to do to the aortic overture, the coronary flow, and the risk of perfusion of the aneurysms due to the paravalvular leak. Martin Chiserney also proposed a prosthesis like that as a composite prosthesis with a stent graft for the scenario and a transcatheter valve connected to it. But still the coronary arteries are perfused, not treated. The aortic root is not treated, so it is still an incomplete solution. And that's why an endovascular composite graft is very challenging because of all those drawbacks that I comment on in the previous slides. And also because if you have residual aortic regurgitations. We learned from the partner trial that mortality can be high on the follow-up if compared to if you don't have any kind of residual aortic regurgitation. We have to deal with the stress over the stent since the ascending aorta is very dynamic, and including the stress on the transcatheter valve that is connected to it. We also have absence of dedicated components, especially the connecting stents from the main graft to the coronary arteries. At this time, we do not know how they will behave on the long-term follow-up. So find a perfect clinical and anatomical patient for an endeavor like that is very difficult in the regular proximal distance landing zone. The size of the ascending aorta should be enough to allow us to navigate inside of it. So true lumen should be not so extremely compressed. We need a long left main, absence of significant coronary disease, and perhaps true aneurysm is easier to treat compared to type A. So our first patient was a combination of different anatomical, geometrical, and clinical setup that allowed us to treat it. It was a 64-year-old lady with a previous AVR and a huge pseudoaneurysm on the ascending aorta, our porcelain aorta, previous attempts to treat it with 7 vascular plugs and a very high error score. So surgery was not an option for that patient. And that's why we proposed at the end of bento. We went from the computer tomography, we prototyped that, we made a custom prosthesis and put a partnership with Bright Biomedical. We tested all of this fluoro, as you can see here, and we ended up with prosthesis that was partially self-expandable and partially balloon expandable, taking into account all these factors in order to build up a perfect prosthesis. And this is an image of the project and the prosthesis if you look at it from the side. So the idea here was to put the main body in a transcentrical approach in order to be easier to maneuver the prosthesis, then cannulate the branches and the coronary arteries and put the connecting stents there. And that was done on a neighborhood wire. We crimped on the table side with special care to avoid twisting the prosthesis and to not miss the reference marks. We use a transapical incision, bilateral femoral, bilateral brachus, TE, echo monitoring, and ECMO on standby for safety reasons. So we started putting guide wires on the right and the left coronary arteries. After that, we started putting the C-arm in an adequate position and doing our first angio, confirming a huge leak on the ascending aorta. And then we start deploying on a rapid pacing the main body of the endobenta. We can see here the deployment of the first segment, the second segment, now the third one that contained the branches for the right and for the left coronary artery with marks on the tips of the branches. After that, still rapid replacement, we inflate the transcatheter valve, completing the main body of the endobenta. Then we move it to the coronary arteries. The right was the first one. We can see here the deployment of the connecting stent, connecting the proximal part of the RCA to the endobenta with a very nice flow to it. After that, the connection of the left main to the main body of the endobenta, again with a very nice flow, completing the procedure in 6 hours and 30 minutes with no endoleaks and no VAR complication, with a patient discharged in 80 days, placed on aspirin and clopidogrel. And this is a 3-year follow-up on computer tomography showing complete exclusion of the aneurysm and flow on the left and on the right coronary artery, and no fractures of the stent on the follow-up. So from this point, the endobenta was not admitted anymore, but a lot of question was still unsolved. You can see here from my eyes that was not an easy procedure, but when we take a look 24 hours later, was the patient awake and extubated on an intensive care unit. A lot of questions arise after that. Are the coronary flows adequate? And this elegant paper from Francesco Maisano proved that the Chimney technique provided adequate flow to the coronary arteries. But we need to move further, and move further is not to use a transapical incision and build a completely transfemoral endobenta. And this is being done now. This is our first implantation in a very low fidelity model of the new endobenta that is completely transfemoral. You can see here it's all self-expandable. It's not more a combination of a self-expandable and balloon expandable procedure, and we call this orthosafe. can be partially deployed. The coronary arteries can be previous cannulated, making the procedure easier, as you can see here in a simulation of the device. And now we call orthosafe endobento. You can see here that we deploy partially the endobento, we cannulate the coronary arteries, we engage there, and then we deployed the full prosthesis. It's a 22 French transfemoral Conclave, and we are programming for the next 6 months our first in-man case for this. Of course, there are other groups working on that. This is a paper from Dr. Goresh, published in 2023, showing a custom physician-modified device combining a constricted stented graft with a transcatheter valve. It's prepared on table side with all the drawbacks of preparing a prosthesis on the table side. We can also see here the buildup of the coronary fenestrations, the reinforcement of that with nitinol wire, and the check of the position. So it's not so perfect if a company produces it for us, and if we can test this previously on fluoro and in computed simulations. But of course, it's possible to be done, and this is a proof of that. The first case from this group presented on TCT, do not treating the coronary arteries. And again, the second case from this group proposing first stage doing a total arch, and on the second stage doing an endobento at this time, treating the coronary arteries with stent grafts, connecting stent grafts using a 26 Evolut Pro 2 to a TIVAR graft from Cook. If you ask ChatGPT to compare what you have in terms of treatment of endovascular type A dissection, we see that the technical success can be very high, around 90%, but hospital mortalities are still high, around 15%, neurological complications up to 10%, endolytic type up to 20%, and reintervention rate up to 25% in 1 or 2 years. And if you ask again ChatGPT to compare the fenestration devices or treating only the ascending aorta, you see that success rate are similar. The third-day mortality is lower if you treat the roof at the same time, but of course, treating the root at the same time are not off the shelf, and we need a center that's more experienced to deal with a lot of endovascular skills that we need in order to perform a completely endobento. So the endobento is feasible, is really the proof of concept with good follow-up results at this time, especially if you look at a population that's very high risk or even inoperable. But we still have a lot of unsolved questions like the best anticoagulation or the anti-aggregating protocol, the absence of dedicated materials. We do not have a coronary stent that is dedicated to this connection. And there's a risk of coronary stent thrombosis and flow. And also patient selections need to be more clarified in the future. So we need to design patient solutions and not solutions for patients. And what we want is to move from a procedure that is very big with a lot of mortality and morbidity, and move to a procedure that could provide a solution for patients that are too sick for any type of other procedures. And this is a procedure of us of a type A aortic dissections and the vascular treated 24 hours after the initial procedure. So will endobento be the standard repair for type A dissections? I think yes, in a selected population. Thank you very much for the invitation, and I'm here to answer any questions that should arise.
Thank you, Diego. Very, very fantastic and very good presentation. And a couple of questions. You had an ideal patient. You had a platform. Already there was a degenerated bioprosthesis in this index case. So it was easy to land the TAVR device. But in acute dissection, usually your root is dilated and you have a severe AR. And to the best of my knowledge, there is no dedicated TAVR valve for AR except one valve, which is called J valve, which is available in China. So how do you solve that problem? And how much you will oversize in a pure AR? 30%, 25%?
I think there are two things here, Christian. The first is the problem with aortic ER and the vascular treatment of aortic ER. One of these are migration. But yes, if you are talking about an endobento that's connected to a thoracic stent graft, and this stent graft it's connected to the ascending aorta. I think that will be the landing zone that will anchor the valve on the annulus, not only the annulus. So we have two mechanisms to anchor that, the annulus and the ascending aorta. So the migration problem should be reduced. And the second answer to you, we are aiming to at least 15 to 20% of size.
Okay, thank you. And it was good to show some physician-modified devices, like one with the Medtronic valve. And do you have a balloon expandable valve modified, let's say, with a rendezvous technique, a combined transfemoral, transapical approach? From transfemoral, you deploy a stent graft, and transapical, you deploy a balloon expandable valve?
I think that could help. We can use this strategy. But the question here is the aortic root would not be addressed. And if you do not address the aortic root that is to be perfused, the long-term follow-up is not so good. As I show you on some series, we have residual leaks, we have ruptures of the aortic root. So I think that if you were in an emergency setting and the only thing that you have is an abdominal cuff or a thoracic stent graft, and you have enough length for the aorta, you should go for that and plan the endobento on the second step. If you just treat the intimal tier or the ascending aorta, the follow-up would not be so good.
Thank you, Diego. It was really a fantastic and fascinating presentation. And I'll open the floor for discussion. We have Dr. George Joseph here, we have Dr. P.C. Gupta, and we have Dr. Girish here. So they would be they would like to ask you questions to you.
Thank you, Diego, for that fantastic talk. I saw that from your first case to your subsequent cases, you have changed your TAVI device from balloon expandable to self-expanding. Is that going to be the trend in future?
No, that was not a case. That was the case of Goreshi, I think. The one who has used a core valve along with that. I don't think so you have done that case. You are using a Innovare valve with endobentol device.
Our first endobentol device was use a combination of a self-expandable stent graft and a balloon expandable valve, because Brand Biomedical only had at this time a balloon expandable valve. The physician modified device was presented by Dr. Goresh on TCT. Our new device that's ready to be used in a partnership with PENF that made a trick valve, it's totally self-expandable. I think it's easier to deploy it. We don't have to deal with a balloon and a stent graft at the same time. And this allowed us to reduce the French. So we're
is it a
talking
dry
about
tissue technology? Is it a dry tissue
Sorry?
technology?
Dry tissue.
Dry tissue. Okay.
Like trick valve. So we were dealing with a 22 French device that can come from transfemoral. The first endobento, it was a 28 device. So it's very difficult to come transfemoral with a 28 device.
Okay. Dr. Girish, you have any question?
No, do you pre-cannulate these fenestrations or pre-wired?
On our first case, the fenestrations were not pre-wired, so we lost some time cannulating them. It was the most difficult part of the procedure, especially on the left main. But our next device that I showed, it's all pre-cannulated, so it's much easier.
And could you, in the future, use it for connective tissue disorders?
Sorry, again?
Could you, in the future, use this for connective tissue disorders, like Marfan's?
I'm not sure. I think if it's an emergency setting or an inoperable patient, yes, but it's an inoperable patient, for sure not. They should still go to conventional open surgery, for sure.
By the way, Diego Gaya is a cardiac surgeon. And most of the innovations are by cardiac surgeons, like Francisco Maisano, who has the...
Thanks, Prashant. Thank you, Professor Diego. That was an excellent talk, and I think very inspiring for everyone. I think in the next 1 year, you might see a case report from India about a total endobentology. Thank you so much for being with us.
Thank you very much. Have a nice day.
Thank you very much. Moving on, we are a little behind schedule now. Dr. Takuya Fujikawa, he will speak to us about the controversial topic of frozen elephant trunk, and he's going to compare the various devices, their structural differences. So he's a consultant cardiovascular surgeon from Hong Kong. He's Japanese by Japanese origin, but he's one of the best cardiovascular surgeons I know who does open aortic surgery and a very strong proponent of open aortic surgery.
Thank you very much. Thank you for your kind invitation. And actually, I'm very happy to come India again. So this is already third time after COVID-19 subsided. So first of all, I need to apologize 2 points. First, today's topic is about aortic dissection. And today, my topic is frozen elephant trunk. But as I said, my basic strategy for type A is hemiarch, no use frozen elephant trunk. Second is major device I refer is Frozenix. It's from Japan Lifeline. It's not sponsored in this meeting, but Artivion and Thermo sponsoring, so I hope they won't kill me. Anyway, let me start my talk. So first experience of Frozenix in Hong Kong and structural comparison. So now Hong Kong, 3 FET devices are available. So first, Solaflex. Second, Evita, open nail. And third, the newest one is Frozenix 4B. So there are 3 major differences between 3 devices. The structure of stent part. Solaflex and Evita is mainly a exostent structure. Of course, more precisely, Evita open nail in the distal part is endostent, but proximal part is exostent. But Frozenix is totally endostent, endoskeleton structure. And second is the attachment of color. Frozenix and Solaflex and Evita has attached in a concentric circle, like this result. But Frozenix has a parallel direction like a bell, like this shape. And third is orientation of branches. For the Solaflex, the 3 branches are straight on the main trunk, and the side branch is in 3 o'clock direction. And third branch in the frozen elephant trunk is very close to the collar and only 5 mm. This makes it a bit difficult to reconstruct left subclavian artery for me. Evita open nail is similar. 3 branches are straight on the main trunk, but side branch is in 4 to 5 o'clock in direction. And distance from between third branch and the collar is 2 cm. To me, this is more comfortable to reconstruct left subclavian artery. However, in Frozenix, 3 branches are obliquely attached. And left subclavian artery branch and the side branch are on the same line. And there is still 1 mm distance between third branch and the collar. So tips for the implantation of Frozenix is actually same with usual total artery placement and transect aortic arch, and I apply 4 Prejet sutures for the traction and stay suture as a stay suture. this can open up the aortic arch structure, so it's much easier to insert elephant trunk devices. Actually, how to use it is almost similar, but Progenics need to remove this color, and company recommend to tie here on the color to make it easier to insert the devices. Company recommend tying, but I don't want to tie, so I'll just snare with I use snare. So a bit tighten, so that makes smaller than normal structure. Just insert device. So probably this is similar with Flaplex or Evita. No difference. Then after you make sure the direction of frozen elephant trunk, just remove this snare. Then if you remove this wire, it's already deployed. And asking to your assistant, pressing the color not to come out to the proximal. And then shaft is twisted, or sometimes need to hold it more closer to the tips, and then remove. So this kind of tips is almost similar with other frozen elephant trunk devices. And actually, for the implantation, there's nothing new comparing with other frozen elephant trunk devices. And using this color, I fix using previous 4-stage sutures. I apply 4 stitches on the colors. And at that time, I leave this needle. I keep this needle, not cut, and later I will use for the continuous suture. Actually, technically, nothing is demanding. So I agree with some surgeons who want to proceed for the elephant trunk even in acute type A dissection, but still a little bit challenging for the juniors. In my center, hemiarch replacement for the type A dissection is one of the first operation training experience. So if that's the case, frozen elephant trunk is a bit too complicated. Anyway, after the continuous suture, this is my preference, and I applied a whole circumference interrupted double prejet sutures. So this technique is same with my conventional total arch replacement, and this right side drawing is my drawing for my junior to teach how to do conventional total arch. I prefer to use interrupted suture because it may take a bit longer time, but easier to teach, and actually even for the young surgeon, it's easy to do it. After completing whole circumference double prejet reinforcement, we can resume perfusion. This step is actually same with conventional, no other frozen elephant trunk devices. There's no difference. Then check the bleeding, and normally I don't need to add any more stitches for the distal anastomosis, and the bleeding should be okay. So other parts, the proximal anastomosis and neck vessel reconstruction, actually normally I leave this part to my juniors. And so tips for suturing for the Surrogate, there's if you look at the width of the color, is a 12 mm. The whole diameter is graft diameter plus 24 millimeter. So it's quite huge. Even if you choose 24 millimeter size of graft, whole diameter of color is much bigger than graft size. So it makes a bit more difficult to anastomose. And if its arch is already dilated, probably for the bigger aorta, no problem. just showing. But recently, our anastomosis line for the total arch is becoming more and more proximal. So if you anastomose zone 2, size is not dilated sometimes. So is that the case? Color is much bigger than aortic arch, and it's caused sometimes discrepancy and sometimes dog ear. So to prevent these things, sometimes we need to trim this color. This is our practice in Hong Kong. But when it comes to prosthenics, the diameter, because the color is attached like this belt, so the whole diameter and color diameter is same. So less chance to cause discrepancy. So the color inline the aortic inner wall. So this may prevent unnecessary bleeding. So actually, basically, I'm doing a whole circumference interpret suture, but after I introduce Frozenics, normally I don't use less using for the whole circumference reinforcement. Then this is a proximal anastomosis being done by my juniors. He is a post-year graduate about 8 years and just passed the exam of specialist. And for this step, even for this step, I describe in detail. So he is just following my method. And actually, this video was taken by me. I had already scrubbed out. I'm a bit lazy, so I try to get more time outside. Then after the proximal anastomosis, all neck vessel reconstruction was also done by my juniors. Yeah, so surgeon is now 8 years, and the supporting is assisting is 3rd year or after graduation. And this design was done by my junior, so it's very nice and it's no bleeding, almost no bleeding. And actually, initially, I have some strange impression about the oblique attachment of neck vessels, neck branches, but eventually it clarified it's more beautiful alignment of neck vessels. And actually, still, we started using these devices, and this is not a standard device in Hong Kong. So we sometimes use Reflex, sometimes use Evita, and sometimes use Prosthenics. But previously, today, we have some discussion about post-ventral procedure. But I've done redo total arch replacement, redo Tarfet using Frozenics, but it's so far working well. So if I'm asked what is my basic strategy for the residual dissection after ventral procedure, my answer is just to redo frozen elephant trunk. So this conclusion is actually now same with stent-graft. So there are a lot of devices, but we need to know the feature of each frozen elephant trunk devices. Now we compared 3 frozen elephant trunk devices, and the design of Frozenics is revolutionary, especially in the color and the branches attachment. But still, a lot of complication was also reported. So Frozenics has a potential to be in the first choice of the frozen elephant trunk devices, and statistical comparison also important because we need to do some randomized control trial or something. So this is my opinion now. Thank you very much.
Any questions to Dr. Fujikawa? Yeah, Dr. George Joseph.
That frozen elephant trunk of the third device you said is endoskeleton. What's the reason they changed to that?
Sorry, I don't know that. But
I can try and answer. So one of the reasons they give for a distal new entry tear or sign is the presence of the stiff stent outside. So the newer designs, and since I'm going to be talking about some of these things, that's why I read about it. So they are actually putting the distal stents inside and actually even leaving just fabric at the distal end to reduce the incidence of design. That is the logic.
And for the distal sign, for the Surrogate, so for the Surrogate has a this distal ring. This distal ring sometimes called distal sign, and actually Evita, in my previous impression, Evita has a less chance of distal sign. However, still there is some sharp point, this kind of sharp angle of state structure. It causes a distal sign. And tomorrow I will show some distal sign in the open surgery. So in Japan, this frozen X has been used for many years. So, but still there is some distal sign were reported. So we are not sure exact reason of distal sign, but as Dr. Gupta mentioned, maybe this endoskeleton structure reduce the possibility of distal sign.
Another thing you mentioned is that the Prosenix has a large collar, which sometimes you trim. So what is the advantage of a large collar in the first place?
So the structure or the difference of direct color direction is important. So because if you have this kind of concentric circle direction, sometimes this diameter is this whole circumference size is much bigger than aorta. But frozen X is attached this direction. So this diameter is not changed comparing with main trunk. So I think this is, and even if arch is bigger than graph, just the color is just broadened. So I think it's less chance to cause discrepancy between color and aortic arch size.
The inner circle on athletics and running in the outer circle.
Yes.
There's a lot of discrepancy while suturing it to the aorta.
Yes.
So then you have a lot of dog ears.
Yes. So sometimes when I use Evita, I trim the color as much as possible so that just make smaller the diameter of color.
Thank you, Dr. Fujikawa.
Thank you very much.
I will talk to you about current and future perspectives on aortic dissection. And I will have to cut short my talk because we have an online talk after this. So when it comes to aortic dissection, there is a variety of presentations as we've been discussing, variety of therapeutic modalities, a constantly evolving field, and of course, a variety of opinions as to how we deal with these things. Now, this is something that Dr. Chandrasekhar referred to, the TEM aortic dissection classification. So I won't discuss it, but this is one good way to look at prognostication or even decision making. Now, one of the challenges that we face is the ascending aorta. And Professor Diego mentioned very eloquently, it's a large outer curve and a smaller, lesser curve. There's elongation and angulation with aging, variable length of the ascending aorta, and normal ascending diameter changes throughout the cardiac cycle. And we don't know what the effect of a rigid stent might be on maintaining blood pressure. And extension of pathology into sinutubular junction or aortic root obviously makes it difficult. And of course, first human in Bentall, we've heard that. And then of course, how do we manage the complete arch endovascularly? Then dealing with chronic aortic dissection, dealing with paraplegia, dealing with sign, genetic studies, and following up these patients. So some of these issues have already been covered. So we need to keep in mind what is the access vessel that we are going to use. Arch angulation, again, Dr. Shuvro spoke about the bird beaking and how we need to be on horizontal portion of the arch to reduce risk of type 1 endoleak. Aortic tortuosity, avoiding stroke, very important, avoiding paraplegia, dealing with the left subclavian. And the trend now is to perfuse the left subclavian to reduce the risk of paraplegia, avoiding proximal and of course distal endoleaks. So these are some of the things that have been done, different types of debranching or hybrid procedures, type 1, type 2. All of us are familiar with these. And then prosal elephant trunk, which generated a lot of controversy whether to use it for acute type A dissection or not. Now, these are some of the newer things which are coming for and will be useful for people who find doing type A dissection, frozen elephant trunk for type A dissection. So this is a stent. So you see, this is the proximal collar, which is going to be stitched to the ascending aorta. And you have these stent grafts, which are sort of constricted. And you can push these into the innominate and this one into the left carotid and release them. So you don't have to do an anastomosis to the branch, makes life easier. Similarly, in addition to Frozen X having an improved technique, there is another one which is being developed where you have a cuff outside. So you put 4 stitches like Dr. Fujikawa did and then tighten the cuff instead of having to do the complete anastomosis, again, making life easier for the surgeon. And of course, these are some of the things that we do routinely. TVAR and either a carotid subclavian bypass or a transposition. Again, neck vessel transposition. This is a standard TVAR. And this is one of the patients where we actually had a complete thrombosis of the false lumen. PMEG, again, something which is being done very frequently. Chimneys have been done for complete endovascular management of the aortic arch. I'm personally not a big fan of chimneys, but there are people who claim that the results are good. And then on-table fenestration. People have been doing single, and Dr. Joseph has been regularly doing 3-vessel fenestration. Rohit was here, he's been doing 3-vessel fenestration, and they're quite happy with the results. But not everybody is technically savvy enough to do 3-vessel fenestrations and do a complete endo repair. So we have branched devices. This is from Termo and this is from Gore. So here you have 3 branches. There are grafts with 2 branches, and Gore has a single branch which goes to the nominate, and then you can do a debranching in the neck. Again, this is all to make the procedure easier. And then this is a Chinese graft which is being developed, the V-Flow Arch Modular. There's trial going on. So where you have space for 2 inner branches, and then the TVAR can be placed. Technically, it becomes like a chimney, but then probably more stable because there is a longer contact with the branches inside. And this is something which is probably on display outside on the LifeTech stall, where you have a mesh which is open, and you have 2 inner branches this side and 1 for the subclavian here. So even if you deploy the stent graft, you can continue to perfuse the cerebral vessels through this bare area while you are deploying the stents from the carotid and the subclavian artery. And then Professor Diego spoke about the ARISE-1 and the ARISE-2 trial. ARISE-1 had 19 patients. So this was basically looking at endo repair for the ascending aorta. And this was acute dissections, type A or type B. And they had type 1, 10 patients, and type 2, 9 patients. Mortality was 3, stroke in 1, and MI in 1. And ARISE-2 is now a prospective study again, looking at chronic dissection. So ARISE was done for patients who were really unfit for surgery. So it was more experimental. Now they're trying it for patients who have other chronic diseases or chronic conditions of the ascending aorta. This you've all heard. And then, of course, there was some discussion on how to deal with false lumen filling up from below. And there are different devices like candy plug. And then, of course, there was some discussion on the stabilized technique and the petticoat technique, which are really not new. They've been published quite some time back. We are all scared to inflate the balloon and stabilize, but the studies have not really indicated I think there was only one rupture, and that too when the balloon was inflated in the bare segment of the stent graft, and that could be managed with a covered stent subsequently. Chronic DBAD, we'll hear about this more from Professor Fujikawa tomorrow. Open surgery is a fantastic option. And I think as surgeons, we really need to be good at doing open surgery for aortic diseases. So those who are on medical therapy, some of them do get aneurysm formations. And when we do an endo repair, there is a risk of distal stent-induced new entry tear, especially when the lumen is small or there is patient with connective tissue disorder. And there is a new design to try and tackle this problem. So it's a dissection-specific stent graft. So this was a study conducted in Sweden with a median follow-up of 17 months for 16 cases of chronic type B aortic dissection. They had a technical success of 96%, one death due to retrograde dissection within 30 days, and one late design despite the special design of the graft. So this is the graft. We've been talking about tapering. So this tapers from 38 to 28. These are the stents which are like the exoskeleton outside. These stents, if you see, they are sort of more rounded, the lower ends. So chances of injury to the intima and causing new dissection would be lower. And this segment is just fabric. There is no stent in this. So this is the aim, with the aim of reducing design. So this is how it looks when it is placed. And these are some images showing long-term, fairly good remodeling of the aorta. And this is one of the patients where they had a new entry tear following placement of the stent graft. Spinal cord protection, again, a very important area that we discuss when we are discussing aortic dissection and treatment of the descending aorta. Paraplegia can be seen with stent grafts in 3 to 4%. Risk factors are coverage of the left subclavian, and we should actually, as a principle, try and keep the left subclavian open, especially if we are covering down to the celiac axis. Bilateral internal artery occlusion, again, is a risk factor. Concomitant or previous abdominal surgery or intervention, again, a risk factor for paraplegia. Hypotension is a risk factor. Preventive strategies are address all of the above. Spinal drain, there is a controversy, as we heard, pre-op versus post-op. What we do in our practice is for open surgery, we like to put it pre-op. For stent grafts, since we do it percutaneous, patients are awake. And if patients do develop limb weakness, and we have seen this, we place a spinal drain after the procedure, and we've always seen complete recovery of limb function in patients with stent grafts. But with open surgery, if we've had to place a block drain later, we invariably, there is no recovery because by the time we discover paraplegia, it's quite late. And these patients with stent graft developing paraplegia, we've actually done MRIs and seen changes in the spinal cord. And yet after placement of spinal drain, they do recover. So we like to place the drains post-procedure if required. We've seen deaths following cerebral hemorrhage with spinal drains. We were also discussing whether we have a bare stent distally to reduce the risk of paraplegia. So this is a honeycomb design where blood can actually flow through the stent to perfuse the intercostals. So all these are things which are being developed. The future seems bright. Innovation is the key, as we've been hearing from all people today, and very interesting talks. Endo is certainly moving forward very, very rapidly. Hybrid approaches seem to be the key, and outcomes of good surgery even today are really unmatched. Thank you very much for your attention. And I think teamwork is something which is very, very important. And I would take this opportunity to thank our industry partners, LifeTech, Vibgyor, Termo, Artivion, Gore, Medtronic, Cook, and Abbott, who are supporting this meeting. Thank you very much. Yeah, so we've caught up in time and we will have a talk soon. Is he online?
Good morning, everybody from New York City. Thanks for having me. This is Panos Kougias.
So is Dr. Panos online? Yeah.
Yes, can you hear me?
Yeah, so welcome, Dr. Panos, and thank you for accepting our invitation. So Dr. Panos is Chair Department of Surgery, and he's a vascular surgeon at the Sunny Downstate Health Sciences University in New York. And he's the co-PI of the IMPROVE AD trial. And something we've been discussing about how we deal with the type B dissection, I think he's going to throw some light on how the trial has been designed and how it's moving forward. So the stage is yours, Panos.
Thank you. I'm afraid I have some, can you see my slides?
Not yet. We can see you, but not your presentation.
I may have to log on and log back in for a moment to be able to share my slides.
Yeah, sure. Not a problem.
But thank you.
So I happened to meet the PI and co-PI of IMPROVE AD trial last year in New York. And I thought it would be a good idea to include their talks in this session because it's really so relevant for what we've been discussing so far. Vijay, you are supposed to take over. Vijay, Sharath, and Niranjan is gone. Ajay. So Vijay, Ajay.
All right, I apologize for this. Good morning, everybody. Thank you for having me. I just wanna see if you can guys hear me well.
Yeah, we can hear you. Please go ahead.
Thank you. It's a true honor. I'm Panos Kougias of New York City. So good morning to everybody from the United States and New York City. And I will be presenting to you today on the IMPROVE AD randomized controlled trial. This is a randomized trial that has as an objective to compare a TEVAR first versus a medical management first strategy for the treatment of uncomplicated type B aortic dissection. It is a team effort, as every randomized trial is, and I would like to spend just a few moments to mention the very important team of collaborators, especially Dr. Faraz Musa, who is depicted on the left hand side of this slide. Faraz, I believe, also has a talk in your conference, and he has been the brain and the person who has very passionately pursued the randomized trial. His efforts having started close to maybe a decade ago to get to the point that the trial has been funded and has started recruiting. Before I talk about the study per se, I would just briefly mention that this is an NIH randomized trial funded by the National Heart and Lung and Blood Institute in the United States. This is just to show the quite involved way that those trials are run. In this country, there's of course the executive committee that is at the heart of the study and coordinates all the major decisions. But as you can see, it's a very horizontal structure to run this trial. In addition to the executive committee, There is a clinical coordinating center that is making the clinical aspect decisions of the trial, and also a statistical and data coordinating center that makes all the logistical decisions. And those two centers are informed in the decision-making process by the executive committee, the NGLBI leadership, and also the steering committee and many, many other subcommittees that we have in place. So why do we need a trial for asymptomatic type B aortic dissection? And this audience knows very well that way back, maybe 15 or so years ago, when thoracic stent grafts came out, they truly revolutionized the way we treat the symptomatic type B aortic dissection. Outcomes improved, follow-up was shortened, and survival even improved. And at the time, it wasn't clear whether stent grafts can really be used for patients who have a type B asymptomatic dissection. The concept was very appealing and it was very intriguing, with many of the operators advocating having an early use of a stent graft on patients who present with an asymptomatic type B dissection in the anticipation of promoting remodeling and facilitating a shorter hospital stay and more improved long-term outcomes. And some operators actually started using endografts in thoracic aorta for those, again, asymptomatic type B patients. And instead, the trial, as you all know very well, had some preliminary results that were rather vague, very small sample size, and it wasn't clear what the long-term consequences of a stent graft versus the medical-only management would be. That was the motivation behind our trial, which really wanted to understand how placing stent graft on patients type B who is asymptomatic will affect long-term survival and other complications. And the hypothesis that anchors improve really is shown in this slide. So we hypothesize that in patients with uncomplicated type B aortic dissection, a strategy of upfront TVAR with medical therapy, of course, when compared to a strategy of medical therapy alone, will reduce death and major aortic complications or interventions. And this is an important aspect of the study. It is a strategy trial. So it's a strategy trial. We'll compare one strategy, which is to do the TVAR upfront, with another strategy, which is to give medical management upfront, and then follow the patients as per standard of care to see if the outcomes will improve, and if necessary, sometimes even place a stent graft in these patients that initially had the medical management, who dilate over time or who develop a complicated type B aortic dissection. So the structure and the design of the trial is summarized really on this slide that I will go in a step-by-step fashion to give the audience some idea of what is that we do. So we do randomize patients with uncomplicated type B, Stanford type B aortic dissection within 48 hours to 6 weeks from the index admission. We target 60 sites in North America, and we have planned to expand to Europe and Canada. And maybe other sites internationally. India may be a consideration if you all have interest in the study. We do include patients that are at least 18 years of age. And as I previously mentioned, this is Stanford type B aortic dissection, uncomplicated. So we don't have any ruptures, we don't have any malperfusions. And we do stratify by the presence of those three high-risk features I showed in the slide. We randomize by the presence of the maximum aortic diameter, by the presence of an entry tear, and by the presence of a maximum false lumen diameter. And we do this stratification to further understand the role of high-risk features and how they may impact the patient's outcomes in the short term and, more importantly, in the long term. This is a long-term study, as I will mention in a second. Again, we randomize those patients in 1-to-1 ratio. It's a strategy trial. So the invasive arm would be to give medical management as per the standard of care and then perform the upfront TVAR from 48 hours to 6 weeks after the index admission. And the conservative strategy is to give simply medical management, beta blockers, calcium channel blockers, and whatever else is necessary to control blood pressure. And of course, both arms have a standard of care follow-up with CT scans every 30 days after the index admission, and then 6 months interval follow-up. We do remote blood pressure monitoring of those patients, which is a very important element to understand if the treatment, the medical treatment we implement after randomization is effective. The primary endpoint, and I will discuss this in more detail in a second, I will briefly mention that the primary endpoint is a composite of all-cause mortality or major aortic complications or interventions. It's a time-to-event analysis. And we do collect many other very important clinical events as secondary endpoints. And those include quality of life and clinical important events that I will also discuss momentarily. This is the primary outcome broken down. So we do have a composite endpoint as a primary outcome, all-cause mortality or major aortic complications and interventions. And those complications, as you can see from this slide, are very serious clinical issues that we do need to know for our practice. Rupture, of course, is an endpoint. Malperfusion, either visceral, renal, or limb malperfusion is an endpoint. A new aortic tear that may lead to the need for reintervention. Of course, the dreaded retrograde aortic dissection, dialysis, major amputation, tracheostomy, if patients develop respiratory complications and stay on the vent for a long time, any major aortoesophageal or aortotracheal fistula, and of course, the again dreaded spinal cord ischemia or stroke consist outcomes for the primary endpoint. And we do also include this in this endpoint, aortic dissection-related interventions, major ones like conversion to open thoracoabdominal or thoracic aneurysm repair, the need to perform a fenestrated or branched endovascular repair or a repeat thoracic EVAR. The secondary outcomes, as I briefly mentioned, include the quality of life, cardiovascular hospitalizations, cardiovascular mortality, aortic-related mortality, and all-cause mortality, as well as aortic-related hospitalizations. We include patients that have a Stanford B aortic dissection, again, uncomplicated. I briefly touched upon this. We want them to be between 48 hours to 6 weeks of the index admission. And we do want them to be able to provide written informed consent and comply with the follow-up imaging protocol we have. We do exclude patients who have an ongoing systemic infection. Those who have a known genetic disorder that may trigger dissection, and those who have an iatrogenic aortic dissection. And of course, other exclusion criteria are pretty standard for the randomized trials we typically perform. The study flow is pretty unique in that we have tried to take the burden off the site as quickly as we can. The site is, of course, responsible to recruit the patient, randomize, and perform their procedure. But after those 6 weeks have been completed, the Data Coordinating Center from the Duke Clinical Research Institute, the DCRI, takes over really the entirety of the follow-up. And the follow-up has been remotely and oftentimes in conjunction with what the clinicians do at the primary investigator site. And this is an important element to facilitate recruitment As we have seen the time and time again, that shifting the burden of the follow-up on the site level has some negative implications with respect to recruitment. This timeline of the study, as I mentioned at the beginning, Dr. Faraz Musa had the idea, the inception of the trial was all the way back in early 2010s, but we finally got the trial funded in 2023. We enrolled the first patient in February 2024, a year and a half ago, and we expect to end enrollment sometime in March of 2028 with a database lock in April 2030 and subsequent analysis of the data. Our objective has been or was at the beginning of the trial to have 60 sites in the United States. Our target sample size is 1,100 patients, and we base this on an event rate of approximately 25% for the open arm and an effect size of 25% for the endovascular arm. We do have an approximate 4-year enrollment period, and the maximum follow-up will be 6 years for those who enroll first. But the average follow-up we anticipate to be for the whole cohort between 3.5 to 4 years. We have truly been recruiting from coast to coast in the United States. Or from this colorful map that you see, the red color states are those that haven't been a site of the trial, but as you can tell, we have really enrolled patients and activated sites in almost 2/3 of our country here, from East Coast to West Coast, and have stratified those sites and geographically to facilitate recruitment. We do want to make this study as pragmatic as it can possibly can. As all of you know, the aortic dissection, acute aortic dissection is an entity that doesn't come predictably. It doesn't come often. And we don't believe that there will be many opportunities to collect data on the outcomes and natural history of this disease. So we do want to be as inclusive as we can. And what I show here in this slide is a representative of the efforts we have been making to be all-inclusive. We, for instance, circulate in our sites a screening log questionnaire, and we request to get some sense of why patients will not be recruited in the trial, why are excluded if they don't meet the exclusion criteria. And we get some sense of the reasons for screen failure. Some of those reasons fall under the exclusion criteria, others do not. And if you look at this slide on the top 3 rows of this table, what we very quickly realized is that we were losing many patients because they had a prior aortic dissection or aortic surgery. We were losing quite a few participants because they were not interested in participating in research, and quite a few patients because they had, in conjunction with the aortic dissection, a PAE or intramural hematoma. So we do use this information to modify the inclusion criteria and educate both sites and patients properly to be able to increase our enrollment as we move along. We have, at this stage, activated 58 out of our target 60 sites and have recruited 102 patients out of our targeted 1,100 patients. So we are almost 10% in the way. We have got some time to go. So we do want to encourage recruitment and encourage investigators and patients to be willing to enroll in the study. As part of the trial itself, we have launched an effort to promote education and promote a sense of camaraderie among the surgeons who treat patients with acute aortic dissection. As part of this effort, we'll launch the quest for manuscripts on acute, complicated, and uncomplicated type B aortic dissection to discuss equipoise issues. We want to discuss the patient engagement perspective, and we do have a separate patient engagement arm that really is run by patients. And we as investigators, and Shirin Shahub, one of our co-investigators, guides and directs this arm, but we truly want to get the patient experience and their own perspective on why this trial is important to them, how it can facilitate recruitment. And all those other topics from manuscripts that you see, illicit drug use, landing zone, and how important it is to assure exclusion and remodeling of thoracic aorta, intramural hematoma, extent of coverage, high risk features, and of course, we want to promote guideline awareness. Currently, the data we have to support the guidelines for type B asymptomatic aortic dissection are quite weak, thus the need for the randomized trial. And of course, have several methods to promote investigator and patient engagement in every possible way we can in an effort to improve their recruitment for the study. So in summary, our study, our Improve AD randomized controlled trial, is a multi-center randomized trial on asymptomatic type B aortic dissection. We have started recruiting in the US. We will be extending very likely in Europe and Canada, hopefully even in Asia. And our goal and aspiration is to conduct a high quality trial that will answer critical clinical and quality of life questions that relate to the management of the asymptomatic type B aortic dissection. Thank you all so much. It's been a true privilege. I do appreciate the opportunity. I will be happy to take any questions that you may have. Thank you.
Thank you, Dr. Panos, for giving us an insight into the study design. And I'm sure the results of this trial would really take care of the confusion many people have or dilemma we have while treating such patients, to treat them at first upfront with the TVAR or put them on a medical therapy, of course, uncomplicated type B dissections.
Yeah, it's a difficult problem, difficult question to answer. And really, if you ask 10 people, you're gonna receive 11 different answers because even within the same group of people, sometimes the decisions and the perceptions vary widely. And have seen a shift over the course of the last year and a half of the study is in progress. We have seen a shift in perceptions and a shift in the way people have embraced the trial. But we do aspire to give answers to those questions. As you all know, there are two other studies from Europe. There's a Sunday trial, the Earnest randomized trial, and we have all harmonized our endpoints, which is critical, we feel. We have harmonized our endpoints, so at the end, we will have close to 2,000, maybe 3,000 patients together to have imaging data for, to have clinical data for, and we should be able to get some better sense what's the best strategy to use. It's a tough problem, and as you all know very well, dissection comes in many different shades of gray. Not two dissection patients are alike. And trying to get a study that will somehow get everybody together and make it as pragmatic as possible is difficult. But we have been making the best effort that we can.
And I'm sure it is going to give us a very good result, people are looking forward to.
Thank you.
Yeah. May I ask a question, Dr. Panos? Many thanks for coming over. I've got two questions. One is, you said the timing of intervention is 48 hours to 6 weeks, which is quite a big, long period. Do you think that will affect the results?
That's a great question. As you might expect, we agonized quite a bit. And I remember calls after calls with the executive committee, with investigators, the NIH, trying to marry together two very different issues. One is the need to have a homogeneous patient population, right? You don't have a hyperacute with a subacute dissection on the same trial because the results will be different. So that was one issue. The other issue was to be pragmatic. Can we truly recruit, randomize, and treat a patient within 3 days or a week or so? And in this country, I have to tell you, it's very difficult. It's very difficult to do sometimes. Logistically, it's difficult. And then you have other issues that relate to managed care issues. Somebody with an asymptomatic dissection who improves quickly, may be discharged by day 2, and it's difficult to maintain. So how do we include those patients in the trial? At the end, we decided on this range, just a happy medium, we thought. Not perfect in any way. We admit it's imperfect, but again, it was a compromise on how to make the trial pragmatic and how to have a trial that is feasible. At the end of the day, we do want to get the patients. If we limit the trial recruitment length too much, we're going to end up having no patients. The Earnest trial and the Sunday trial will have even a broader, I believe, I'm not certain, I can't speak for them, but I do believe they have even a broader range to recruit. So that's a great question. It's a difficult one to address. And we thought we came up just the happy medium of feasibility and scientifically appropriate study design.
Okay. Thank you, Dr. Panos. So just one more question, if you don't mind. So you started the recruitment in 2024, and we are expecting the results to be in 2030. And then you rightly said the follow-up time is the average follow-up time is 3.5 to 4 years. So if you have your majority of patients falling in the 3.5 to 4 year follow-up rather than 5 or 6 years, do you think that will affect the data?
Again, great question. It might. However, what we have tried to do statistically is to power the study for the mean follow-up of 3.5 years. And we will intend to do further follow-up outside the scope of the study for those that were enrolled late. It's always a risk, as you all know very well, when the endpoint is a long-term endpoint, unlike the 30-day or the 90-day that can collect data for everybody. It's very difficult to capture every single patient. And the issue also, again, in the United States is that the cost is just prohibitive. We cannot really design a study to last for 10 years or 12 years to get all the data we need on the last recruited subject. We do intend to do this likely with a sub-study that we can fund with a separate funding mechanism. So if somebody is enrolled in 2028, then we expect to get some data on them even for 5 years at least out. As you all know, again, very well, dissection is a lifelong disease. I believe I heard somebody mention twice in this talk. It's not once and done, and the surveillance is lifelong. And we do want to get data, not just imaging data, also clinical data to see how these patients improve, not again, with respect to the major outcomes, but also the quality of life. Can they go about what they need to do? So our goal is to follow in the long term. Again, pragmatically and within the study design constraints, we have tried to statistically power the study for the mean follow-up of 3.5 to 4 years.
Thank you.
One question I'd like to ask you. Are you going to categorize the patients who are in medical management who get converted into the TBAR group?
Again, great question, guys. Absolutely, by all means, absolutely. Again, we'll have to do the intention to treat analysis to be compliant with the science randomized trial. So we'll do intention to treat, but we'll also do the per protocol analysis to identify those who actually ended up having the early TVAR just because they developed the complications. So we will do a sub-analysis for those patients as well. And we do anticipate also the need for other sub-analyses according to high-risk features, according to the timing of the need for intervention. As you all know, somebody who comes in with an asymptomatic type B and develops a complication 1 week later is not the same patient with somebody who comes in with asymptomatic and develops a complication 6 months later. So we do get the sense that the timing of the need to convert is important. So we will have pre-specified analysis in that regard as well.
What's expected or likely crossover from the medical arm to TVAR on the follow-up? You must have calculated.
Yeah, we do anticipate at least about 15-20%. The question is also very pertinent. Crossover with respect to the need from the medical arm to have a TVAR, because there is a clinical need to have the TVAR. We won't classify this as a crossover. This is really standard of care. But we do anticipate about 20% of those patients from the medical arm to do require at some point a stent graft. The data, I believe, is within 6 months or so, about 20 to 30% of asymptomatic type B dissections will enlarge enough to justify a TVAR anyway. So along those lines, this is pretty much what the percentage is of the anticipated need for a TVAR. But again, we'll see. As you all know, all the numbers we have so far are from real world, and they they do include some bias. Being in a randomized trial setting and having more granular follow-up and very detailed prospective follow-up, we do believe will give us some better idea of what those numbers are finally going to be.
Is the TVAR procedure itself standardized? Would the repairs be zone 2, zone 3? And where would they end? Would they go down to the celiac artery? And how much would the oversizing be proximally, distally? Any standardization?
Great questions again from that group. We made the decision again after a lot of agony and a lot of conversations. We didn't make the decision to not standardize the procedure, to leave it up to the individual investigators. Again, to have a pragmatic trial. We will include up to zone 2. We do allow people to use any device they want. We don't have access in the United States of many branched devices for the arch, unfortunately. We'll only have access to the TBE, the subclavian branch. But we do allow them to cover as much as they want proximally within the IFU of the device, and to cover as much as they want distally using either petticoat technique or a covered stent graft technique or whatever that they want to use. So we give significant freedom, again, trying to balance the need for scientific accuracy and being pragmatists, trying to be all-inclusive and have the appropriate number of patients recruited.
Thank you. Thank you, Panos. I think it's a great trial and will answer a lot of questions which are there in all our minds about how to deal with TBAD. So all the best for your trial and look forward to seeing you sometime soon. Thank you so much. Have a great day.
Thank you. It was a true privilege. Thank you.
So before we go on to the next talk, which will again be on the same Improve AD trial by the principal investigator, Firas Musa, we will have some presentations by the industry. Since it's a sort of continuous session with no breaks, we thought we'll ask the industry to come and talk to you about what products they have. Please come. Abbott is not talking. Come. And while they prepare the talks, we plan to finish before 7, and drinks and dinner will be at 7:30 on the rooftop.
So very good evening. First of all, at the outset, a big thanks to Sir and the organizer for the Aortic Conclave. It's a very novel meeting, Sir. Thanks so much for the opportunity to be associated with this meeting. I'll quickly take you through some of the LifeTech products here. LifeTech, established in 1999, and the company is listed in Hong Kong. We have 2 factories, one in Shenzhen and one in Europe. And the products are countries and across regions with 33 plus innovative products and 14 product series. Now, one thing what makes slightly different LifeTech would be the number of innovations and the new products which are coming in. And in India also, if you look at LifeTech Scientific has been established back in 2008. Currently, we hold a #1 position for the occluders structural heart occluders, and the graft as number 2 position in India. Probably like, this is what it makes a difference to us. Like now, it's the only MNC who can say that like an Indian physician design product is now available across the globe. It's known as like Konar MF. And I should take the person's name because it's basically from Hyderabad, Dr. Nageshwar Reddy. So that's why the name is Konati Nageshwar. And Konar MF, it's a multifunctional occluder. And he already has around 6 to 7 patency from different countries. Last month, we got the US patency also. So that gives us a very proud moment for India. One Indian design, like no doctor design product is available across the globe. So this is something like what makes LifeTech slightly different, I'll say, because a lot of innovative products are coming. This is our like thoracic as well as the abdominal aortic aneurysm stent grafts. I'm not going to take time on this. So probably like what LifeTech stands for is like as a therapy partner and more as an academic partner. We've been ever since like we were on board like last 5 years, we've been involved in a lot of therapy development program, including the refined course. Thanks to Rochan sir here, like he has been like guiding us, like and Girish sir, like on many of these courses, he has been guiding us. And thank you once again for involving us in the Aortic AI 360-degree meeting, which was recently held in the month of May. So we do a lot of these programs. This is what probably like you can count on us to associate with. And one thing is that like LifeTech is slowly getting into as endovascular segment as a significant player because we are there with many new additions like the custom-made graft, G-branch, iliac bifurcation, FET grafts, concave supra-arch grafts, etc. I'll just come to this. This is the thoraco-abdominal. I don't want to like spend time on this one. We also have the silver flow here. So the G branch, we already did a couple of cases in India. These are the different cases done across the globe. And next one like to come in is the concave supra-arch branch stent graft system. The very unique design. And this product was also immediately approved for the innovative design, especially like the groove design maintaining the continuous cerebral perfusion during the procedure. And this is some of the cases which was done internationally for the concave. And the next one will probably come in is the Ancora chimney stent graft. Aortic stent graft with a longitudinal aortic branch stent graft system. Now, what again, like you can look at some of the innovation here. There is a double skirt here for the extension, the branch stent graft system, which really helps in two things. The outermost layer has got a very less radial strength, so the compressive deformation is allowed in that. So that will prevent the endovascular leak. And if you compare with the other one, like the Viban or like now Fluency, this is how the final shape looks like. With this unique design, the inner skirt actually gives a very high radial strength. That's my last 2 slides. Uranus is the next generation of the abdominal aortic stent graft, which is going to come in. Again, the profile is now reduced to 18 French, and 2 to 4 piece system will arrange covering of a big range. There are a couple of products, Fustar deflection sheath for 180-degree deflection, it helps. IVC filter and snare, and the new production, the other one in the market is the Zoom track, is a super stiff wire. And so if you can look at now, currently we have, very soon we'll be having the complete range of products for the entire range of endovascular. Right.
Do you have?
Thank you so much for the time.
Do you have cerebral protection devices?
No, sir, not yet. Right.
Questioning outside at the booth. Thank you.
Thank you, sir. Thank you so much for the time.
RTV? Yeah, come Arun.
I can do from here, right? Yeah,
Good evening, everybody. This is Arun here from Artivion. The Artivion is recently launched in India about 3 months back. So Artivion is a full form, if you can see the Aortic innovation vision. So Artivion as a company is only solely into the Aortic solutions, not beyond aorta or into digital aorta. So it's pertaining to the Aortic solutions. We have right from the root till the iliacs. So both into the investor space and the surgical space. So when I talk about endovascular, we have a AAA with the IBD, we have a T-triple solutions with the crystal solutions as well, and branch graft for the aortic solutions. So when it comes to the surgical graft, the conduits with the again, background graft, solutions. So this is solutions what we have as on today is a very available off the shelf solution, which is the E inside triple, which has the 15 branches, which comes with each branch has a 2 centimeter ceiling rim, and the center has got a 8. This is a 6 branch. So when it comes to the custom solution, can construct 16 abdomen. So is that analytical we can configurations like inner branch, outer branch, semi branch, scalloping, 10-7. So these are small video I'm just going to play. So this is the on the shelf device. So these all pre-cannulated inner branches. So there are the 4 hubs in the distal end of the delivery system. So this is the wire which goes. Once it's become a rolling pathway, then we can cannulate each individual vessel, target vessel. So it doesn't need a more required any appropriate required precise placement of the stent graft. So all one constant for this that if it is out as yeah. So then it comes to IPD. This is a system what we have. So it's again comes with a so on that we have is also isolated. So we have a different configurations on that right from 14, 16, 18 and all that. So these are delivery system which ensures the precise deployment. And then comes the frozen elephant trunk. So we have the images of frozen elephant trunk in way back 1982. Then it's got so this is self-expanding. Some conduits you can expand on the chunks. When it comes to the vascular graft, fully we have surgical solutions.
Cook Medical.
So good evening, everyone. So I am Ajay Kumar from Cook Medical. So briefly, I am going to take you through like for intervention products, we are in almost last 50 years in the market. So here I am going to our endovascular portfolio exclusively. So what additional we have, we are going to talk about. So we are the one having lowest profile device, that is the alpha device in the market. So this is one of the thing. Apart from that, we are only who is offering two-piece modular device. So that is basically for the better coverage, and technically also we are advanced as compared to others because we have proximal barbs with bare metal and we have distally also bare metal with the anchoring barbs. When we are talking about any aortic repair which is having the length more than 200 mm, then we are offering the distal component. So we are the only in the market, I think. So who is offering the distal component? Price wise also we are very competitive when we talk about as a whole two-piece device. So apart from that, we have dedicated dissection covered graft along with the combination of bare metal. So covered is for all the covering entry points. So we all learned from all of you and very thankful for that. So we also have the exclusive bare metal also with the combination of covered graft. So this is also, I think, only available with the Cook Medical. So apart from that, we also have this T-branch device. So this is also based on the demand we can bring, and on the patient license, we can also use it. So this is all how we are different from the other companies. So we have captured here. So thank you so much for giving us the platform to demonstrate. Thank you.
Thank you. Medtronic. Somebody's here from Medtronic? No. Okay, we can go to Thermo. Gore. Ah, go ahead.
This is not the slide.
Good evening, everybody. My name is Tejasvi. I head the clinical and commercial at Thermo. I'll skip the things. At Thermo Aortic, our motto is freedom to find the fit. So like every aorta is unique, we have solutions right from surgical, hybrid, endovascular, custom devices, and we have an in-between. For the physician modified, we have a trio fit. Just to give you a glimpse of our aortic solutions, right from surgical till endovascular custom devices, we have the entire thing as such. It is not like, each of these devices are tailored made according to the anatomies of aorta. So in this image, you will see all the devices. You will see our fenestrated anaconda. So we have two devices for the abdomen. We have the anaconda and trio. Then we have Thoroflex hybrid for frozen elephant trunk. We have the standard devices. We have the branch devices, both for thoracic as well as for the abdominal. And already our straight and bifurcated grafts are there for the surgical graft portfolio. So this is our right from the aortic root. We have the Valsalva graft. Then moving ahead, if we want to do a hemiarch, we have a single side branch with the straight graft, which is called our antiflow. Then we have the bifurcate graft. Then we have the trifurcate graft. Then if you want with the perfusion side port, we have the plexus. With the collar and the radiopaque markers, we have the Sienna graft if you want to do a classic elephant trunk. Then we have Thoraflex hybrid for the frozen elephant trunk. Then coming to our, just to give you a glimpse, this is our plexus and the Sienna graft for doing our classic and arch related anatomies. You can do a plexus without the collar, then Sienna graft with the collar, with the radiopaque markers, then you can extend it with the endovascular stent graft. This is for the cases where patients are not affordable across, and then, earlier they were doing Sienna graft and then extending with the endovascular stent graft. This is what I was talking about. Then we have the straight graft for the ascending aorta, where either Valsalva or straight graft can be used, but Valsalva has its own advantages. People are preferring for the David's procedure. Then we have the single side branch for the antiflow. Earlier, we had something called as a Lupier graft, which is still available, can be made available. This is a graft which can completely, you can bring another graft directly to the renals. This is the connection. We have Coselli thoracoabdominal graft for a complete open thoracoabdominal procedures. We have one more graft which is in the investigational device used in US, but right now not available in India, called as a thoracoflow, which is stented portion for the descending thoracic, and then you have the surgical portion for your celiac SME, and then we have the bifurcation graft for your common iliacs. This is our flagship product, Thoraflex Hybrid. You have two versions. You have the completely branch graft with the perfusion side port, and then you have the anti-flow version of Sienna Thoraflex is called. Coming to our endovascular portfolio, I can proudly say we are the only company which can have both the portfolios on the standard. Standard, we have the Relay Plus and the NBS. Relay Plus is with the barbs. Relay NBS with the non-barbs. Both these grafts are available in 100, 200, and 250 length. We have been launching Relay Pro, our low profile device, and then also we have our Relay branched devices for innominate and carotid. This is the complete portfolio. We have right from 100, 150, 200, and 250 in tapers and straight devices. Coming to the abdominal portfolio, we have Trio, which is the only graft which is both suprarenal as well as infrarenal fixation. It's a 3-piece device with a main body and 2 legs independently. We have Anaconda for angulated anatomies. Both these platforms are available on the custom devices across. You can choose, depending on the anatomies, you can go with the Trio platform or with the Anaconda platform. More than 70-degree angulation, we can choose Anaconda. 0 to 70 degrees, you can choose Trio. So this is the portfolio across. I'll just to give a glimpse of, I'll run you through a platform. This is important. Just this one. Just yeah, open. This is an in-between for the abdominal devices, what we call as Trio Fit. Once we receive the patient CT, we give a patient template. So with the template, we also give you a fenestration ring, suture, and the reloading tool. It comes complete kit across, which we called as a Trio Fit standard system. You can open up your standard devices. You don't have to worry about how the anatomy changes across. Everything is AI managed. The software considers that anatomy will change after you put in your Lundercrest wire. So we give you the template and the reloading kit across, so that makes your life easier. So we plan to bring this in India. If there are any cases, please feel to send across to our team. We plan to bring this, the advantage with this is we plan to do this in a 4 or 5 day spectrum. So once we received, the CT, it goes to the engineers, put it into an IOTA software. Then then the plan will be shared across to you. Once you agree with the plan, then the template is manufactured, steriled, and then shipped it across. Already, we have done almost around 100 cases in US. We are awaiting for the agreement across FDA approvals, and then we plan to bring this in India. So these are just the glimpses. Once we receive the CT from the doctors, then we make a template according to. So as per the software, we make the templates. So we send you the design approval, according to the calculations. Once you agree onto it, it's 3D printed, pouched, and then steriled. So it is 4 or 5 days. If you can see, it is 4 or 5 days after receiving the CT from the doctors. So this is just a demonstration. We can do it on a fit across. Thank you for your time.
So Gore is making its re-entry back into India. Re-entry.
Good evening, everyone, and thank you for giving an opportunity with Dr. PC for giving us an opportunity to present ourselves here. Yeah, as Dr. Gupta mentioned, currently we are coming back in India after quite a decade, quite a long time. So just to improve life the patients. So myself, Kannan here, I'm the national sales leader for Gore Medical. So the history is something, like 65 years back, I think the Bill and the Beeb Corps had a dream of starting the Gore enterprise. And that's how the Gore has been established quite a long back. The first R&D developed product is the EPTFE material. I think that is one of the core strength of Gore. And after that, there was no seeing back. Like we started putting all our resources in the R&D, and this is a short video.
Abilities to improve life by discovering partnerships that develop into relationships so we can overcome life's obstacles together. We are compassionate. We seek to protect not only those we care for, but to improve the future for those we may never meet. We are dreamers, explorers, thinkers and tinkerers, creators and collaborators. Stretch our minds and suspend disbelief so that as soon as one dream is reached, it becomes a stepping stone to another. Because the uninhibited mind doesn't fit inside any sized box. In fact, it designs a whole new one. At Gore, freedom unlocks the human spirit, empowering those who are anything but ordinary to reimagine the truly extraordinary. We are in your hearts, in your souls, bouncing around 230,000 miles above, connecting dots across all 7 seas. We are cleaning the air in there. We help you see, hear, and feel chords A through G. We are where you expect us to be, where you need us to be, and in some places where, quite frankly, you'd never believe. There's no secret to our scientific method. Just mix together equal parts curiosity, creativity, and collaboration. From the new materials we gather and advancements we make, to the breathtaking, blood-pumping, inconceivable places it takes us, We are together, always pushing forward. That is our nature. This is our promise. Together, improving life.
Yeah, I think this is a very interesting thing. Core is not only present in the medical device, but also they are present in different diversified industry. The Core is also present in the space agency. They are also present in the aerospace and the life science, and they're also coming out with the IT sector as well in India. So there is a new developments happening across Core in the diversified fields. So Core believes on the material science, and they try to build up the advanced material capabilities based on the sound science and the fundamental understanding. So finally, what we try to achieve out of this is all about the patient care and providing a better solutions to improve the patient outcomes. Thank you very much for giving this opportunity once again. Thank you so much.
This one. Hello, everyone. Thanks for the wonderful opportunity. Thanks to IIT Conclave team and PC, sir. So we are Rupture Healthcare Private Limited. Myself, I'm Krishnamurthy Hariharan. I'm taking care of business and a clinical specialist in the South area. So as a Rupture Healthcare, we have a multiple portfolio, vascular, we have metal stent and cover stent and all. So our main focus is healing with precision, not only with a specific company or specific product. We heal the thing with the specific product and particular anatomy and particular devices. So since last 15 years, we are serving patients with good products. With supporting our doctors by suggesting reliable solution, not only selling the product, we are known for solution providers. So 15 years of trusted medical solutions, and we are one of the leading importing company in India. So I'm just going a little fast. It has some more slides. So this is our product portfolio. So we have a Bentley, where most of all the doctors already using it, and it's a very prominent product. So in Bentley, we have aortic and peripheral also. We have a endovascular graft, and we have a InnoSpring braided stent. We have a Brosmet peripheral balloons, high pressure and semi-compliant balloons. And we have neck spears, which is a new thing, new baby coming into the industry, Indian market. It's a resorbable powder-shaped gelatin microsphere for endovascular embolization. And coming soon with the Fold-X valve, it's called as TRIA. Initially, we are coming up with a mitral valve. It's a surgical mitral valve, world first polymer leaflet valve. And we are coming up with frozen necks, FET from JLL. So this is basically the covered stent indications for Bentley. And this is the Bentley portfolio. Actually, Bentley is the lowest profile, one of the lowest profile cover stent in the market, Indian market. And we have a good feedback from the customers also. And India, wherever the most of penetration cases are happening, the Bentley is getting used. And this is an indication for the Bentley aortic, mainly for coarctation, aortic coarctation. And this is the Bentley aortic portfolio. This main thing is, this is starting from 12 mm. This 12 mm will go through the 9 French sheath. And same 12 mm cover stent, it's already pre-mounted, pre-crimped, which we can expand up to 20 mm. So same like that, it's available up to 24 mm, which we can post dilate up to 30 mm. So this is a Serap case, just one case I kept it here. So it's an infrarenal total occlusion. So we did at Serap. Infrarenally, we deployed Bentley aortic stent. Through that, like a casing stent, we deployed 2 Bentley peripheral. This is a post-implantation image. It's got completely open. We are getting a very good results in the Serap procedure. So this is our low profile meta endovascular graft. This device, we have a bare metal stents and proximal non-bare metal stents also available, which is diameter start from 20 to 44 mm. And this we have 4 mm tapered, 6 mm tapered, 8 mm tapered, 10 mm tapered also. So this is a graft design, and it has a unique design actually. This each nitinol struts are not in the same length. So each have a different set so that it can take any orientation like anterior, posterior, or medial lateral. This stent doesn't have any spine, so that we don't need to more bother about the orientation, how we need to take it up into the arch, all these things. So that's one extra benefit into that. And particularly this graft length is available up to 240 mm. So mainly for type B dissection cases and all, it will be very useful. And also, as I already mentioned, it's 10 mm tapered graft. So AAA system, we have a 3-piece system, same diameter starting from 20 to 36. And this AAA system, it's starting from 14 French profile. So main body starting from the 16 French, limbs are available in 14 French. So next product, this InnoSpring. It's a braided stent, which is available from 4 mm to 8 mm. Interesting thing is, in this stent, we have added one more radio opaque wire also. So in the braided stent, the problem is the visibility since it's a nitinol based. So this one radio opaque wire will show the entire stent length. And in this one, we have added 2 more. It's a 8 pairs of nitinol, super flexible nitinol wave, so that we are trying to reduce the elongation. So braided stent, normally all the problem is the elongation. So we are getting a good feedback from the customers. So we reducing the length of the elongation also by increasing the 2 pairs of nitinol. So this is a previous case. This we done in Kerala and North India and all, and it's a fluxion position. Actually, this is not indicated in the popliteal artery, but due to some complication, they deployed in that popliteal artery also. But I just want to show that flexibility of the stent. So you can see that radio opaque wire, entire stent, you can see that radio opaque waving wires. So that entire stent, we can see it very clearly. This is our high pressure balloon. It's a Brosmet balloon. So we have starting from 2 mm to 10 mm. So we have all the lengths up to 150 mm lengths. It is available. This Nexpear, Next Biomedical. So brand name is Nexpear. Nexpear is a powder shaped gelatin microsphere for endovascular embolization, and it's a temporary embolization purpose. It composed of hydrophilic material and used to conduct arterial embolization with a contrast medium. So this, as all the physicians must be knowing, all this indications for uterine myoma and liver cancer and benign prostatic hyperplasia and bleeding control also. And same Nexpear, F also available. The concept is occlusion, dissolution, and right timing. This will remain for 4 hours. So complete recannulation within 2 to 8 hours, and efficacy, complete occlusion of the abnormal vessel, and effective pain reduction and degenerative arthritis. And we already, some samples are used in Cochin Aster Medicity. We got good feedback, but we are in the follow-up phase. So indication, osteoarthritis, sports elbow, frozen shoulder, and wrist joint pain. So thank you. So since 5GR, we are doing so many marketing activity, hands-on training, and so we are participating in all the IIT Conclave programs and all the activities. So we are trying to bring new technology, and whichever products are not available in India, also we are trying to bring to improve the technology and healthcare. So coming soon with off-the-shelf branched grafts. So these grafts yet to come. So thanks for the opportunity. Thank you so much.
So we move to the last talk of the day. So the speaker for this session is Dr. Firaz Musa. He's the principal investigator of the IMPROVE AD trial. Sir is a professor of vascular surgery at McGovern Medical School, Houston. And the lecture is going to be on NHLBI trials, the difference between industry studies and their relevance. Over to you, sir. So can you hear us?
I can hear you. I did send a
You're not getting audio from your side.
I can hear you.
Yeah, you're audible, sir. Please go ahead.
Okay. I sent my recorded.
Do you want us to play that?
Yes, if you don't mind, and I'll be on for questions. And I'm just about to start a case. I'm sorry, it said 8 o'clock.
Not a problem.
Houston
We understand.
time.
Fantastic. We'll just start we'll play the talk.
Yeah, yes. Thank you, Dr. Gupta.
Yeah.
It's a great honor for me to participate, and thank you so much for the invitation. So my hope is over the next 20 minutes is to highlight to you the difference between what a federally funded trial looks like and an industry funded study is made of, and how that's different. And this plays a role for us as vascular and cardiac surgeons in kind of approaching the evidence even moving forward. So without further ado, thank you again. These are my disclosures. Thank you to Professor Premchandra Gupta for the invitation. I'm at the BI for NHLBI IMPROVE AD trial. This is a common question I get asked by folks who want to do a study and a trial comparing two arms, and they think that they could actually get it funded from the NIH. And here's what I give them. First and foremost, for any study that is investigator initiated, this means it's not something that came to you from a company, a device manufacturer, or a pharma, or so on. This is something that you and colleagues would like to investigate. So the first initial thing that you got to ask yourself in the community is the following: do we have equipoise? Which meaning, do we have folks who agree that this needs to be studied, and those who disagree that this needs to be studied? It's really, you cannot all, we can't all agree or disagree. So here's a group of vascular surgeons agreeing to actually conduct a trial. This is how we surgeons, this is actually meant to be a funny joke, a funny slide, but it's not really a funny slide. It is meant to show you how we actually agree on things, and with that process, a lot get lost in trying to achieve the same thing, but we have a different understanding of what the same thing looks like. So, so the basic argument is saying this: if we take IMPROVE AD, and the main hypothesis for IMPROVE AD, as Dr. Kugias will show you, is for patients with aortic dissection can upfront TVAR anywhere between 2 days and 6 weeks or up to 6 weeks be superior to the current standard of care of medical therapy and intervention if they need it in terms of reducing mortality and major aortic complication. Is TVAR superior to current standard of care? If you poll the audience right now, and if all 100% agree that say TVAR is superior, even we don't have actual level 1 evidence, then we don't need a trial, and we cannot conduct a trial. If the audience is split between 60-40, 60 agree or disagree, and 50-50, or even 70-30, then we actually have 30% agreeing with 70 or 40% disagreeing with 70 or 40% disagreeing with 60. So there is patient could be treated 2 different ways, depending really on kind of a personal interpretation of data. So that's where equipoise is, when it could go either way. And we do need the evidence to generate, the evidence in order to have a conclusive way of treating a problem. So that's really what equipoise means, and that is really the basic ingredient of any NIH trial. So moving forward, now that you decide to actually, you have equipoise and you do need to conduct a trial. So this is how it's different between, based on funding. So industry versus federal. When in federal in the US is the US government. So this could be NIH, the National Institute of Health, or it could be the CORI, Patient Center Outcome Research Institute, or any federal and National Science Foundation, and so on. So industry, it could be randomized in 2 arms, very rare, more so in pharma, less in device manufacturers. So, for us as vascular surgeons, it's more, it's less common to see a randomized trial. More so that we see is these 2, non-randomized or a registry. Most trial device, what we call trial devices, is a registry of a single cohort of patients to show really efficacy and safety, meaning you've got to put this stent graft in 100 patients. It's a brand new tool, and it works for those patients, does not cause immediate complication, and over a year or 5 years, depending on really on the regulation of how long you need to follow up, then you get this device and this trial completed. No comparison arm and no intervention arm, no comparison arm period, essentially. So that is what's normally you see in most device trials that's been done in the US and the EU and probably all around the world, is a single registry for the patients that you demonstrate safety and efficacy. However, what we consider in the federally funded, like Improve AD trial, it is a strategy trial, meaning you're not testing the actual device if it's safe and effective. We already know that the device is safe and effective. We're testing whether device is needed. The actual, not only the device, whether actually the intervention is needed versus no intervention and continue on the standard of care. That is same thing with PCI for coronary intervention for, let's say, patients who has a myocardial infarction or a STEMI and non-STEMI. You randomize them into the classic, non-STEMI, you randomize them into medications and optimal medical therapy and close follow-up and stent if they need, if their symptoms get worse, as opposed to PCI at the first time they come in. And there's been studied, as I'm going to show you multiple times. That's a strategy trial, intervention versus no intervention. These are, and almost always it's a randomized trial. There are observational cohort studies, but that doesn't fall, and that falls under a different set of actual funding mechanisms and scrutiny from the study section and the NIH. So that is really the what I want you to take from this slide is industry is mostly a single-arm registry that is, you know, not in the traditional sense of a trial of comparing two arms. There is no comparison in industry. You can compare it to historical controls, but that's not really same as a federally funded randomized trial. So again, to get to within the federally funded studies, you have to abide by certain, not rules, but it's actually metrics to make sure that your application would be successful and your trial would be executed and demonstrate a benefit or no benefit. So there is no point of conducting a trial that is, I mean, in some occasions there is if of non-superiority, but you cannot conduct a trial that is underpowered, that's funded by the let's say the NIH. Will not get scored, will not get funded. You got to have to power to the primary endpoint. So the event rate of the primary endpoint should be frequent, the power should be high, and the relative risk reduction should be moderate to realistic, more importantly, realistic. So you cannot say, I'm going to do treatment A, and this will reduce mortality by 80% over treatment B, which is a standard of care, because I think treatment A is great. That's not how, that is not realistic. That is not seen usually in clinical trials. So you got to have to be moderate to very conservative. If it exceeds actually that's great. But you got to be very conservative when estimating all these things in funding. In industry, that does not really, again, there is no comparison arm. So that's really not in the equation for industry trials. So how to select an endpoint. So you say you want to go to you demonstrated equipoise, you actually selected the design that you want to get this funded. And this is, again, as an NIH study or, you know, something that is not industry. This is all you do this work. You and your colleagues do this work in order to be, and then submit this as a grant in order to be successful. So, you know, the selected endpoint has to be mostly clinical, something that you can actually see that is satisfy the regulatory. In the US is the FDA. It's something you can calculate and computable, reproducible. So it's not like something that, you know, happens only in this trial. Feasible, pragmatic, that is a big buzzword for making it simple. In other words, again, not unique as I said, not something which is reproducible, generalizable, same thing, saying the same thing, and peer and public and broad and a board acceptable. So meaning that it is really everybody who looks at it from all aspects or stakeholders are gonna agree. So outside the NIH, you got to say, okay, I've got to demonstrate efficacy. That's actually, okay, you're going to use a stent graft to treat malperfusion in a type B aortic section, complicated type B aortic section. You put a stent graft, it works, that's efficacy. It did not cause an immediate complication, and no complication within 30 days, and no complication within a year or 5 years. So it is safe. So if efficacy and safety, that's all you need to show in a single arm study. So that is, it's really what I'm trying to get at is the scrutiny and the personal agony, if you will, to come up with an endpoint is really much more scrutinized by your team, your team, and your colleagues, and the broader society and the broader community and the public, as opposed to industry picking up simple regulatory. In order to get a device approved, you got to show its efficacy and safety. Device approved. Thank you very much. You're not going to hear from industry again until, next device. So efficacy, it's again, efficacy endpoints. I'm going to touch base about single and multiple in here. So in order to show that is a clinical, let's say if you want to study a TVAR and you want to show that clinical events happen, there's mortality, paraplegia, stroke. These are events that happen if you kind of borderline between efficacy. Depends on really on what you're treating. Symptom pain. Are you going to relieve the pain in patients that come in? So that's efficacy. Measure of function. Did you get actually able to do something that we were not able? That's another measure of efficacy. A surrogate endpoint, however, which is commonly done in this disease that we're discussing, is this false lumen thrombosis, aortic remodeling. And I'm going to talk to you about this in 1 second, and because this is commonly discussed among surgeons. It's like I put a TVAR because I want to induce remodeling and cause false lumen thrombosis. So how much does that really impact the patient? So this is a surrogate endpoint. So surrogate endpoint or a marker is usually, as we have in aortic section, is a lab or an imaging measurement or a physical sign that's used by therapeutic trials, as we've had instead, for example, or adsorb, and a substitute for a clinical meaningful endpoint that's direct measure of how patient feel, function, surviving, expected predicted effect. So you use the false lumen thrombosis as a measure in your head. It's never been proven that actually it reduces the rate of aortic mortality by cutting the number of patients who rupture or develop an aortic thoracoabdominal aortic aneurysm. That is not really directly related, but it is kind of what a surrogate is indirectly related. It may or may not work. This will not be an acceptable primary endpoint, for instance, to the NIH. This will be acceptable as a secondary endpoint or an imaging study endpoint, but not as a clinical. Tell the patient, your dissection is still there, but I caused a false lumen thrombosis. But guess what? You can't tell the patient that their risk of rupture is completely gone, or risk of the abdominal aorta degenerating into an aneurysm is completely gone, and so on. So that's not been shown to be, but that's a surrogate endpoint that we always talk about in our meetings and in societies and so on. So in a trial on, these are the surrogate endpoint that I was mentioning, aortic remodeling, even aneurysmal degeneration of 55 millimeter. This is an imaging surrogate endpoint that you do not necessarily see on the patient. The patient doesn't come to you and tell you I have a 55 millimeter aorta. So definitely these are important, don't get me wrong, but they are not something that would be funded. And that is the topic that I'm discussing. How are they different between because simply all these imaging, genetic, and aneurysmal formation, false lumen thrombosis, and remodeling never really linked to mortality. So patient sees mortality, patient sees, quality of life, ability to go to the store, ability to attend his son or daughter's wedding, and so on. So these are the pitfalls. This may not be valid, and again, balancing risk benefits really unclear, and many times it's the magnitude that you need to change in false lumen thrombosis to reflect an actual clinical change. So this is really the difference. I'm gonna just touch base on really what the NIH funding, for instance, it's extremely difficult. It is very challenging. You can see that the rate is around 19%, is probably slightly lower nowadays with the current situation in the US. But however, I would like to believe that we are still a great nation to do research for that matter, and the leading research in the world is probably still done within the NIH, in my humble opinion, and a biased opinion probably. So this is how, for what it took me to get this trial funded. Started in 2012 and got funded in 2023. So this is more of a personal growth journey. A lot of false starts, a lot of my personal lack of knowledge, and then acquiring knowledge and getting the right people, the right team on the bus, and then eventually getting funded in 2023. So it's obviously a long, doesn't have to be that long in the US, but it could be long. So it takes a lot of nuance and a lot of detail into what needs to happen. And so just to wrap up and tell you how how the common sense versus actual evidence. These are the people, these are the cardiologists done studies on PCI versus medical therapy for stable heart disease. And you can see there's over 13,000 patients who have been randomized, on more than $300 million in funding on the one single topic. Be it, it's common. However, we have not really randomized a single patient on with aortic dissection, and let alone spend a single penny on aortic dissection. So this is really the time to get this study going. We're really fortunate to have it here in the US, and hopefully we can expand worldwide. Dr. Kugias will go over the details of the design. And again, thank you so much for having me as part of this meeting, and I really appreciate it. And I'm sorry I'm not there. Thank you so much.
Thank you, Firas. I think that was an eye-opener for us. And we can really appreciate your perseverance, taking 11 years to finally get the approval. And while we were reading the guidelines on aortic dissection, we realized that there's no level A evidence for anything. It's all level B and mostly level C. And we are really looking forward to completion of the trial and some level A evidence to actually tell us that, okay, what we are doing is right or what we've been doing is wrong. And we wish you all the best for the continuation and completion of this trial. Anyone has any questions to ask for us? He's got to go into surgery very soon. Well, thank you, Firas. I think
thank you.
I've understood, and all the best for the trial.
All right. Thank you so much. Look forward to seeing
day.
you hopefully in November. You too. Take care. Bye-bye.
Yeah.
Bye-bye.
Bye-bye. So that wraps up the academic session for today, as I promised at 7. So we'll meet after half an hour on rooftop for dinner. And I would suggest that people sleep early so that we are here at 8 to start in the morning so that we can finish by lunch and go home early. So see you.
when I was 15, 16, when I really started to play guitar, I definitely wanted to become a musician.